A very good morning to all the respected teachers and dear delegates. I, Dr. Devang Bharti, on behalf of the team Appec, welcome all of you to the 5th day of this academic extravaganza. A quick reminder before we start the day's session. All the queries from the delegates may be sent into the Zoom chat box and they will be addressed by the respective speakers. We will also be asking multiple choice questions between the sessions, so be ready to answer them again in the chat box. Now for the first session, I would like to welcome Dr. Lalita Chaudhary, Director Professor, ABVIMS and Dr. RML Hospital, New Delhi. Her area of special interest are critical care and pediatric anesthesia. I welcome you, ma'am, and I request you to kindly commence the session.
Yeah. And what is ASA? ASA is American Society of Anesthesiologists, and it includes ASA grading. And the speaker on this is Jyoti Sharma. So I invite Jyoti Sharma to talk on this ASA guideline.
Good morning, everyone. First of all, I would like to thank the organizers for giving me this opportunity. So today we are here to discuss a very important topic, that is ASA classification. So ASA classification means American Society of Anesthesiologists Physical Status Classification. It is a classification system that is used to define the relative risk prior to conscious sedation and surgical anesthesia. It was first developed by Meyer Seclad in 1941. That was the first attempt to quantify the risk associated with surgery and anesthesia. Since then, many revisions have been made in the classification system. Many other risk assessment tools are also available. However, it is the most widely used tool. It is easy to use and understand. However, it does not take into account any preoperative optimization of the patient, the planned surgery, or the level of postoperative care. It is subjective, and so it may lead to significant interoperator variability. It is an assessment tool that is based only on the patient's preoperative medical history. As we have already discussed, assigning a physical status classification level is a clinical decision and it is based on multiple factors. If it is initially determined at various times during the preoperative assessment of the patient. However, the final assessment of physical status classification should be made on day of anesthesia care by the anesthesiologist after evaluating the patient. The purpose is to assess and communicate a patient's pre-anesthesia medical comorbidities. The classification system alone does not predict the perioperative risk, but used with other factors, for example, the type of surgery, frailty, the level of deconditioning, it can be helpful in predicting perioperative risk. Now coming on to the classification per se. We have, in this classification, we have 6 classes. The first class is ASA1, which consists of a normal, healthy patient. For example, in adults, it is a healthy, non-smoking patient, no or minimal alcohol use, or in pediatrics, we take a healthy patient, no acute or chronic disease, normal BMI percentile for age. Next is ASA2, a patient with mild systemic disease. Now, mild disease is only without substantive functional limitations. For example, a current smoker, social alcoholic drinker, pregnancy, obesity, well-controlled diabetes or hypertension, or mild lung disease. In children, the patients having asymptomatic congenital cardiac disease, well-controlled dysrhythmias, asthma without exacerbation, well-controlled epilepsy, non-insulin dependent diabetes mellitus, abnormal BMI percentile for age, or mild or moderate OSA, oncologic state in remission, or autism with mild limitations. In obstetric patients, a normal pregnancy. Now, this has to be taken care of that a pregnancy is not a disease as such. But while classifying the patient in the ASA classification, we take a normal pregnancy in ASA2 and not in ASA1. Then controlled gestational hypertension, controlled preeclampsia without severe features, diet controlled gestational diabetes mellitus also come in ASA2. Next is ASA3, that is a patient with severe systemic disease, substantive functional limitations, one or more moderate to severe diseases are present. For example, in adults, poorly controlled diabetes or hypertension, COPD, morbid obesity, active hepatitis, alcohol dependence or abuse, implanted pacemaker, moderate reduction of ejection fraction, end-stage renal disease undergoing regularly scheduled dialysis, or a history of MI, CVA, TIA, or stents within the past more than 3 months. Then, in children, uncorrected stable congenital cardiac abnormalities. Another can be asthma with exacerbation, poorly controlled epilepsy, insulin-dependent diabetes mellitus, morbid obesity, malnutrition, severe OSA, oncologic state, renal failure, muscular dystrophy, cystic fibrosis, history of organ transplantation, brain or spinal cord malformation, symptomatic hydrocephalus, premature infant, PCA less than 60 weeks, autism with severe limitations, metabolic disease, difficult airway, long-term parenteral nutrition, or a full-term infant less than 6 weeks of age. In obstetrics, the patient can be preeclampsia with severe features, gestational diabetes with complications or high insulin requirements, or a thrombophilic disease requiring anticoagulation. So these are the examples of ASA3, that is a patient with severe systemic disease. So we should take care that these are only some examples, and this is not a complete list of the diseases which we take in ASA3. Then ASA4, a patient with severe systemic disease that is a constant threat to life. A few examples we'll see. Recent, that is less than 3 months of MI, CVA, transient ischemic attack, CAD or stents, ongoing cardiac ischemia or severe valve dysfunction, severe reduction of ejection fraction, shock, sepsis, DIC, end-stage renal disease, not undergoing regularly scheduled dialysis. Then in pediatrics, symptomatic congenital cardiac abnormality, congestive heart failure, active sequelae of prematurity, acute hypoxic ischemic encephalopathy, shock, sepsis, DIC, automated implantable cardiovascular defibrillator, ventilator dependence, endocrinopathy, severe trauma, severe respiratory disease, or advanced oncologic state. Then in OBS, preeclampsia with severe features complicated by HELP or other adverse event, peripartum cardiomyopathy with ejection fraction less than 40, uncorrected or decompensated heart disease, or acquired or congenital. So these are a few examples of ASA4 patients, that is a patient with severe systemic disease that is a constant threat to life. In ASA5, we take patients, a moribund patient who is not expected to survive without the operation. For example, a ruptured abdominal thoracic aneurysm, massive trauma, intracranial bleed with mass effect, ischemic bowel in the face of significant cardiac pathology, or multiple organ or systemic dysfunction. In children, we can take a case of massive trauma, intracranial hemorrhage with mass effect, patient requiring ECMO, respiratory failure or arrest, malignant hypertension, decompensated congestive heart failure, hepatic encephalopathy, ischemic bowel or multiple organ system dysfunction, or a case of uterine rupture in obstetric as an obstetric patient. So these are ASA 5 patients. That is a moribund patient who is not expected to survive without the operation. The last is ASA 6. ASA 6 includes a declared brain dead patient whose organs are being removed for donor purposes. So these are the 6 classes in ASA classification. Now we have another term, that is E. The E can be added to any of these classes. The addition of E denotes emergency surgery. So what is an emergency surgery? An emergency is defined as existing when delay in treatment of the patient would lead to significant increase in the threat to life or body part. So these were the classes. Now we'll have a short quiz. Let's see a few examples. We have a patient, a 20-year-old college athlete who is scheduled to undergo an elective ACL repair. Who is non-smoker, non-drinker, no medications, BMI is 23. So this patient would be assigned to. So you have a few seconds to think in your mind. So the answer is ASA physical status class 1. Next is a 55-year-old man scheduled for emergency repair of a ruptured abdominal aortic aneurysm. He is brought to the operating room with CPR in progress due to asystole. He had been intubated earlier in the emergency department without the need for any drugs. This patient would be assigned to. So this is a ASA physical status class 5E. Now one more question, that is a 20-year-old female, she is posted for elective cesarean section due to breech presentation. The pregnancy remained uneventful throughout. So this patient would be assigned to, this is ASA physical status class 2. So this has to be kept in mind that a normal pregnancy is ASA class 2 and not class 1. What is the most commonly asked question from this topic is basically the whole topic. What is American Society of Anesthesiologists classification and why is it used? So you have to learn the whole table, classify from 1 to 6 and also the addition of E. So all the best and thank you all for your patient hearing.
Lalita ma'am, would you like to conclude the session? Probably you're muted. I think Lalita ma'am is having some connection issues. Thank you, Jyoti ma'am, for such a informative presentation about the new ASA physical status classification system. I certainly believe that delegates would be immensely benefited from your presentation, ma'am.
Thank you so much. Thank you for
I don't
giving
think
me
there is
this
any question.
opportunity.
I think
Yeah,
Lalita
actually-
ma'am is back online. No, she's not. Yes, ma'am. You were saying, Jyoti ma'am?
Yeah, basically this is a very important topic and obviously there is only a single table that has to be learned by the residents. So that is to be learned by heart basically. And there is no if and but like ऐसे है या वैसे है. It is like 1 is 1 and 2 is 2. So
Lalita ma'am, please unmute yourself, ma'am. Yes. You're not audible, ma'am.
Can you hear me?
Yes, ma'am. Now we can, ma'am.
Dr. Devang, can you hear me?
Yes, ma'am. We can, ma'am. Please go ahead, ma'am.
Hello? Can you hear me?
Yes, ma'am. You're audible.
Okay. This classification includes extreme of age group. So I will tell you, it does not include extreme age group like neonates and the old age. Okay. And she has covered all the classes. So it was a nice presentation. Thank you, Dr. Jyoti Sharma. Thank you, Dr. Diwa.
Thank you, ma'am. Thank you so much. Now for the next session of the day, let me welcome Dr. Lakesh Anand, Professor Maharishi Markandeshwar Institute of Medical Sciences and Research, Maulana Ambala. His areas of special interest are airway management, resuscitation, critical care, and trauma anesthesia. He has conducted many workshops and has multiple publications in prestigious journals. I request you, sir, to kindly commence the session.
Hello, Devang, am I audible?
Yes, sir, you are audible,
Yeah.
sir.
So good morning, all. At the outset, I want to thank the RML Hospital and particularly the Madam Kaur for arranging this conference. So now I invite Dr. Abhishek Sharma. He is a consultant anesthesiology in Max Hospital, Saket, and Max Institute of Laparoscopy, Endoscopy, and Bariatric Surgery. His area of interest, anesthesia for OBs, airway management, and regional anesthesia. I invite Dr. Abhishek Sharma to continue with the what we are day to day using before even entering the theater. We must thought whether the things are available, and that is one laryngoscopy or video laryngoscopy. Dr. Abhishek Sharma.
Good morning, everybody. Respected Chairperson, I would like to first thank the Appec team for making me part of this program. We'll now discuss about laryngoscopes. A laryngoscope is an instrument which is used to examine the larynx and its surrounding structures, and also to facilitate the intubation of the trachea. A little regarding the history and development of the laryngoscopes. There is some evidence of awareness of respiratory anatomy and tracheal cannulation in ancient time, as some texts indicate. Andreas Vesalius, in his text on the fabric of human body, explains the cannulation of trachea in a dying animal and maintaining ventilation. In the next few centuries, there were reports of tracheal cannulation for rescuing drowning patients and also in diphtheria patients. Elective intubation was probably first reported by William McEwan in 1878. He practiced selective intubation for surgeries with limited success. Intubation was performed by awake, blind, digital, and also indirect laryngoscopic techniques during the 1800s. The need for laryngoscopic techniques probably being realized even more. Indirect laryngoscopy was also being developed with the use of speculums for observing oronasopharyngeal anatomy. Bosenius designed a licht lighter, which used an artificial light source within his scope, which is the first during that time. Garcia extensively studied the larynx, describing a technique of laryngoscopy and the physiology of larynx. This was preceded by the development of a glottoscope by Babington in 1829. Alfred Kirsten is credited with the first direct laryngoscopy. He named his device the otoscope, and which he modified out of an esophagoscope after reports of accidental tracheal intubations during a esophagoscopy. So he cut the lower half of the esophagoscope and he made a blade out of it. It also had a proximal light source. In his text, he described the removal of foreign bodies using his device. Now, some historical laryngoscopes of interest. In the early 1900s, Chevrolet Jackson designed a straight blade scope with a disc which had a distal bulb, and also described the Boyce-Jackson position, which is similar position to the sniffing position which is used today. Henry Harrington Janeway is considered the first anesthesiologist to develop a laryngoscope, which had batteries included in the handle, very similar to the current scopes. In 1920s and after the First World War, Sir Ivan McGill and Rob Botham popularized blind intubation techniques, nasotracheal intubation techniques, and later on designed his own laryngoscope, which had a straight blade. With the introduction of curare by Griffith and the introduction of muscle relaxation, hence, in early 1940s, laryngoscopic techniques picked pace. In 1941, Robert Arden Miller modified the straight blade, which had a smaller cross section and was much easier to use. In 1946, he introduced a pediatric laryngoscope, which had a much smaller design. Notice the hinged design in his blade in 1946. In 1943, Sir Robert Reynold Mackintosh introduced his revolutionary curved blade design based on the Boyle-Davis mouth gag with the help of his assistant Richard Salt. He emphasized that the tip of the blade should stop short of the epiglottis, and his design was patented by the Welsh Allen Company, which also designed the hook-on fitting or the foldable blade on the laryngoscope. Coming to the types of laryngoscopes, they can be classified as direct and indirect laryngoscope. Indirect laryngoscopes can be further classified as optical laryngoscopes, which use prisms and mirrors. The TUView and the ViewMax laryngoscope were the first to be introduced in this category. Rigid fiber optic scopes include Bullard, Wooscope, Optioscope, which have a blade design and a rigid fiber optic bundle included into the blade, and so-called stillets, which have a more of a fixed fiber optic design. The examples are the Shikhani optical stillet and the Bonfils optical endoscope. Video laryngoscopes have gained popularity in the last decade, and a video laryngoscope is now also a part of the standard ASA difficulty algorithm. Flexible intubation scopes include fiber optic scopes and ambioscopes. This has been taken as a separate lecture. Now, the blade consists of the laryngoscope consists of the handle and the blade, which is joined together by a hook-on fitting. Now, the handle provides the power source for the illumination system, and it connects and locks with the blade with a hook-on fitting, where the hinge pin locks with the hook of the blade. It provides the power source for the illumination, and the electrical contact on the handle connects with the same on the blade in certain systems. While in fiber-lit system, there is a blade present instead of a electrical contact, and there is also green marking on the handle in case of a fiber optic illumination system. The illumination system consists of bulb on blade or the bulb on handle, or also called the fiber optic or the fiber-lit systems. Now, there is no well-accepted light intensity, but the ISO 2009 recommendation recommends a minimum illumination of 500 lux. I could not get the latest recommendation from the ISO, but some texts mention that the ideal illumination should be 700 lux. For bulb on blade designs, in the locked position, the spring contact maintains firm connection between the bulb at the battery terminal and the electrical contact on the blade. In case of the bulb on blade designs or the fiber-lit, I'm continuing with the bulb on blade designs. From the electrical contact in the on the blade, there's an insulated wire which runs from the electrical contact on the blade to the bulb socket, where the bulb is placed, which can be screwed into the socket. Now, in case of the fiber-lit systems or the bulb on handle systems, in the locked or working position, there is an activator switch which depresses the bulb and makes contact with the battery terminal, as you can see in figure 1b. Now, from there on, the fiber there is a light conducting fiber which runs from the proximal end of the blade to the distal end of the blade, conducting light and providing light source on the blade. The fiber, the conducting fiber, light conducting fiber can be made of glass, which is traditionally called as fiber optic, or it can be made of plastic fibers also, if it is cheaper to produce. Now coming to the blade designs, this is a diagrammatic representation of the blade of the laryngoscope. Now let's see the parts of the blade of the laryngoscope. It consists of a tongue, which is the main shaft of the blade, and the flange, which is connected to by the web. The tongue ends in a rounded tip in case of curved blade designs, while in straight blades, the blade is straight for most of the part and the tip is slightly curved upwards. The bulb or the light source in case of fiberblade systems is present on the web, with the light, the illumination system running along the web of the blade. The base consists of a hook-on fitting and the electrical contact or the proximal end of the fiber optic bundle. The locks on the side fit with the corresponding slots on the handle. The end of the base is called the heel. Now the curved blade have a Z cross section because of the arrangement of the tongue and the flange, where the flange turns away from the blade. In case of the straight blades, the cross section is a compressed C cross section, where the blade where the flange turns towards the blade. The height of the cross section is called the step. Now the function of the tongue or spatula is to compress the tongue and the soft tissue into the mandibular space. The tip is rounded in curved blades and rests in the vallecula, indirectly lifting the epiglottis by applying force to the hypoepiglottic ligament. In case of straight blades, the blade lies posteriorly and picks up or includes the epiglottis, directly lifting it. So this is the difference between the two blade tip designs. The flange projects from the tongue on the other side, as we saw in the picture, and it deflects the soft tissue to one side away from the line of sight and directs the instrumentation. The electrical connection or the fiber optic bundle travels along the web of the web to illuminate the larynx. In some cases, some straight blades, the bulb may be located on the tongue. So during use, the flange lies below the upper dentation during use, and it is important not to hinge the flange against the upper dentation, as it can cause damage. Now the base attaches to the handle, and it has with a hook-on fitting, and it has electrical contact or the end of the fiber optic bundle. It has locks on the side which engage with corresponding slots on the handle. The base may have markings for the type, size, name of the blade, and a green marking for the fiber optic system. These are the just to summarize the difference between the two blades. So the displacement volume is larger in a curved blade compared to a Miller blade, and it is preferred in adults and is also less likely to cause dental damage because of the curved design. It is preferred in children and with patients with long floppy epiglottis, and also in patients with prominent teeth. Now these are the ISO markings for the various blade sizes from 000 for small premature infants and 5 for the extra large adult. On the right side, there is a suggested blade size for use in pediatric patients. Now, these are the approximate length of the blades according to the size of the blade. Now, you notice that the Miller blade has a slightly longer size for the corresponding blade length, for the corresponding size of the blade. And generally, most commonly, these are the sizes which are available. However, 0 and 5 size is also available in the Macintosh. Now, coming to the types. The types of the handles vary according to the use, and generally the slimmer or the penlight handles are used with smaller blades or in pediatric patients, and short handles are preferred in obese patients or where the handle comes in contact with the chest. There are various battery sizes which are there according to the type of the handle. They commonly used a large handle accommodates 2D size batteries. Now, another handle is the Patel Syracuse handle, which was developed by Dr. Vijay Lakshmi Patel in Syracuse, New York in 1984. And the advantage is that it can be positioned in 4 different angles. The blade can be positioned in 4 different angles in relation to the handle. It has a blade lock with which it can be positioned. And it was initially described to be used when the handle impinges on the chest, wherein the blade is introduced in the position number 1, almost parallel to the blade. And once the blade has been introduced, the angle is then changed to 135 or 90 degrees, and then laryngoscopy is performed. However, you can initially use the handles in a fixed angle also. Holland lock is a type of an adapter which gives a fixed 45-degree angle with the blade, with the handle and between the handle and the blade. Another another adapter which had various angulations was published by Dhara, SS Dhara et al. And it has a hinge pin, a push rod pin to change the various positions. It had a range of angles which were available, and it can be attached to the conventional laryngoscope handle. Now, these are the indications where, in general, where these wider angles can be used. Different angles can be used. In general, angles wider than 90 degrees is used where the handle impinges on the chest or any obstruction at the level of the neck. Like in fixed flexion deformities, or in obesity, or in large chests or breast hypertrophy, or where the cervical spine movement is undesirable, or while applying cricoid pressure where the handle might touch the hand of the provider providing the cricoid pressure. In angles narrower than 90 degrees is used where we have to pry open the mandible or the lower jaw to lift, like in receding mandible or an anterior larynx. Now, the left-handed Macintosh blade is useful for left-handed intubators, and it is also useful in individuals with limited left arm use. Also, in patients who have to be intubated in right lateral position, the left-hand Macintosh is useful. Now, it has a reverse. It has a Z cross section compared to a reverse Z cross section in a standard blade. The polio blade is positioned at 135 degrees to the handle, and again it was designed initially for use in polio patients who had body jackets, so that standard laryngoscope blades handles would come in contact with the iron lung. So the polio blade was designed to facilitate intubation in these patients. And one disadvantage of broader angles is that there is limited control of the blade and limited force can be applied. The English Macintosh design was a modification of the standard Macintosh, which is also called as the American design. And it has a very smaller step, as you can see, and a lower profile, which makes the introduction of the blade easier and provides a better glottic view and less dental trauma. These are the common designs which are used, modifications which are used today. A modified English type has a reduced flange, and it decreases the pressure on the maxillary incisors and also reduces the damage to the incisors. Another low profile blade is the Upshur low profile blade, which has a much lesser curvature and also much reduced height of the flange, and it is useful in patients with limited mouth opening. The Bizarre Giuffrida blade is another low profile blade where the entire flange is done away with, and there's a small flange present for the placement of the bulb, and it minimizes the danger of damage to the teeth. It's useful in patients with limited mouth opening, prominent buck teeth, and the anterior larynx. Now, the Fink blade was developed by Bernard Raymond Fink, who is famous for the Fink effect. Now, in this blade, the tongue is wider, and there is an additional angle present towards the distal end. It has a smaller flange height and is available in an adult size. The improved vision or the IV Macintosh has a concaved blade laterally, and it provides a better view compared to the standard laryngoscope blade, as the line of sight passes more through the blade, through the concaved out portion of the blade, reducing the blind area. Another way to improve the vision is by flexible tip blades. The most common blade which is available is the McCoy blade, which has a 70-degree tiltable, upwards tiltable handle, which is tilted by depressing the lever of the laryngoscope. It is flexible tip blades are also available in straight blades, but most commonly we see it in a curved blade design, which is called the McCoy. So it improves glottic view and the likelihood of successful intubation by elevating the epiglottis, and is also useful in patients with limited neck movement. Now, coming to the straight blades. Now, straight blade designs were modified according to the varying cross section of the straight blades. Now, the larger the flange or the larger the cross section, the larger the displacement volumes and easier tube delivery. However, it makes the introduction of the blade difficult into the oral cavity. This is called the straight blade paradox. Now let's see each of these blades, and with successively increasing cross section. So first is the Cranwall blade. It has a very reduced flange and almost like an arc type cross section, and it has a decreased risk of damage to upper dentation. Now, because of the minimal cross section, it can be used for providers can, with limited use of the left arm, can use this blade also. The Phillips blade has a slightly more curved cross section or larger cross section compared to the Cranwall blade, and its flange is slightly larger than the Miller blade, as you can see in this picture. Now it combines the shaft of the Jackson direct laryngoscope that we saw was introduced in the early 1900s, and it includes the curved tip design of the Miller blade. The Wisconsin blade has a larger design, almost a C-shaped cross section, complete C-shaped cross section compared to the Miller blade. It doesn't have a curved tip, and the flange or the cross section widens out towards the distal end. That's the characteristic feature of this blade. Now, this blade was discontinued from its use, but the Vis-Hippel modification continued to be used for pediatric patients. Now, the Whitehead modification has a reduced flange, and generally it's more open, both proximally and distally. The Vis-Hippel design has a flat tip, and the flange runs almost parallel to the tongue, and it is useful in infants and pediatric patients. The Vis-Forager blade has the flange expands slightly outwards, and the tip, the distal end of the blade, is slightly curved or rotated to the right. The Snow blade is a combination of the Vis-Forager blade that we saw, which had a complete C cross section, and the tip design is like a Miller blade with a curved upward design, which the curve starts about 1 inch from the tip. Now, coming to the angled blades. Now, the Goodell blade is one such blade which has an angled fitting, as you can see here, and it makes a 72-degree angle with the handle, giving an acute angled introduction. It has a U-shaped cross section, tilted U-shaped cross section on the side. Another modification of this blade is the Bennett blade, in which the distal part of the flange is omitted. Albert's and Michael's blade are again angled fitting blades, which the only difference being that between the two blades is the angle of the fitting, 67 degrees in the Albert's blade, while it's 93 degrees in the Michael's blade. And both of them are used for pediatric patients. They both these blades also have a minimal cross section. Now these are the pediatric blades. The Robert Shaw, both of these blades have a straight blade design, and the rounded tip here rests in the vallicula and lifts the epiglottis. And it is used for neonates in children and also used for nasotracheal intubation, as it allows a binocular vision because of the flange being pushed more laterally in this design, as you can see in this cross section. Oxford or the Bryce Smith infant blade was introduced, and it was quite popularly used in patients with cleft palate. Now it has again a curved cross section, almost a U-shaped cross section it has, and the flange here tapers off distally to provide better view, and it can be used to lift the epiglottis directly or indirectly. Now coming to blades, pediatric blades with designs of both features of both Macintosh and straight blades. The Sober blade here has a reverse Z cross section, which we see in the Macintosh blade, but it is a straight blade, and it is again used in neonates and infants. The Seaward blade again has both the curved and the design of a Macintosh blade with the reverse Z cross section. And it also allows for nasotracheal intubation because it has the cross section is very small. The Z-shaped cross section is very small, and it is used for children under 5 years of age. Now this blade also has a rounded tip, which is supposed to rest in the vallicula. However, depending on size, you can even lift the epiglottis. Can be used anyways. Coming to the blade's specific function, the Tull suction blades have a suction port, and where the suction can be connected to one end, and it can be controlled with a finger on the through the other opening. The oxyport blades have a provision for connection of oxygen and to provide oxygenation during laryngoscopy. Disposable laryngoscopes blade are also available. You can either have blades. Disposable blade which can fit on standard non-disposable handles, or you can even get a complete disposable laryngoscope. MRI compatible laryngoscopes are also available, which have an aluminium body structure and gold plating on some parts of the blades. It has a dry carbon zinc battery. The other blade types are the Dodge's universal blade. I've just listed a few of them which I have not discussed here. There are many such blade designs. Another design which fits onto the laryngoscope blade is the Huffman prism. Now this prism fits onto the blade of the laryngoscope, and it improves the view by refraction of the light, providing a anteriorly refracted view.
Abhishek, I think you
now coming to indirect rigid laryngoscopy. These are the indications of indirect laryngoscopy wherever there's in case of difficult intubations, or where the direct laryngoscopy technique has failed, or in patients with unstable cervical spine who require minimal cervical movement. In any case of distorted upper way anatomy or unsure airway anatomy, or any kind of obstruction in the airway, generally the indirect scopy is contraindicated. Coming to the first of the scopes which were introduced as indirect scopes, an example is the true view optical laryngoscope. Now this is an optical laryngoscope which has a prism and lens system in the optical view tube, which is present in this laryngoscope, and it provides a 42-degree angle deflection from here by anterior reflection of the light. It provides an unmagnified view via a 15 mm eyepiece over here. And in later designs, there was a video camera, still camera, which was introduced, And also a camera head can be included, attached to the eyepiece, and a 2-view PCD laryngoscope is also available, which makes it a video laryngoscope. Coming to the Bullard laryngoscope, it is a fixed fiber optic device, and it is available in 3 sizes: the adult, pediatric, and pediatric long. Now, it consists of a curved blade design over here and a fixed rigid fiber optic bundle, which lies posterior to the blade, and it opens under the blade, which has the fiber optic bundle opening over here, which consists of the light and a port, a hollow port for suction or oxygen administration, and the camera. The fiber optic light source is present on the anterior side, and a standard battery handle provides power to the light source over here. It has a contoured stillet according to the blade design, and the endotracheal tube is placed on the stillet after lubricating it, and it is introduced in the midline, and once in place, the larynx is visualized through the eyepiece. Now, a multiple function stillet is also available, which has a hollow core, and you can pass a pediatric fibroscope or a tracheal tube exchanger through that. Coming to the Bonfils intubating scope, which this is again a rigid fiber optic scope, which is about 40 centimeter long, and it has a distal anterior angulation of 40 degrees. It can accommodate adult ETT of 5.5. 2 pediatric versions of the scope are also available. Now, coming to laryngoscopy, laryngoscopy involves first an airway assessment. I've listed down some predictors of difficult airway. Arrangement of proper functioning airway equipments, a skilled assistance, suction, oxygen monitors, and a proper position. Positioning the patient involves putting the patient in a stiffing position, and by cervical or neck flexion, which is achieved by placing a 10 centimeter pillow below the head, providing about a 35 centimeter neck flexion, which brings the laryngeal and pharyngeal axis into line. Next, head extension of about 80 degrees makes the oropharyngeal, laryngeal axis, all 3 axes in one line. In case of obese individual, ramped position is preferred, and one way of endpoint of achieving the position is matching the external auditory meatus and the sternal notch in the same horizontal line. Now, for children, large occiput causes flexion of the head and neck, and of the head and neck. Therefore, a small pillow or a pad is placed on the shoulders to achieve the same position. In older children, neutral position may be sufficient. Now, the mouth is opened by a scissoring technique, and for the Macintosh, another way of opening the mouth opening is placing the palm on the forehead and opening the lower jaw with your index or your third finger. It is important that in such a situation, the heel should be avoided to be placed on the eye, which may cause damage to the eye. Now, in case of Macintosh, the blade is inserted on the right side of the mouth and swept on the other side. And during this maneuver, it is important to avoid lip impingement between the blade and the upper dentition. Once the blade is advanced, the tip is positioned in the vallicula, and a force is oriented about at a 45-degree angle up and away. In case of Miller blade, a paraglossal technique is used, similar to the technique used in esophagoscopy, where the blade is inserted along the paraglossal gutter and passed over the posterior surface of the epiglottis, and again lifting it with a 45-degree angle. A guide to this angle is positioning the tip of your handle to the place where the roof and the wall meet in the corner. These are the various laryngoscopic views. This is a standard laryngoscopic view that we observe, and the Cormack-Lehan grade can be graded from 1 to 4. Generally, intubation is easier in 1 and 2A. In 2B, only the posterior part of the arytenoids are visible, and in grade 4, no structure is visualized. Another way of determining the laryngoscopy view is a POGO score, which is in which we identify the percentage of glottic opening, or how much of the larynx of the vocal cord is visible. So the total length should be from the anterior commissure to the arytenoids. Now, based on how much is visible between the two, the percentage is approximated. Now, if you do not have a proper view, then there are measures like the Burp maneuver which is given over the thyroid cartilage, or the optimal external laryngeal manipulation, which is given by the laryngoscopist on the hand of the assistant on the larynx to optimize the view. Again, for nasotracheal intubation, it should be made sure that nostrils are patent, and a nasal mucosal vasoconstrictor should be used. ETT should be lubricated with and introduced with a bevel facing away from the midline, just like similar to the way you put a Gudel's airway, and then twisted forwards once we move ahead from the nasal cavity. Now, once their laryngoscopy is performed, once the tube enters the pharyngeal cavity and guided with a Magel's forceps into the laryngeal inlet. Once we have placed the ETT either by oral or nasopharyngeal technique, direct visual confirmation, auscultation, and detection of carbon dioxide confirm the placement of the tube. Now, these are some complications related to laryngoscopy. From minor trauma to major perforation of laryngeal structures, which is rare. Cardiovascular complications, the most common is tachycardia, hypertension due to sympathetic stimulation. There can be some complications due to laryngoscopy, while performing laryngoscopies, laryngospasm due to the inadequate depth of anesthesia. And if esophageal, if it remains undetected, esophageal intubation can also happen. Now, coming to video laryngoscopy.
Abhishek,
now, video laryngoscopy
Abhishek,
is a method of indirect
hello, Abhishek.
laryngoscopy, and it utilizes the video camera technology, where the laryngeal structures are visualized on a monitor on a display. Now, this technique has come into popularity because of the miniaturization of the chip design. Now, these are the advantages of video laryngoscopy. It offers a magnified view of the laryngeal structures, and a direct line of sight is not required. So wherever direct laryngoscopy is difficult or has failed, video laryngoscopy can be used. Other advantages include it causes less cervical spine movement and possibly less hemodynamic stress. Also, it can be used as a teaching tool. The disadvantages are that in many cases, in spite of a good glottic view, the passage of the endotracheal tube is often difficult, sometimes difficult, not often, and sometimes a stillet is needed. According to the design, there can be fogging or secretion which may obscure the view. And although there is a short learning curve, but it may require some amount of experience before using a laryngoscope. Now, let's come to the technology used in the laryngoscope. It consists of a camera which is placed on the tip of the blade, and along with a light source at the end of the blade. Now, the camera consists of photodetectors or sensors. The CMOS sensor, or the complementary metal oxide semiconductor sensors, are the most commonly used, and they capture the light on the chip, where these the device converts this light which is falling on the chip to electrical signals, which converts it into transmits it to the display, and the display converts electrical signals to the image. So this is the basic technology which is available in the video laryngoscope. Now you can classify the video laryngoscopes as 3 blade designs: the standard Macintosh blade designs, the curved or highly distally or distal angulated blades, or blades with a ETT guided channel. This is the general classification. You can I have put the reference down there. You can table which is summarizes all the classification. Now coming to the McGrath Mac, which is based on the video standard Macintosh blade, and it is a non-channel blade, is available in various sizes, and it has a monitor which is attached to the handle itself. These are the various parts. The battery is integrated into the handle, and there's a disposable blade of various sizes which is available, which is put on the camera stick, which contains the camera and the light source over here. Now the advantages include that it is extremely compact and lightweight and robust, and the use is very similar to the Macintosh blade, so it has a very short learning curve. And however, there are some disadvantages, like the battery is non-rechargeable and lasts about 250 minutes, and you have to replace the battery which is supplied by the laryngoscope manufacturer. There is no image capture recording available in this scope. The CMAC D-blade design is based on a highly elliptical tapered blade, which offers an 80-degree angled view. And it has a single reusable blade. It doesn't have a ETT channel. And this blade, the blade insertion is along the midline, which is different from the standard Macintosh use. It's based on the Dodge's blade, and it comes with a large 7-inch TFT display. This is the electronic module which slides into the handle, and this is the assembled blade. The other end is the cable is connected to the monitor, which can be fixed to the pole or kept in a safe bag for transportation. Now the blade also has a channel for suction or administration of oxygen on the left side of the flange, or located on the web of the blade. The handle has buttons for image and video capture, which is located on the handle as well as on the monitor, and it can be easily operated while using the blade. It has a memory to store the images. It uses an SD card of up to 2 GB for storing the images and the videos. Now, this blade significantly improves the glottic view and requires much less extension. The handle also, although seems bulky, but it is lightweight, and there is also an active warming to prevent fogging in this device. It has a rechargeable battery and a reusable blade. However, the blade insertion, because the blade is bulky, it sometimes may be difficult in patients, in obese patients or patients with large chests, and it may require stiletto or a puji, especially during the early learning curve of using this laryngoscopes. So Pentax airway scopes again has a guided airway channel, and it's anatomically shaped. It's available in disposable blades in 4 sizes, and it uses a Miller type approach, midline approach, and it lifts the epiglottis, just like a straight braid technique. It has an integrated display on the handle and a small TFT inch display. Now, the blade consists of 3 channels over here. In the first channel, we insert the camera cord from the handle, and the middle blade has a provision for suction of the oral cavity or to administer oxygen or drugs, or local anesthetic can also be instilled into it if needed. And for intubation, there is a guided channel which incorporates maximum ETT of 8 endotracheal size of 8.5 mm in the standard blade size. The thinner blade size is also available. Now, this is a fully assembled scope which is here. This camera cord attaches and goes into the leftmost channel, while the endotracheal tube, as you can see, has been placed in the ETT channel present on the right side. On view, there is a digital marker for intubation to guide the endotracheal tube, and it has slots, the compartment here for reusable standard AA size batteries. The advantage is that it is portable and robust, and it easily accepts two AA size batteries. And but the handle is bulky, and again, no image capture or video capture is available over here. You have to connect it to external display in order to record image or videos. Coming to the last part, the decontamination of laryngoscopes. Laryngoscopes classified as semi-critical medical equipment by the according to the CDC guidelines, and they require cleaning and high-level disinfection. Sterilization is ideal but not mandatory for laryngoscopes. Now, these are some of the definitions of cleaning, high-level disinfection, and sterilization. So the difference between sterilization and high-level disinfection is that in sterilization, all bacterial microbial forms, including bacterial spores, are destroyed. Now, before cleaning, the provider should wear disposable and protective equipment and first discard all the disposable blades if present, and dismantle the laryngoscope. And if the battery is reusable, or if it's not waterproof, it should be removed. And for video laryngoscope, you should follow the guidelines of the manufacturer for various parts of the laryngoscope to be cleaned. Again, decontamination should be done in a dedicated area for cleaning the instruments. Now, the handle should be can be cleaned with water and detergent, and the blades should be rinsed and soaked in enzymatic and detergent solutions and washed thoroughly, especially on the bulb sockets. It's important that the water temperature should not be too high. It should be less than 45 degrees to prevent formation of protective proteinaceous film, which can prevent disinfection. And avoid soaking the saline in high chlorine content, that is water, and also in sodium hypochlorite, as it may corrode the metal. Now, for disinfection, remove the batteries from the handle before sterilization. And handle can be disinfected or sterilized by steam, plasma, or ethylene oxide. For blade, remove the bulb for bulb on handle systems, for bulb on blade systems for sterilization. And it can be disinfected or sterilized using steam or plasma, that is hydrogen peroxide, glass plasma, and ethylene oxide, or chemical disinfection. Chemical disinfection, two main chemicals are used, glyceraldehyde and alcohol. And for glyceraldehyde, the contact time is about 30 minutes of 1 to 1.5%. And but it requires activation, and it produces irritant fumes. So the glyceraldehyde chamber should not be left open, as it can cause damage to the user. Another alternative is the orthophtaldehyde, which can be used in place of glyceraldehyde. Alcohol provides only intermittent to low level disinfection. It's active against most viruses except hydrophilic viruses. If you're wiping with alcohol, it only provides a low level disinfection. For disinfecting or sterilization, you have to immerse the instrument into the chemical for disinfection. The contact time is about 15 minutes with 70% ethanol for inactivating hepatitis B, and about 1 minute for HIV. The ethyl or isopropyl alcohol is mostly used in a concentration of 70 to 90 minutes. And the contact time is about 5 minutes for disinfection. For video laryngoscopes, the manufacturer recommendations should be followed, and discarded blade should be, disposable blade should be discarded. The screen and the external surfaces of cables can be wiped out just with the alcohol, which provides a low level disinfection. And the other parts, according to the manufacturer, can be sterilized or disinfected using ethylene oxide or plasma, or hydrogen peroxide plasma. Other sterilization systems like Steris or Sterat is also available, which are recommended by many manufacturers for video laryngoscopes. It's important that post-sterilization laryngoscopes must be stored in under clean condition under disposable covers. Thank you so much. I'm sorry for exceeding the time. Thank you again.
Thank you, Dr. Abhishek, for covering the topic starting from history to the sterilization. It's an
Thank you, sir.
exhaustive
I
topic.
really apologize for exceeding time. I'm really sorry about it.
No, in between I was trying to hold you, but the system have not allowed me. So it is all right that particularly for postgraduate, it is very important the direct or indirect direct laryngoscopy, video laryngoscopy. The postgraduate must know start from the history of how they have developed. So ideally, the initial days, the direct laryngoscopy developed from the indirect, and now again we have into the indirect laryngoscopy. So for postgraduate student point of view, can you highlight the main limiting factor with the direct laryngoscopy and video laryngoscopy, and how we have to overcome this?
So the main limitations that we find in direct, the very reason that video laryngoscopy was developed was the in anticipated difficult laryngoscopies, the predictors of difficult laryngoscopy. If we are predicting in any of those, first thing, like when we say difficult cervicospinal movement, so difficult limited mouth opening is there. So all these situations wherein we predict a difficult direct line, those predictors were initially developed for as predictors of difficult direct laryngoscopy. So
Yeah.
in any of those situations, when we predict that the direct laryngoscopy will be difficult, we can always go for the video laryngoscopy, which is we now the part of the ASA difficult airway algorithm. So in preparation for the difficult laryngoscopy, once we in the examination part, if we predict a difficult airway, and we can always use video laryngoscopy as a alternative for a direct laryngoscopy.
Yeah.
Like
so for postgraduate, it's very important. We must know the limitation and advantage or added advantage. Like in direct laryngoscopy, we might not be able to have the good view in difficult airway, versus in video laryngoscopy, we can have the good view, but sometimes we are not able to guide the tube. So we must be knowing all this before going, particularly handling the difficult airway. So thank you very much, Dr. Abhishek, for highlighting the topic and cover. I think you have covered history part also and all the things. Thank you very much.
Thank you, sir. Thank you so much.
And thank you, Devang.
Thank you, sir.
The help from you because you are exceeding from the time. So and
Yes, sir.
hosts are not allowing to interrupt.
It was a recorded
session.
session.
Thank you very much
sir,
for giving me the opportunity.
Thank you, sir. Thank you, sir. Next is the simulated drug Viva Vote session on the topic opioids. The Viva will be conducted by Dr. Neeja Banerjee and Dr. Anupma Gil Sharma. Dr. Neeja ma'am is Professor Anesthesia, ABVIMS and Dr. RML Hospital, New Delhi. Her areas of interest are critical care and neurosurgery. She is also an ATLS and CCLS instructor. Dr. Anupma ma'am is an Associate Professor, ABVIMS and Dr. RML Hospital, New Delhi. Her areas of special interest include critical care, difficult airway management, regional blocks, and transplant anesthesia. Their questions will be answered by our second year PGs, Dr. Akash, Dr. Kshitij, and Dr. Sandra. Over to you, ma'am.
A very good morning to everyone. So we are now continuing with the sessions on drugs of table Viva. As you all know that answering precisely in the exam and giving all the relevant information about the drug is an art. To emphasize this, today we have a session on general opioids and the individual opioids in particular after that. So I welcome our Professor Dr. Neeja Banerjee ma'am to start the session and take it further. We welcome you, ma'am.
Thank you, Dr. Anupma. Good morning, everybody. Welcome, Dr. Akash. Dr. Akash is a first postgraduate for this Viva that we will be taking on opioids. And then we will be discussing specific opioids like morphine, fentanyl, remifentanil. Then we'll also be discussing your tramadol, buprenorphine, and naloxone will also be discussed. So we'll start with Dr. Akash. Good morning, Dr. Akash. Could you tell me about opioids? What do you understand by opioids, the term opioids?
Ma'am, any compound that are naturally semi-synthetic or synthetic that acts on the specifically on the opioid receptor and are similar in action with endogenous opioids, ma'am.
Okay. So what are these endogenous opioids?
Ma'am, endogenous opioids are enkephalin, endorphin, and dynorphin that act on the mu, kappa, and delta receptors, ma'am.
Okay.
Opioid
So
receptors.
these, right. So these drugs which are called opioids, they act on these specific receptors and behave like the ones that are endogenously secreted. That they are the ones which are termed as opioids. So you use these three terms: naturally occurring, synthetic, semi-synthetic. So is there a way by which you can classify opioids based on these terms?
Yes, ma'am. They are classified on the basis of occurrence, like naturally occurring morphine, codeine, thebaine, and papaverine, and semi-synthetic like oxycodone, hydrocodone, and synthetic opioids like pentazocine, fentanyl, remifentanil, and buprenorphine.
Okay. And depending on the agonists or antagonists, is there a particular way of classification also further?
They are also classified on the basis of their receptor activity, like opioid antagonists like morphine, fentanyl, and remifentanil. Agonist antagonists like pentazocine, butorphanol, and opioid antagonists like naloxone, naltrexone, and nalmefene.
Right. So agonists or pure agonists, if there was some problem in connection, Dr. Akash, could you just repeat the agonist part, the first part that you said?
Ma'am, morphine, opioid agonists like morphine, fentanyl, remifentanil, and partial like buprenorphine.
Right. Right. We could hear the rest part. So why I wanted you to repeat was because morphine is basically considered as a gold standard, is considered as a prototype of this group, and very strong mu agonist. That's why I asked you to specify it further in detail. So these opioids, which have got a very good analgesic effect and sedative action, how do they act?
They act on the mu, kappa, and delta receptor that are present supraspinal and spinal. In supraspinal, they are present in periaqueductal gray, cerebral cortex, and thalamus. In spinal cord, they are present in substantia gelatinosa, ma'am. And act by inhibiting the G protein coupled receptor that in turn inhibit the release of excitatory neurotransmitters such as acetylcholine and substance P, and further hyperpolarize the postsynaptic membrane and inhibits the transmission of impulse, ma'am.
Very good. Very well explained, Dr. Akash. So this is how the analgesic effect of opioid takes place. Okay. And what is the effect of these drugs on various organs?
Ma'am, they act on a different organ system. Like in central nervous system, they act by causing sedation, euphoria, and analgesia, and also decreases the ICP. In respiratory system, ma'am, they causes respiratory depression by acting on a respiratory center and medulla, and also causes cough suppression, and they are also used in cough syrup depressions.
Yeah, right. Is there any cough syrup that you know of which is a opioid which you use routinely? Or say people use it?
Ma'am, they are preparation. Ma'am, preparation made of codeine and dextromethorphan, ma'am.
Right.
Yes,
Right. Codeine was the first one which was used, in fact. Right.
Yes,
exactly. And then what else?
Ma'am, dextromethorphan, ma'am. Because it is a dextroisomer, ma'am. It has it has no abuse potential, ma'am.
So nowadays, dextromethorphan is used more than codeine because codeine has got a big disadvantage of dependence.
Yes,
getting addicted to the drug. Right. Yes. Then what else? What are the other effects?
Ma'am, on GIT, it causes nausea, vomiting, and constipation, and it also causes biliary spasm in some patients, so that biliary colic is also seen. And genitourinary system, it causes urinary retention, and also causes pruritus, ma'am.
Okay. So, and other than that, histamine release is also a big one of the effects of with these drugs. And
Yes,
it is
ma'am.
most troublesome with which group, which opioid?
Ma'am, it is mostly from a morphine, ma'am.
Right,
And,
morphine. So you have to be careful where you do not want, let's say, in patients of bronchial asthma, you would not like to give them.
yes, ma'am.
Right. Okay. Okay. And what else? What about CVS? Does it have any effect on CVS?
Ma'am, on ma'am, and CVS it act by causing bradycardia and hypertension. Ma'am, that decreases the preload on heart. So, ma'am, it is also used in cardiogenic pulmonary edema, ma'am.
Yeah, morphine is classically used for that. But, there is one drug which doesn't cause bradycardia. In fact, it causes tachycardia. But which opioid?
Yes, ma'am. Pethidine is the one.
Very good.
Yes, ma'am.
And what about effect on pupils? Whenever there is an overdosage, this is what you look for.
Ma'am, in overdose of opioids, ma'am, we look for the meiosis, ma'am. Ma'am, this is because of ma'am these action on mu and kappa receptor on the Edinger-Westphal nucleus, ma'am.
Right, and here again, with pethidine is different from others. It doesn't cause so much of meiosis. In fact, pethidine was brought up as an anti-muscarinic agent, so it has got all the effects that are anti-muscarinic effect. But
Yes.
since it acts on opioid receptors, it was finally classified as a opioid drug. Right, very good.
Yes, ma'am.
So these are the various effects of this drug. So once you and they can be taken by various routes, which can be oral, IV, IM, depending upon the characteristics of the drug. So then, how is it metabolized?
Ma'am, it is metabolized by hepatic and extrahepatic pathway by enzyme cytochrome P450 and cytochrome 2D6, ma'am.
So what is that extrahepatic pathway?
Ma'am, drugs like remifentanil, they are metabolized,
Right.
ma'am, extrahepatic.
And that is by tissue esterases.
Yes, ma'am.
Yeah. So it gets metabolized by that. So because of that, that really gives us a very big advantage, because it is not dependent on any organ system for its metabolism and excretion. So the onset of action and is very short and immediately prompt. Right. Very good.
Yes,
And then, can you tell me something about the duration of action? Do all drugs have similar duration of action?
Ma'am, duration of action, ma'am, depends on lipophilic and hydrophilic nature of these drugs, ma'am. Like morphine is hydrophilic in nature, so it crosses the blood-brain barrier very delayed. So it action is delayed. But because it cannot pass the blood-brain barrier, so similarly the onset duration of action is prolonged, ma'am, because of this. And on the other hand, fentanyl, which is lipophilic drug, it gets distributed very easily, so the onset of action is fast, or similarly because it is distributed, it is washed off very quickly, so the duration of action is a little smaller, ma'am.
Right. This I wanted to basically here, what I'm trying to highlight is this here. We are at this moment we are discussing the general properties of all opioids. But individual opioid have their own individual properties, and which is like duration of action, some specific side effects of that drug, or some excretion processes are different. So whenever you're answering a specific opioid, you should know which opioid has got one specific action. That's why I asked also the unusual properties of some opioids. So please keep this in mind whenever you are answering questions on opioids. Okay, Dr. Akash, and something about their pharmacokinetic property. Are they bases or acids? What are these drugs?
Ma'am, opioids are the weak base, and ma'am, they are weak base, ma'am, and they are highly ionized on the physiological pH. So
they can be ionized and ionized, and that's how that also affects. So basically, all these factors of that particular drug affects their onset of action, duration of action, excretion, metabolism, effects, and side effects. So this was about the general overall in a wider term about opioids. So now after this, individual drugs will be discussed. Then now Dr. Akash will be talking about morphine. Dr. Anupma, could you ask questions on morphine now?
Thank you, ma'am. Yes, Dr. Akash. So, which opioids have you used in your clinical practice? Which all opioids are you using?
Ma'am, we generally use ma'am fentanyl, tramadol in our regular practice, but we have also used morphine ma'am sometimes.
Okay. So, would you like to tell us something about morphine? When was morphine discovered?
Ma'am, morphine was extracted from the ma'am straw of plant opium poppy, ma'am, in 1804 by ma'am German pharmacist Friedrich Saturner, and
Yes.
ma'am it was earlier given the name ma'am morphium on the name of Greek god Morpheus, ma'am, the god of dream. So ma'am, after that it is named ma'am morphine, ma'am, because it causes sedation, ma'am, so that the name was given.
Very good. So it causes a kind of euphoria. So that was the name was
Yes, ma'am.
given based on that. Okay. So are you aware of the various formulations in which morphine is available and how is it dispensed?
Ma'am, morphine is available in ma'am oral tablet preparation of ma'am 15, 30, and 16 mg, and also in ma'am injection formulation in 10 mg per cc, 15 mg per cc, and ma'am 20 mg per cc ma'am preparations, ma'am.
Are there any other routes by which morphine can be given?
Ma'am, morphine can be given via ma'am IV, IM, oral route, rectal route, subcutaneous route, and also can be given intrathecally or epidural, ma'am, by epidural route, ma'am.
Very good. So why do you think where is the oral morphine tablets used? Have you used them? Have you seen using them? What are the precautions that one should take while giving them? And where is it
Ma'am,
given?
oral tablet preparation are mainly used in ma'am patient with ma'am patient in cancer treatment, ma'am, for pain management.
Very good.
And ma'am, they are associated. Ma'am, constipation is the associated side effect with those preparations, and ma'am, use of laxative is recommended along with ma'am that. And ma'am, tolerance is also seen, ma'am, in such patients, ma'am, because of the prolonged use of these opioids. So dose adjustment has to be done, ma'am.
One might has to increase the dose as we
Yes,
give
ma'am.
tablets to these patients because they are terminally ill. So then we keep on increasing the dose as and when the pain requirement occurs. Okay, so can you
Yes, ma'am.
tell something about the typical intravenous dose that you must have used in the perioperative period? What are the doses?
Ma'am, the IV dose for pre-medication is 0.05 to 0.1 mg per kg body weight, and ma'am, the onset of action is 1 to 2 minutes, and the ma'am peak effect reaches by 30 minutes, and the duration of action is 1 to 2 hours. And ma'am, for ma'am, for pain management, and the bolus of 0.1 to 0.2 mg per kg is given, and the infusion of 20 to 30 mics per kg per hour body weight is ma'am started, ma'am.
So what are the disadvantages of giving the drug as an infusion? Are there any organ dysfunctions which you want them to be careful in, and how is it metabolized in the body?
Ma'am, morphine is metabolized by ma'am glucuronidation. Ma'am, so the two metabolites are formed: morphine 3 glucuronide and morphine 6 glucuronide. Ma'am, and these are after that excreted through the renal pathway. So, ma'am, in patient with renal or hepatic failure, ma'am, the metabolism will be slow. So, ma'am, in these patients, ma'am, they have to be given carefully. And ma'am, these two metabolite, morphine 3 glucuronide, it causes, ma'am, it decreases the seizure potential and causes allodynia in children. And morphine 6 glucuronide, ma'am, that is the analog of morphine, which is 10 to 20 times more potent than morphine, ma'am.
So one has to be careful in the renal failure patients or the patients who have a propensity to having seizures. So these drugs, one has to be careful titrating the dose. So are there any other subset of patients in which you want to be careful by giving morphine?
Ma'am, we have to, ma'am,
Yes.
careful, ma'am, careful in patient with complaint, ma'am, complaint of asthma, and
Yes.
ma'am, in
Why
pregnant
is it?
females. Ma'am, in asthma, it can cause bronchospasm due to the ma'am release of histamine.
Yes, so histamine
Yes,
release
ma'am.
can cause a bronchospasm in these patients. Very
Yes,
good.
ma'am. Yes, ma'am.
Okay. What are the other ways by which you can give morphine? You're giving IV,
Ma'am,
don't you have to? Then,
yes, ma'am. We can also give it by ma'am IM route, ma'am, for which dose is 0.1 to 0.2 mg per kg.
yeah.
And then ma'am, the onset of action is within 15 to 30 minutes and will be until 3 to 4 hours, ma'am.
And
And
also,
ma'am,
right,
it can also be given through ma'am oral route.
yes, and your axial also route it is given. So what kind of
Neuraxial route,
respiratory,
ma'am, it
yes.
can.
So what kind of respiratory depression does one see with the morphine?
Ma'am, because morphine is a ma'am hydrophilic compound, so ma'am there is a ma'am delayed. It crosses blood-brain barrier very late.
Yes.
So
So
ma'am, it
yes, Dr.
causes the
Akash, can you
delayed
repeat
respiratory
that?
depression in patients.
Can you repeat that? I think.
Ma'am,
Can you
ma'am,
repeat
it
other
causes
kinds of depression? Yes.
yes, ma'am. It causes delayed respiratory depression in patient because morphine is hydrophilic and highly ionized on physiological pH. So that ma'am, there is a delay in crossing blood-brain barrier. So ma'am, activity is delayed, ma'am.
Very good. Very good. So, are you aware of something like WHO step ladder for pain, and where do you place morphine in this?
Yes, ma'am. Ma'am, WHO pain ladder, ma'am, is divided into mild pain, mild to moderate, and moderate to severe pain. In ma'am, opioids are used for ma'am moderate to severe pain, in which strong opioids are used along with the ma'am analog treatments, ma'am.
Okay, so under step 3, so it is for moderate to severe pain. Thank you, Dr.
Yes, ma'am.
Akash. So this is how one should go about. The question can come on general opioids or on a specific drug. So we'll move on to our next candidate. Thank you, Dr. Neeja ma'am. Thank you, Dr. Akash.
Thank you, ma'am.
Thank you, Dr. Anup.
So now we have with us postgraduate Dr. Kshitij with us. So he will be talking about fentanyl, fentanyl, and the antagonist, opioid antagonist. Since Dr. Kshitij, to which class of drugs does fentanyl belong?
Fentanyl belongs to lipophilic opioids. It is a synthetic lipophilic phenylpiperidine derivative opioid. It was first developed by Janssen's Pharmaceutical in 1959.
Okay. Okay. So is it a synthetic? Can you name some other synthetic phenylpiperidine derivative?
Yes, ma'am. Other synthetic phenylpiperidine derivative are remipental and elfental.
Okay, very good.
And also methadone.
So how potent it is as compared to morphine?
Ma'am, if we'll compare it to morphine, it is 100 times more potent because its dose is also very less compared to the morphine.
Which other drug is more potent than morphine that you know of?
Ma'am, remipental, elfental, sufental, and buprenorphine, they all are more potent than morphine.
Very good. So have you seen an ampule of fentanyl? To what all composition does it come? And by which
Yes,
route do you
ma'am.
get them? Yes.
Yes, ma'am. Ma'am, fentanyl comes in an ampule of 2 ml, 5 ml, 10 ml, and 20 ml, and the concentration present in it is 50 mics per milliliter. Ma'am, it is also available as transdermal patches, which comes in 50% concentration of 2.5 mg, which gives fentanyl, which releases fentanyl in 50, 75, and 100 mics per hour. It also comes as intranasal sprays, and it also comes as buccal soluble films.
Okay. So why do you think we need an ampule of 10 ml of fentanyl? Why does it come in 10 ml also?
Ma'am, because sometimes we will be needing the fentanyl as an infusion, so that time we require fentanyl more volume.
Very good. So can you tell us about the typical IV dosing of fentanyl and when one wishes to use it as an infusion? So what all scenarios do we use it? And what are the specific properties of fentanyl when we're using it in which makes it useful as an infusion? Yes.
Yes, ma'am. Ma'am, the typical IV dosage of fentanyl is 1 to 2 mics per kg. And when we run it in as an infusion, the dosage is 0.01 to 0.05 mic per kg per minute. Ma'am, what is special about this drug is it is fast acting. Ma'am, the onset of the drug action is 2 to 3 minutes, 1 to 2 minutes, sorry. And the total duration of action is 60 to 90 minutes. The peak action comes at 2 to 5 minutes.
Okay.
So it is a very fast action.
Very good.
Sorry, ma'am.
Have you heard of context sensitivity half-life? Can you tell something about it? And how is it relevant for fentanyl?
Yes, ma'am. Ma'am, context sensitivity half-life can be defined as how much time would a drug would take to its effect to wear off. Like if I'll give you an example with fentanyl. The context sensitivity half time of fentanyl is 260 minutes, 4-hour infusion. Context sensitivity half life. It means that if we'll run an infusion of fentanyl for 4 hours, it would take another 4 hours and 20 minutes for effect of fentanyl to wear off.
Completely wear off. Okay.
Yes.
Right. So, can you tell us something about how it is metabolized in the body, and what does it have any
Yes,
active and inactive metabolites?
Yes, ma'am. Fentanyl is metabolized primarily by dealkylation and hydroxylation. Then the metabolite formed after this is norfentanyl, which is excreted through kidney. Though 10% of fentanyl is excreted through kidney unchanged. This is the metabolism and excretion of fentanyl. Yes, ma'am.
Okay. So, what are the side effects which you see with fentanyl, which are of importance to us?
Ma'am, the side effects seen with fentanyl are sedation, respiratory depression, and when fentanyl is given in higher doses, it can also cause chest wall rigidity. Ma'am, it can also cause, yes, ma'am.
Especially if it is given as a bolus, then it can cause chest
Yes,
wall
ma'am.
rigidity.
Chest wall, yes, ma'am.
It can also, have you seen bradycardia also occurring with fentanyl?
Yes, ma'am. Yes, ma'am. In a higher dose and in rare instances, bradycardia is also seen. In some cases, biliary colic pain is also seen because of its spasm acting on smooth muscles. And ma'am, yes, these are the side effects.
Okay. So let's now move on to our next drug. Have you heard of opioid pruritus?
Yes, ma'am.
Okay.
Ma'am, opioid pruritus, ma'am, it is caused usually by mechanisms acting on the midbrain only.
Okay.
And ma'am, what we do is we look for the rashes on the patient. We talk to the patient, ma'am. What we give for the management of it is we usually give antihistamines. Earlier, we gave antihistamines and sorry, ma'am.
And naloxone also, as Dr. Sandra has already.
Yes, ma'am. As an infusion. Yes.
So fentanyl itself can also cause some kind of allergic reactions in few patients, although it is not very common. Thank you, Dr. Sikshit.
Yes,
so Dr. Neeja ma'am will be taking on the next drug. Yes, ma'am.
Okay, Dr. Chitij, let us learn about remifentanil. Tell me something about remifentanil, what you know of. Which group?
Ma'am, remifentanil is, sorry.
Yes, tell me.
Ma'am, remifentanil is synthetic, ultra-short acting, lipophilic piperidine derivative opioid. Ma'am, it comes in a vial of, though we don't use remifentanil in here, but it comes in a vial of 3 ml, which contains 1 mg of remifentanil hydrochloride, which can be reconstituted later on. It is a sterile, preservative-free, white to off-white powder, lyophilized powder, which is reconstituted with distilled water or water for injection or glycine.
And how potent is it?
Ma'am, remifentanil is as potent as fentanyl only.
Right. So, what is so different about remifentanil compared to that of fentanyl? You get these newer drugs because they have some advantage, no?
What is different? Fentanyl is, ma'am, it is very precise and it's rapidly acting ability. Ma'am, there is no accumulation of this drug and there is rapid onset and rapid offset of this drug. Plus, if we'll discontinue giving the drug or if we'll discontinue the infusion, the effect will wear off immediately.
So why? Why there is rapid offset? Why there is no accumulation?
Ma'am, because of its metabolism. Ma'am,
Very good.
because remifentanil, yes, ma'am. Ma'am, remifentanil is metabolized by non-specific esterases present in plasma by the
Yes.
hydrolysis of, yes, ma'am. Yes, ma'am.
So, you know, that is a
Ma'am,
very big advantage, that it is not dependent on any organ system function. So if there is liver dysfunction, if there is renal dysfunction, then also you're not worried about the metabolism or accumulation of this drug. If you stop the infusion of this drug, the effect wears off. So what is the biggest advantage of this drug? Where is it used? In which kind of
Ma'am,
surgery?
ma'am, it can be used in, yes, ma'am. It can be used in daycare surgeries. It can also be used in TIVA, where we want to avoid the inhalation agents. Yes, ma'am.
So in TIVA, we are using this. And the main thing is that it is because of all these qualities that we talked about. You talked about context sensitivity in this. There's a term used for remifentanil specifically. It is context insensitive. What do you understand by that?
Yes, ma'am. Ma'am, context insensitivity means the half-life, the clearance, and the distribution is completely independent of the strength and duration of the infusion that we are giving.
Yes. So basically, because it is getting metabolized by the plasma esterases, so it does not affect the half-life. If it does not have any effect. Very good. So what else can do you? What are the side effects seen with this drug? Anything specific or the similar ones?
Sorry, ma'am.
The side effects, are they same that we talked about in opioids, or anything unusual about this?
Ma'am, the side effects usually seen are similar. In high dose, it can also cause a chest wall rigidity.
Yes. So there is nothing unusual about this drug.
Yes.
The advantages it has, it does not have any added disadvantage. And the only thing that one has to take care of is when you stop this drug infusion, you have to make sure that you have already given some other alternative drug to the patient, because the effect immediately finishes off, right? So the patient would start having pain. Okay, so this was about remifentanil, and other antagonists we had already talked about with Dr. Sandra. So let's learn about neuraxial opioids. So what do you understand by neuraxial route?
Ma'am, neuraxial route can be described as that we will be injecting the drug in neuraxial route, which is subarachnoid space and epidural space.
Yes. So what are the various drugs that are given through neuraxial route?
Ma'am, the various drugs that we give through neuraxial route are local anesthetics like lignocaine, bupivacaine. We can also give opioids like fentanyl, morphine. Other drugs given are alpha-2 agonists, clonidine, corticosteroids, dexamethasone, and NSAIDs like ketorolac.
Okay, tell me something about, let's talk about opioids only, neuraxial opioids. So where do they act, these neuraxial opioids?
Ma'am, neuraxial, the mechanism of action.
Right,
Sorry, ma'am.
Right.
Yes, ma'am.
For neuraxial opioids.
Yes, ma'am. There are two ways how neuraxial opioids act. Ma'am, there is one opioid mechanism of action. They act on mu receptor present in substantia gelatinosa layer in dorsolateral root horn of spinal cord.
Right.
And the other one, the non-opioid mechanism of action is they act on pain pathways. They modulate the pain pathway. They activate the descending inhibitory pathways.
Yeah, exactly. Perfect. So it is the substantia gelatinosa which plays actually a very big role for the administration of these opioids. Now there is something about when we had talked about the pharmacokinetics, we talked about hydrophilic and lipophilic property. So does it have any impact on the onset of action, duration of action, anything of these drugs? Can you tell me some difference?
Yes, ma'am. Because of this action, their lipid solubility, which can be described by water soluble, water partition coefficient, octanol number, which we also know as octanol number. They are classified into two groups: lipophilic opioids and hydrophilic opioids. Lipophilic opioids are fentanyl, sufentanil, remfentanil, elfentanil, and hydrophilic opioids are morphine, dimorphine, pethidine, and ma'am, these are the hydrophilic opioids. Commonly used hydrophilic.
I'll stop you here, Dr. Chitij. How is it that hydrophilic opioid, what is the difference of a mechanism of action or say duration of action, onset of action of a hydrophilic and a lipophilic neuraxial opioid? Can you explain that to me?
Yes, ma'am. The most commonly used hydrophilic opioid I can say is morphine. So how morphine acts is, morphine is, it has high CSF solubility. It has
Right,
high
very good.
CSF, it has high CSF spread. That there is slow onset of action, but the duration of action is longer because of its
Prolonged.
low lipid solubility and high water solubility.
And
So
what about
when we will
fentanyl?
inject the, ma'am, fentanyl is right opposite to the it. Fentanyl water partition coefficient is 813. It is highly lipid soluble. So it will be the action of fentanyl would be similar to like an intravenous injection. It will be systematically absorbed.
Okay. So very well explained, Dr. Chitij. Dr. Anupma, would you like to ask about the side effects? You're
Dr.
mute. Could you
Yes.
unmute yourself?
Yes, ma'am. So, Dr. Kshitij, have you ever used these opioids in neuraxial route, and what are the side effects that you have seen, and what precautions one should take when giving them by this route?
Ma'am, the most common side effects that we see after using these opioids are respiratory depression, pruritus, nausea and vomiting, and sometimes urinary retention as well.
Very good. So, how does one take care of these? One should monitor them?
Yes, ma'am. We are supposed to monitor the patient constantly. We are also supposed to talk to the patient if they are feeling any discomfort or is there any rashes on the body to check out if there is any case of pruritus as well. And yes, ma'am, that's what we do usually.
And one should look for delayed respiratory depression. It can happen. Ma'am, you are
Yes,
muted.
ma'am.
Need
Yes, ma'am.
Okay.
Yeah, I was saying classically pruritus in these cases on nose and face. Patient is
Yes, ma'am.
scratching the nose more than anywhere else. Yeah. Yes.
Typically seen. So, what is the typical dosing, Dr. Kshitij? What is the dosing of hydrophilic and lipophilic opioids that you know of?
Yes, yes, ma'am. The dosing of fentanyl that we are giving is 10 to 25 micrograms. Ma'am, this is the intrathecal dose. If we'll talk
Okay.
about the epidural dose, then there will be a bolus of dose. First of all, we'll be giving a bolus dose 50 to 100 mics per hour, and then we'll run an infusion of 25 to 50 mics at the rate of per hour rate of this. And if we'll talk about, ma'am, shall I also tell about onset
Yes.
and duration of
Yes.
action?
Yes.
Yes, ma'am. Ma'am, the onset of action of fentanyl infusion will be 5 minutes, and the whole duration will be 4 to 6 hours. While if we'll talk about morphine, the dose of morphine is 50 to 300 mics. That is intrathecal dose. If we'll talk about epidural dose, it would be 1 to 10 mg. And when the onset of action for this would be 15 to 20 minutes. And the
So
whole
that-
duration, it will be acting with, yes, ma'am. It would be 6 hours to 24 hours.
So nowadays we are not using morphine that commonly, and so one has to be careful about respiratory depression when giving, and the dose has to be titrated depending upon the effect. Okay, so are you aware of opioids being used by in the labor analgesia? Is it an advantage?
Yes, ma'am. Yes, ma'am. Opioids are used in labor analgesia as there is lumbar epidural analgesia we're giving to the patients.
Why neuraxial
These
route?
days, yes, ma'am. These days, very low dose bupivacaine, that is 0.06 to 0.125% bupivacaine, local anesthetic, plus opioids are used. Ma'am, the advantage of this thing is that the patient, there will be no motor blockade of the patient, and the patient would be ambulatory.
Yes.
So we will be providing the analgesia. Yes, ma'am.
Yes, so even ropivacaine, along with ropivacaine, along with low dose bupivacaine, if you give a small dose of opioid, the patient can be ambulatory till the second stage, and the motor blockade can be prevented, and the patient will also have a good pain relief. Thank you, Dr. Kshitij. That was a very wonderful session. Thank you, Dr. Neja, ma'am. Do you want to conclude, ma'am?
Thank you, Dr. Chitij. Yes, thank you, Dr. Chitij. Thank you, Dr. Anupama. This was a comprehensive discussion on opioids, and each individual drug, neuraxial opioids, have been covered, including naloxone. So I hope the postgraduates, you have You have learned whatever specific to learn. This is generally asked on table viva. Sometimes the short note on neurexil opioids is also asked. So these are the questions which are generally expected out of this topic. Okay. Thank you very much.
Thank you, ma'am. Thank you, Dr. Shetty.
Okay, so our next postgraduate is Dr. Sandra. Good morning, Dr. Sandra.
Good morning, ma'am.
Yeah, so we'll be starting our discussion first with pethidine. Tell me something about pethidine. Have you used it?
No, ma'am.
Okay, yeah, in our days, it was one of the commonest ones which we were using. In fact, nowadays you are using fentanyl, but you should know about pethidine. It has got its own advantages. And there's one very specific advantage for which it is used very frequently. So let's learn about pethidine. Yeah, Sandra, tell me about pethidine.
Ma'am, pethidine is a synthetic opioid agonist which is derived from the opioid alkaloid phenylpiperidine. It is available in 1 ml ampule containing 50 mg per ml of meperidine hydrochloride. It is also available in 2 ml and 20 ml vials. The 20 ml vial contains 0.1% metacresol as a preservative. Mechanism of action.
Yeah, Sandra, this was the first synthetic opioid which was made. Earlier, only naturally occurring were there that you know of. Morphine was the first one which was used, and this was the first which was prepared. When it was prepared, what was it considered as? Was it considered as an opioid or some other drug? When is it similar in action to some other drug? Yeah.
Ma'am, it was initially prepared as an antimuscarinic. Ma'am, mechanism of action.
By virtue of this being antimuscarinic effect, what are the effects which are different of this drug compared to the other opioids?
Ma'am, meperidine produces, unlike other opioid agonists, meperidine produces tachycardia, dry mouth, and mydriasis.
Yeah, so that classically that opioid overdosage that we see neosis that we are looking for, that may not be there if there is an overdosage of pethidine. That is something that you have to know of. And yes, that significant bradycardia that you may see in overdosage, that also may be missing there. So these are some exceptions. This is for the students. Some exceptions of every drug you should know of, and that is what you should look, and that is what an examiner expects you to know. Okay. So is it lipophilic or is it hydrophilic?
Ma'am, pethidine is lipophilic. It is 30 times more lipophilic than morphine.
Yeah, and then its mechanism of action, what is it? Mechanism of action?
Ma'am, it is a mu opioid receptor agonist, and it also shares structural similarity to local anesthetics and atropine.
Yeah, this is exactly what I was talking about. Because of its structural similarity, this is what it shows. Okay, and metabolism, what does it get metabolized to, the products?
Ma'am, pethidine undergoes metabolism in the liver to normeperidine and normeperidinic acid. Both are active metabolites, ma'am.
Okay.
And it is eliminated in urine.
Okay. And then why are you worried about these metabolic products? If they accumulate, can they cause increased duration of action, increased side effects of this drug?
Ma'am, the metabolite of pethidine, normeperidine, is neurotoxic. So it can precipitate normeperidine-induced neurotoxic side effects like confusion, agitation, seizures, and myoclonism.
Right. So that is why the accumulation of these metabolites is like really one thing one has to be careful about. And does it cause placenta?
Yes,
placenta?
ma'am. It crosses. Yes, ma'am. It crosses the placenta, and the concentrations of meperidine in the placenta can even be higher than maternal concentration.
Yeah. So there was a time when it was used very frequently, but whenever it is given, then we have to take this precaution. And yes, the pediatrician should be informed about this side effect. And what about some non-analgesic effect, specific non-analgesic effect, which it is very useful for anesthetist, which we have of pethidine?
Ma'am, pethidine is used to treat post-operative shivering, ma'am.
Yes, 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 excellent. So what are the dosages? Is it as high as analgesic or much lower?
Ma'am, it is a weak analgesic, ma'am. It is given for acute pain at a dose of 50 to 150 mg orally. Ma'am, it can also be given in subcutaneous dose 1 to 1.8.
And shivering, for post-operative shivering, the dosages are much lower. You give 10 mg and then 10 mg, that's how you increase it intravenously. It's like very, very effective. And is there any absolute contraindication of pethidine?
Ma'am, pethidine cannot be given with MAO inhibitors. It causes serotonin syndrome, ma'am. Serotonin syndrome is character.
So this is something that you have to keep in mind. So the history of intake of MAO inhibitors is extremely important. There's another drug where you will learn where again it cannot be given with MAO inhibitors. So for that, I will hand over to Dr. Anupma for the next drug discussion. Dr. Anupma, please.
Thank you, ma'am. Dr. Sandra, have you ever seen tramadol being used in
Dr. Anupma, you may take over.
Yes, ma'am. Thank you, ma'am. Dr. Sandra?
Yes, ma'am.
Have you ever used tramadol in your hospital? And
yes,
how
ma'am.
is it available? Can you tell us?
Ma'am, tramadol is a synthetic opioid agonist. It is which is a phenylpiperidine analog of codeine. It is available in 2 ml ampules containing 50 mg per ml of tramadol hydrochloride, ma'am.
Okay. And how potent it is as compared to morphine? It's a weak agonist at all the receptors. So
yes, ma'am. It is 5 to 10 times less potent than morphine, ma'am.
Okay. So what are the various routes by which tramadol can be given to the patients, and how is it different from other opioids while giving it in these routes?
Ma'am, tramadol can be given orally, IV. It can also be given by rectal route, ma'am.
Okay. So why do you think tramadol is so popularly given by the oral route? And what are the doses?
Unlike other opioids, tramadol causes analgesia without respiratory depression, without organ toxicity, without development of dependence and tolerance. And it can be given orally at a maximum dose of 3 mg per kg, maximum 400 mg per day. It can also be given IM and slow IV 50 to 100 mg, ma'am, or by rectal or subcutaneous.
It has a very good oral bioavailability. So that's why it is okay,
yes, ma'am.
Nicely by the oral.
70 to 100%.
Yes, very good. So how
could you please repeat it? Dr. Sandra, there was some connection problem. So could you repeat about the oral bioavailability of this drug? Because that will explain that what Dr. Sandra was trying to tell, this is for the students, that the fact that we can give this drug orally is because of a very high oral bioavailability. And how much is the oral bioavailability, Dr. Sandra?
70 to 100%, ma'am.
Yes. So that is why this is what exactly Dr. Anupma was asking. Why is it that we can give this drug orally, whereas so many other drugs we cannot because of high oral bioavailability?
Yeah. Yes, the doses are almost similar, the parenteral dose and the oral dose. So the duration of action is typically about 4 to 6 hours. So how is the mechanism of tramadol different as compared to fentanyl, morphine, other opiates? How does it act?
Ma'am, tramadol has 2 mechanisms of actions, opioid mediated and non-opioid mediated. The opioid mediated mechanism of action is that it has a moderate mu opioid receptor agonism and weak delta and kappa opioid receptor agonism. It also has non-opioid mediated mechanism of action. It inhibits the neuronal reuptake of serotonin and norepinephrine. It also stimulates the presynaptic release of serotonin.
Good. So one has to be careful, like giving in this drug into which class of patients who are taking which drugs, just like pethidine.
Ma'am, drugs that increase serotonin or pro-serotonergic drugs like serotonin reuptake, selective serotonin reuptake inhibitors, MAO inhibitors, drugs.
Yes, good. So when you're giving tramadol, what are the usual side effects that you have seen, and how do you manage that?
Ma'am, tramadol is associated with a high incidence of nausea, vomiting. It can be managed by giving administering it with ondansetron, ma'am. And
Yes.
ma'am, and it also decreases the seizure threshold. So tramadol cannot be co-administered with drugs that decrease the seizure threshold, ma'am.
So how is the tramadol
Like-
metabolized when you are saying that it decreases the seizure threshold? So something it has to do with the metabolism of tramadol. How is it metabolized?
Ma'am, tramadol is metabolized by hepatic P450 enzyme systems to O-desmethyl tramadol. This O-desmethyl tramadol has 6 times the analgesic effect of tramadol.
Okay. And the accumulation of the metabolites can decrease the pain threshold for the seizure. Okay. So is there any other use of tramadol apart from pain, which we can use it?
Ma'am, tramadol can be used for its anti-shivering effects, ma'am.
Good, good. So
Post-operatively.
very good. So Dr. Akash told us something about the WHO step ladder for pain. So where would you like to place tramadol here?
Tramadol is placed in step 2 of the WHO step ladder, that is for mild to moderate pain.
Along with the adjuvants. Okay. All right, Dr. Sandra. So we'll now move on to the next drug. So have you heard of buprenorphine? To which
Yes,
class
ma'am.
of opioid does it belong to?
Ma'am, buprenorphine is a partial opioid agonist antagonist, ma'am. It is semi-synthetic. It is derived from the opioid alkaloid thebin.
Okay.
It
So
is available in the form.
Yes, go on, please.
Ma'am, it is available in the form of 1 ml ampoules containing 0.3 mg per ml of buprenorphine hydrochloride. It is also available in 10 ml vials, ma'am.
So is it as potent as morphine?
Yes, ma'am. The analgesic effects are almost as potent as
How
morphine.
does it differ from other opioids in its analgesic action, and how can that be useful for us?
Ma'am, buprenorphine has a very high affinity for mu opioid receptors, 50 times higher than that of morphine. So buprenorphine cannot be co-administered with other opioid agonists due to its high affinity.
So where do you use buprenorphine? Where on the
Ma'am,
clinic
buprenorphine
used? Yes.
Ma'am, buprenorphine can be used as a pre-medication intraoperatively and post-operatively 0.3 mg IM, ma'am. And it is also used for patients with chronic pain who have opioid use disorder, ma'am. It can for this a combination tablet with naloxone is available, ma'am, for opioid use disorder, ma'am. And
any other drug which can be used for the stimulation for opioid overdose and for stimulation of the respiration? Any other drug which you are aware of?
naloxone.
Naloxone. Okay. So now we go on to our next topic, that is opioid antagonist and naloxone. Dr. Neeja ma'am will be taking this topic. Yes, ma'am.
Okay, thank you, Dr. Anupama. So, Dr. Sandra, we have talked about all these opioids. So, let's learn how the effect of these can be antagonized by making use of these opioid antagonists. So, can you name a few opioid antagonists?
Ma'am, naloxone, naltrexone, and nalmefene.
Okay, so let's first talk about naloxone. Tell me about naloxone.
Ma'am, naloxone is a non-selective opioid receptor antagonist. It acts on mu delta and kappa receptors, but it has primarily antagonism in mu receptors, ma'am. It is available
in Dr. Sandra, this is a competitive type of antagonism. It basically
Yes.
occupies the place where these opioids are occupying the opioid receptors. Yeah, displaces it, and that's how it antagonizes the effect. Okay. Yeah. Yes, and how is it dispensed?
Ma'am, it is available in 1 ml ampule containing 0.4 mg per ml of naloxone hydrochloride, ma'am.
Okay. So how do you give it, and what is the duration of action?
Ma'am, naloxone can be given IV. It can 1 to 4 microgram per kg is the IV dose. In case IV access is not available, it can also be given by intratracheal route. Ma'am, it can also be given IM, and nasal sprays and patches are also available.
Right. And what is it basically used for? Or as an antagonist to antagonize what? What are we worried about? What are we antagonizing?
Ma'am, it is used to opioid. It is used to antagonize opioid-induced side effects, primarily respiratory depression. Ma'am.
Yeah, it is the drug of choice for that.
For
Yeah.
respiratory depression.
Yes, yes. And how do you give it for antagonizing the effect?
Ma'am, in deliberate opioid overdose, it can be given 0.4 to 0.8 mg IV every 2 to 3 minutes, maximum dose of 10 mg. Ma'am.
Okay. And what is the total duration of action of this?
Ma'am, 30 to 60 minutes. Ma'am.
So that is why whenever a long acting opioid has been given, or for a long duration any opioid has been given, when you expect the duration of action of that opioid to be pretty prolonged, so only one dosage is not going to help. That is something which we always have to keep in mind, and we can even start the infusion of this drug.
Yes, ma'am.
So what is the dose of infusion of this drug?
Ma'am, 5 microgram per kg per minute.
It is basically, if you're giving much lower dosage than this, say if you're giving just 0.5 to 1 microgram per kg, so what is the effect that it will antagonize? Will it be helpful for respiratory depression?
Ma'am, low doses of naloxone can be given to antagonize naloxone opioid-induced side effects like pruritus. Ma'am.
Pruritus. Sometimes pruritus can be very troublesome for the patients. So these smaller dosages that you give, they will antagonize specifically only the pruritus effect, whereas the sedation effect, the analgesic effect, that will stay. So that is why we are making use of the lower dosage. And what is it if suppose you have given it to an addict? So what is it that you have to take care of?
Ma'am, naloxone can precipitate withdrawal, acute withdrawal when given to patients who are to addicts. Ma'am.
So whenever you are giving to addicts, please be prepared for taking care of the opioid withdrawals. Sometimes. So this has got a place in opioid poisoning. This is the drug which is supposed to be given for opioid poisoning, and in fact, in according to HA guidelines, the new 2020 HA guidelines, there's a separate algorithm for this which has been added to it. So please remember this drug, how to use it, what dosages to be used, and proper dosaging. Only just one dosage will not be sufficient because it acts only for 30 minutes, and further dosage of further infusions or repeated dosages will be given. So what about naltrexone? How is it different from naloxone, Dr. Sandra?
Ma'am, naltrexone is different from naloxone in the fact that it can be orally administered and it has a much higher duration of action than naloxone.
Yes, it has got a half-life of 24 hours. So it is good for using where in addicts oral dosing can be given. Okay. Thank you, Dr. Sandra. You have covered our many drugs and antagonists with it. Thank you so much. Very well done.
Thank you.
Okay.
Thank you, ma'am, for comprehensively covering all these important drugs. There are a few questions, ma'am. First question is from Dr. Mansi. What are the equivalent IV doses of morphine and fentanyl?
Should I take the question, Dr. Deva?
Yes, ma'am, please.
So the equivalent doses are 10 milligrams of morphine. As you know, fentanyl is about 80 to 100 times more potent than morphine. So typically a 10 milligram dose of morphine would be equivalent to 100 mics of fentanyl. That is for parenteral route. And via intrathecal route, it's 4 times as potent as morphine. I hope that answers the question. Do we have any more?
Yes, ma'am. There's another question from Dr. Mansi. Okay. How do you manage wooden chest syndrome?
Okay, so wooden chest syndrome is the chest wall rigidity, which is caused by giving fentanyl. Generally, it is in patients who are elderly, more than 60 years, who are on antidepressants or in Parkinson's disease. So one has to remember, one can anticipate in such patients that you have to give it slow IV, okay, rather than giving it as a bolus. And in if emergency situation one is not able to ventilate such a scenario, you can, if the mass ventilation you think is okay, this is not a difficult airway, one can proceed to give short acting neuromuscular blockade also earlier than you can give it immediate. And if you do not have that on hand and you can in a situation with dire emergency, you can also use naloxone. The dose will be 0.2. You can repeat it after 2 minutes until you can ventilate the patient. I think, do you want to add anything, ma'am? Or do we have any more questions?
There's one more question from Dr. Avinash.
Okay.
He's saying that by giving opioids intrathecally, whether it increases duration or density of local anesthesia.
Typically, in the textbook, this has been mentioned that by giving opioids in the intrathecally, the quality of analgesia typically increases. This is because, and also because in surgeries, the motor part, the sympathetic block, all those side effects of local anesthetics can be decreased if you're giving opioid, and the density is also increased. But there are various studies which also tell that the duration is also increased. Nija ma'am, do you want to clarify on this?
No, Dr. Anu has covered up everything comprehensively. And you are all our students, our postgraduates. We are happy to answer the questions during the lunch session. Thank you so much. We are anyhow running behind schedule. So Dr. Devang, I would request you to kindly shift to take over now. Thank you. Thank you.
Thank you, ma'am. Next on today's agenda is a short case presentation on a pediatric patient posted for squint surgery. The session will be conducted by Dr. Smita Prakash, consultant anesthesia, Vardhan Mahavir Medical College and Safdarjung Hospital, New Delhi. Her areas of interest are research, difficult airway, pediatric and obstetric anesthesia. Case will be presented by our final year PG, Dr. Pankaj Kumar. Over to you, ma'am. Ma'am, would you kindly unmute yourself?
Thank you, Dr. Devang. Good morning, everyone. We'll now start with the anesthetic management of a case posted for strabismus surgery. Dr. Pankaj, you may start with the
Good morning, ma'am.
examination. Good morning, everyone. Please start with the relevant history and examination. Dr. Pankaj, is there an issue?
Hello. Good morning, ma'am.
Good morning, Dr. Pankaj. Please start. We have lost 4 minutes.
Good morning, everyone. I'm presenting the case of a 5-year-old male child, resident of Vikaspuri, New Delhi, brought to the hospital with the chief complaint of deviation of the right eye since 3.5 years and defective vision 3.5 years. And history of present illness, as informed by the mother, the child was apparently normal 3.5 years back when she noticed outward deviation of the right eye, which was gradual in onset. And the deviation is constant since 3.5 years and is associated with defective vision, which is gradually increasing. There is no history of headache, abnormal eye movement, drooping of doubling of vision, blurring of vision, seizure, fever, trauma to the eye, drooping of eyelid, and difficulty in walking. There is no history of repeated chest infection, no history of synovial spell, recurrent upper respiratory tract infection, pneumonia, jaundice. There is no history of head trauma, annular surgery, hydrocephalus, and meningomyelocele. And no positive history of COVID-19 infection or any hospital admission during the COVID-19 pandemic. Antenatal history was uneventful. There is no history of maternal smoking. The childbirth history, full-term normal vaginal delivery at hospital, cried immediately after birth. Birth weight was 2.6 kilograms. There is no history of NICU admission. Child was normal developmental and milestone for age, fully vaccinated till date. There's no similar history in the parents and siblings. On examination, the weight of child is 15 kilograms, afebrile to touch, pulse rate is 19 beats per minute, regular in the blood pressure is 84 by 56 millimeter of mercury taken in the left upper arm, respiratory rate 20 per minute. There is no pallor, icterus, cyanosis, clubbing, pedal edema, and lymphadenopathy. The systemic examination and airway examination is within normal limit. On ocular examination, head posture is slightly deviated towards the right side, facial symmetry maintained, eyebrows, eyelid, conjunctiva, cornea sclera normal on the both the sides, and visual acuity is 6 by 18 in the right eye and a 6 by 6 in the left eye. Pupils are normal in size and reacting to light on the both the sides. On Hertzberg corneal light reflex test, in the left eye, there was corneal light reflex present in the center of the pupil, and the right eye corneal light reflex present on the medial side of the limbus.
Please summarize.
A 5-year-old male child with the complaint of outward deviation of the right eye and defective vision without any congenital anomaly, diagnosed to be a case of right eye divergent squint.
Okay. Dr. Pankaj, why did you ask for a past history of head trauma in this patient?
Ma'am, head trauma can lead to the injury to the orbit, eye muscle, or the nerve, which supply the ocular muscle, which causes the in later cause squint, ma'am.
Okay. And why is evaluation of the airway and cardiovascular system especially important in a child with strabismus?
Because ma'am, some syndromes like Down syndrome.
So please ask the participants to unmute themselves, to mute themselves. Thank you. Carry on, Dr. Pankaj.
Some syndromes like Down syndrome, Turner syndrome, DiGeorge syndrome, and Chart syndrome, this child may have squint. Along with that, there is facial structure deformity may be present, or in this patient, airway may be difficult. Moreover, moreover, cardiac defect also may be present, ma'am, in such children's, ma'am. So the airway evaluation and cardiac evaluation is very important in this child's, ma'am.
Okay, so your child has strabismus of the right eye. So how do you define what is strabismus or what is squint?
Ma'am, squint is the misalignment of the visual axis of the one eye with respect to the other eye, which cannot be voluntarily corrected, and which causes a loss of binocular vision and amblyopia.
Okay, so can you just enumerate the types of squint?
Ma'am, there's 4 types of squint. There's esotropia. In this, there is inward deviation of the eye, and exotropia, there is outward deviation of the eye, and hypertropia, there is upward deviation of the eye, and hypertropia, there is downward deviation of the eye.
Okay. So you mentioned in your definition about amblyopia. What is that?
Ma'am, this is the decrease in the visual acuity due to the decrease in the eyesight due to the abnormal visual development in the structurally normal eye, ma'am.
So amblyopia is loss of vision in a structurally normal eye. Okay. So if you can describe the visual development process, Dr. Pankaj, then we'll understand why this occurs.
Ma'am, usually the orthoptic alignment occurs by the age of 1 month, ma'am, and thus the combination of image by the brain, combination of both the images by the brain as a 3D single vision is occur by the age of 1 year, ma'am.
Carry on, please. See, like Dr. Pankaj said, that orthoptic alignment of the eyes occurs by the age of 1 month. Then what happens is that the brain combines the 2 images, one from each eye, into a single 3-dimensional image, and this enables binocular vision. So this visual development, which results in the brain learning to interpret signals from an eye, occurs during the first 7 or 8 years of life. So Dr. Pankaj, why is it important to correct squint in a child?
Because of the ma'am, the brain receive the images from both the eyes, one from the normal eye and one from the affected eye, ma'am. So the brain spreads the image formed by the weaker eye, ma'am. So the visual axis development is slowed down in the normal eye. So it's very important to correct the amblyopia by the age of 7 to 10 years, ma'am. Correct the squint by the age of 7 to 8 years.
Okay. I will just correct you a little bit here. In children, because two different images are being formed, one from each eye, the brain may suppress the image from the weaker eye, and this impairs visual development and may result in amblyopia. Okay, but the prognosis is good if the correction of strabismus is done as early as possible before the child reaches the age of 8 years. 10 years would be a bit too late. Okay, Dr. Pankaj?
Yes, ma'am.
Amblyopia occur in an adult?
Yes, ma'am.
Usually amblyopia occurs in a child because in an adult, the strabismus usually causes diplopia. It doesn't cause amblyopia because the brain cannot suppress the overlapping images.
Okay, ma'am.
The child, the brain can still suppress the images which are being transmitted to it by the two eyes. Okay, so in adults, you will have diplopia.
Yes, ma'am.
Can you tell us something about the relevant anatomical aspects of the eye for corrective strabismus surgery?
Ma'am, there's the orbital anatomy. There's, ma'am, 4 recti muscles and the 2 oblique muscles. For the horizontal movement of the eye, there's 2 recti muscles like middle rectus. For the vertical movement of superior rectus and inferior rectus, and oblique muscle which coordinate oblique torsion of the eye, in which it is superior oblique and by the inferior oblique muscle.
Okay, and just briefly, the nerve supply to these muscles?
Ma'am, all these extraocular muscles are supplied by the oculomotor nerve except the lateral rectus and the superior oblique. Lateral rectus, which is supplied by the abducens nerve, and superior oblique by the trochlear nerve.
What else does the oculomotor nerves innervate besides the muscle, these muscles which you mentioned?
Sorry, ma'am.
Which other muscle does the oculomotor nerve innervate besides these extraocular muscles you told us about? It innervates the levator palpebrae superioris also, right? And it gives parasympathetic innervation to the pupillary sphincter, so it's responsible for meiosis, and it also is responsible for accommodation because it supplies the ciliary muscles. Okay?
Yes, ma'am.
Dr. Pankaj, you asked for a history of previous surgery of anesthesia and surgery. So is there an association between strabismus and malignant hypothermia?
Ma'am, in previously, squint surgery was thought to be a risk factor for the malignant hyperthermia. But in recent studies, it has been found that there is no correlation between the squint surgery and malignant hyperthermia.
Yes. Previously, it was considered as a risk factor, but now there was a review of over 2,500 patients who were tested for malignant hypothermia susceptibility, and no association with strabismus was found. And another point in favor of there being no association is that it's common practice to use volatile anesthetic agents in children having strabismus surgery, and there's no increase in the incidence of malignant hypothermia. Okay, but what about the occurrence of spasm in patients with strabismus?
Ma'am, it has been found that if the scoline is used, ma'am, at the time of induction in these patients, ma'am, so ma'am, it can cause masseter muscle spasm. So ma'am, brief rigidity for 20 to 30 seconds after the scoline induction is a normal response. But if the rigidity is more than 1 minute, then it is abnormal. So ma'am,
okay. Yes. So just to summarize, there does not appear to be an association between strabismus and malignant hypothermia. However, if masseter muscle spasm occurs in a patient, particularly in a young child, it is important to recognize that the patient may be susceptible to developing malignant hypothermia. That's why it's important to take a detailed anesthetic family history. Okay?
Yes, ma'am.
The goals of treatment in strabismus.
Ma'am, first of all, we have to cosmetic reason. Secondly, to improve the visual acuity. Third, to
Yes.
prevent the amblyopia. And fourth, to achieve the binocular vision with single image.
Great, very nice. So what treatment options do we have? Can you just enumerate them briefly?
Ma'am, we can use spectacles to correct the refractory error in the child, and orthoptic exercises to strengthen the ocular muscles, and occlusion therapy. By occlusion, the normal eye a patch for a couple of hours in a day, so that the affected eye is forced to work, ma'am. And injection, botulinum injection can be given to paralyze the overactive muscle. And there's ma'am some surgical treatment also, like ma'am resection and transposition. In resection surgery, ma'am, we weaken the muscle action by moving its insertion more posteriorly. And in the resection, ma'am, we strengthen the muscle by eliminating a piece of muscle, ma'am. In transposition, we altering the action of muscle by reattaching the muscle at a new location, ma'am.
Okay, great. You mentioned occlusion therapy, and you also mentioned botulinum toxin, which are therapies for treatment of strabismus, but usually they are not done in children. They are done in adults. But yes, we have enumerated all the options which are there for in the management of strabismus surgery. So while we're here, can you tell us what is adjustable suture strabismus surgery?
Ma'am, adjustable suture strabismus surgery usually done in adults, ma'am. This is usually done in 2 steps, ma'am. And the first step under the general anesthesia, and second is under the local anesthesia. In the first step, a adjustable or a sliding knot is taken in one or more the ocular muscle, ma'am, to weaken or strengthening the muscle activity, ma'am. In the second step, which is done under the local anesthesia, the eye alignment is checked by the ophthalmologist after the few days after the surgery. If there is undercorrection, though sliding knot can be tightened, ma'am. Or if there is overcorrection, the sliding knot can be loosened, ma'am.
Right. So coming to the case, what investigations would you like to do in your patient?
Ma'am, complete blood count and urine complete examination.
All right. Any special investigations?
Ma'am, echocardiography to rule out any congenital heart anomaly, and MRI to rule out any CNS infection, any congenital CNS anomalies, ma'am.
Yes, because space-occupying lesions can also be a cause of strabismus, but only when indicated will these special investigations be done. Otherwise, complete blood count and urine examination are enough. What are the anesthetic concerns in strabismus surgery? Can you just enumerate them, Dr. Pankaj?
Ma'am, there is a risk factor of the reflexes like oculocardiac reflex, oculorespiratory reflex, oculoemetic reflex, ma'am. And increased chances of cost of nausea, vomiting. If patient having any symptom, they with difficult airway, and systemic absorption of ophthalmic drugs, and smooth emergence without coughing.
Plus the pediatric concern, the child, right?
Yes,
very good. So let's start with these reflexes one by one. Let's deal with them one by one. Now, what is oculocardiac reflex?
Ma'am, this is a trigeminal vagal reflex which causes bradycardia, dysrhythmias, asystole, secondary to stretch on the extraocular muscle.
Okay. So can you tell me another name for it?
Ma'am, it's also known as Ashner's reflex.
Very good. So oculocardiac reflex, how much percentage decrease or increase in heart rate is considered as oculocardiac reflex?
Ma'am, 20% decrease from the baseline parameters, ma'am.
Some books say 10%, some say 20%. So it's 10 to 20% decrease in the resting heart rate that is sustained for 5 seconds or longer.
Yes.
Okay. And it decreases with repeated stimulation. What is that called? Fatigue, right? If the surgeon repeatedly stimulates the muscle, the incidence of ocular cardiac reflex decreases. This is known as fatigue. Okay. And the incidence is, how much is the incidence in children?
Ma'am, 80 to 86%, ma'am. And in
rather high. Yeah.
Yes, ma'am.
What are the manifestations of ocular cardiac reflex? What will you see on the ECG?
Ma'am, there may be sinus bradycardia, dysrhythmia, or multifocal ventricular premature complexes, ventricular tachycardia, ventricular fibrillation, or there may be asystole.
Okay, and atrioventricular blocks can also be there.
Yes, ma'am.
Supposing this is under anesthesia, we can observe. Supposing if in adult the case is being done under local anesthesia, what are the other manifestations of oculocardiac reflex?
And there may be adult may complain of dizziness, lightheadedness, or
nausea.
nausea.
Of nausea. That's right. So, what is the significance of oculocardiac reflex in children?
Ma'am, it may be associated with increased chance of oculoemetic reflex, ma'am, also.
Okay. Main thing is it needs to be, we have to be very vigilant about it, because bradycardia can lead to hypotension in children because the cardiac output is dependent on the heart rate, right? Okay. So just tell the risk factors for oculocardiac reflex.
Ma'am, any traction on the extraocular muscles and the duration of stimulus on the extraocular muscle, any traction on the ocular remnant following the enucleation surgery, hypoxia, hypercarbia, light plane of anesthesia, or raised intraocular pressure.
Okay. Can you just enumerate some other situations in which the reflex can be triggered besides strabismus surgery? One you mentioned.
Orbital trauma, severe, or it may also occur in retro after the retrobulbar block, or and severe eye pain, ma'am.
Yes.
And orbital hematoma, ma'am.
Orbital hematoma, and it can also be seen in maxillofacial and endoscopic sinus surgeries as well.
Yes.
Aminovagal reflex. Okay.
Yes, ma'am.
So how will you manage this intraoperatively?
Ma'am, first of all, I will ask the surgeon to stop the manipulation, and I will provide adequate oxygenation, and I will deepen the plane of anesthesia. If after all that, if there is no response in the to correction of in the bradycardia, ma'am, then I will give intravenous atropine 20 mics per kg, ma'am.
All right. So when is it safe to proceed with surgery after oculocardiac reflex? You have given atropine.
Yes, ma'am.
When will you tell the surgeon to restart?
Ma'am, when the parameters are within normal.
You can start the surgery once the normal sinus rhythm with the rate within 10% of baseline has been achieved. Okay.
Yes, ma'am.
Is there any way oculocardiac reflex can be prevented? Any drug pharmacologically?
Ma'am, injection glycopyrrolate 10 mics per kg can be given before the manipulation of the extraocular muscle.
Okay. And previously what was happening was most pediatric patients, but not adults, were given prophylactic atropine 20 micrograms per kg or glycopyrrolate, like you said, 10 micrograms per kg, because it causes less pronounced tachycardia.
Yes, ma'am.
Given after induction and before manipulation of the muscles.
Yes, ma'am.
Incidence of oculocardiac reflex really decreased to 5% with glycopyrrolate and 2% with atropine. But now we don't, this is not a practice anymore, because with the cooperation of the ophthalmic surgeons and gentle traction on the extraocular muscles, this is usually not required, because intravenous anticholinergics can themselves lead to dysrhythmias. And however, if it is important to have these drugs drawn up and ready to administer if bradycardia occurs. Okay, they can be ready on the trolley for immediate use.
Yes, ma'am.
Can you just describe the reflex pathway for oculocardiac reflex? You have a slide for that.
Ma'am, any stimulus on the extraocular muscle, which stretch receptor is present on the extraocular muscle, which stimulate the short and long ciliary nerves, then via they will go to the ciliary ganglion, and from there, ma'am, ophthalmic branch of the trigeminal nerve, they will go to the Giserian ganglion, and from there it goes into the sensory nucleus of trigeminal nerve. Then it go to the motor nucleus of vagus nerve, and it stimulate the muscarinic receptor present on the heart, and act on the SA node of the head in causes bradycardia and dysrhythmias.
Yes, it acts on the SA node, causing bradycardia, and also decreases the conduction in the atrioventricular node. Is there a role of retrobulbar or peribulbar block in preventing oculocardic reflex?
Yes, ma'am. These block also effective to decrease the chances of OCR, because ma'am these blocks block the pathway of afferent arc, ma'am. So usually, ma'am, these blocks are not indicated in children due to the high chances of globe perforation, ma'am.
Yes. So which muscle is most often affected in strabismus surgery?
Ma'am, medial rectus.
It can cause OCR.
Medial rectus.
Why is that so?
Ma'am, because this is the most commonly first muscle manipulated during the strabismus surgery, and this is more sensitive and more flexogenic as compared to the other muscles, ma'am. Secondly, this is less accessible and require more force to get exposed.
Okay, I'll just correct you here a little bit, Dr. Pankaj. The medial rectus has shown more resistance to fatigue regarding OCR, but it is just as reflexogenic as the other extraocular muscles if they're exposed to the same stimulus. Okay, so it is not more reflexogenic, but OCR incidence is higher because it is the most manipulated muscle and it is less accessible and requires more force for exposure that you've already mentioned.
Yes, ma'am.
Okay. Now let us come to briefly to oculo-respiratory reflex and what is its significance.
Ma'am, in oculo-respiratory reflex, in this, there is a decrease in the tidal volume and respiratory rate because of the stretch on the extraocular muscles, ma'am.
Okay. So can you describe the pathway?
Ma'am, any stretch on the extraocular muscle, the afferent pathway via the short and the long ciliary nerves, via the trigeminal nerve, then the afferent pathways from the pneumotaxic center in the pons and medullary respiratory center, and via the phrenic nerve, ma'am. This will cause irregular shallow breathing and respiratory arrest.
So what's the significance of this, knowing this reflex?
Ma'am, there is more chances of hypoventilation and hypercarbia on spontaneous mode of ventilation. So the control mode of ventilation is required to avoid the oculo-respiratory reflex.
Okay. The incidence of postoperative nausea and vomiting is 50 to 80% following strabismus surgery. So what is the cause of this high incidence?
Ma'am, oculoemetic exact mechanism is not known, but the oculoemetic reflex may be a cause for post-op nausea and vomiting.
Okay, can you tell us briefly about how this pathway works?
Ma'am, oculogastric reflex, when impulses from the extraocular muscle travel to the vestibular nuclei of third, fourth, and fifth cranial nerve, then these go to the medial longitudinal fasciculi in the reticular formation, which lie in the close proximity to the vomiting center. Then it causes nausea and vomiting.
So how can we decrease the incidence of post-operative vomiting in the children undergoing strabismus surgery?
Ma'am, by maintaining the adequate oxygenation, adequate hydration, and minimum use of opioid and nitrous oxide, and maintenance of anesthesia with propofol, and by giving the combination of antiemetic drugs like injection ondansetron 0.1 mg per kg and injection dexamethasone 0.15 mg per kg, ma'am.
All right. You always say we have to maintain pneumoxia, right?
Yes, ma'am.
Yeah, hypoxemia is not an option in any case. In any case, whether it is strabismus surgery or non-strabismus surgery, right? We have to maintain pneumoxia. Okay. Did you mention minimum use of opioids?
Yes, ma'am. Minimum use of opioids.
You did. Very good. All right. So now we have dealt with the various concerns that we can encounter in the anesthetic management of this case, right? So what preoperative instructions will you write for this case?
Ma'am, I will advise for NPO for more than 6 hours for solid fluids, for 4 hours for semi-solid, and 2 hours for clear fluid, ma'am. And written informed consent from the child parents. And syrup midazolam 0.5 mg per kg orally 30 minutes prior to the surgery. And I will advise to apply the amla cream on the hand and occlusive dressing over it, and handle the child with care.
Yeah, because this child has poor vision, they should be handled in a careful and very sensitive manner. Okay.
Yes, ma'am.
So what anesthetic technique do you plan?
Ma'am, I will go for general anesthesia under LMA insertion with control mode of ventilation, ma'am.
Okay. So let us say the child is in the preoperative holding area and he's on the list now. So please proceed. How will you proceed with the anesthetic management?
Ma'am, a child is in the pre-op area, ma'am, I will confirm the NPO status from the child parents, and also to ask for the whether the amla cream is applied over the hand. Then I will secure the IV cannula in the pre-op room when child is with the parents, ma'am. Then I will take the patient in the OT. Then I will attach all the ASC monitors like ECG, pulse oximeter, and non-invasive blood pressure, ma'am. Then I will give induction agents like injection fentanyl 2 mics per kg and injection propofol 2 mg per kg and injection atracurium 0.5 mg per kg. Then I will put a flexible LMA of adequate size, and I will keep the patient on control mode of ventilation. And during the
what would be the adequate size for this patient?
Ma'am, 2.
Size 2. Okay. What if flexible LMA is not available?
We can go for and cuff endotracheal tube.
Can we use Procel LMA for this patient?
Ma'am, we can use, but usually, ma'am, it's
because flexible LMA may not be available in all institutions.
Yes, ma'am.
Besides, it doesn't have a gastric channel as well.
Yes, ma'am.
So if can't we use Procel LMA, which is very easily available, or iGel LMA?
Ma'am, we can use, ma'am.
We can use. If your plan is to use, because you told me that you're going to use general anesthesia with controlled ventilation using LMA. If you can use Procel LMA as well. Okay. Please carry on.
Then, ma'am, I will provide good analgesia by giving injection paracetamol during the intraoperative period at the dose of 15 milligrams per kg and injection ketorolac 0.5 mg per kg.
Dr. Pankaj, please proceed one by one. We have started the case.
Also, I will give him antiemetic drugs.
Please proceed as if you were doing the case. Don't tell me drugs that you'll give this after induction and this is before extubation. We are proceeding with the case. Tell them in a systematic manner. You have done the induction, intravenous induction. You place the Procel LMA or your flexible LMA.
Then I will put the patient on control mode of ventilation.
Yes.
And I will maintain the anesthesia with oxygen, nitrous oxide, and sevoflurane.
All right.
Yes, ma'am. And during the intraoperative period, I also provide good analgesia to the child by giving injection paracetamol by infusion at the dose of 15 mg per kg and injection ketorolac 0.5 mg per kg at the end of surgery, ma'am. And also I will
let us say there's a leak in the LMA.
Yes, ma'am.
And the surgery has not yet started. What will you do?
Ma'am, I will check the position of the LMA, ma'am. Or I will check the LMA to see the adequate ventilation is there or not, ma'am.
So if there's any concern with airway patency with laryngeal mask airway, it should be changed to a tracheal tube before surgery starts, because manipulation or exchange of the airway device in the middle of the operation can contaminate the field. So if it is not working well, it is not seated well, it's better to convert to a tracheal tube. institutions, they will do the case under controlled ventilation using a tracheal tube, right? Because when you're using an LMA, it is standing up like a flag.
Yes, ma'am.
But because the surgeon is standing at the head end of the child, it may not hamper his movements so much. But in cataract surgery, it could, because it's standing on the side of the patient.
Yes, ma'am.
So, what about the fixation of the tracheal tube or proceed LMA?
Sorry, ma'am.
What about the connection or the fixation of the airway device? Is that important?
Ma'am, we have to fix the LMA away from the surgical field, ma'am.
The fixation has to be really, trustworthy, right? Because everything will go under the drapes. So you have to be sure that your tracheal tube which you have fixed or the proceed LMA which is fixed doesn't get
Displacement.
Displaced. Okay. Why did you choose LMA over a tracheal tube? What is the advantage?
Ma'am, reduce hemodynamic response of laryngoscopy and intubation, and reduce coughing and straining on extubation.
Very good. You mentioned controlled ventilation. Can't we use spontaneous ventilation for this case?
No, ma'am, because there's high chances of hypercarbia and hypoxia. So, ma'am, it also increases the chances of oculocardiac reflex.
So one could use spontaneous ventilation if you're using pressure support ventilation. Okay, that will maintain normal carbia.
Yes, ma'am.
What about maintenance of anesthesia?
Ma'am, oxygen and nitrous oxide and sevoflurane.
Okay. Would you like to use nitrous oxide? Or
yes,
can somebody say why are you using nitrous oxide?
Ma'am, we can use nitrous oxide in children because there's less chances of post of nausea vomiting in children. So,
okay.
Ma'am, we can use.
One could use because the incidence of nitrous oxide and postoperative vomiting is less so in children as compared to the adults. However, if the air is available, oxygen, air, and sevoflurane can also be used.
Yes, ma'am.
When will you avoid nitrous oxide in ophthalmic surgery? Ophthalmic surgery, I'm saying, not strabismus.
Ma'am, when there's glaucoma surgery, ma'am. When there's
okay, and whenever any inert gas is injected in the eye, right?
Yes,
hexafluoride, then you will not use, it's contraindicated. Yes, you mentioned you will provide intraoperative analgesia with the paracetamol and you wanted to give ketorolac half an hour before the anticipated closure, right?
Yes, ma'am.
Any regional block you can give?
Ma'am, we can give subtenance block.
Subtenance block. What is subtenance block?
Ma'am,
what are the advantages of giving subtenance block?
Ma'am, subtenon block is usually given at a conjunctival incision is given, ma'am, 2 to 3 mm, halfway between the inferior limbus and the fornix, ma'am, to open the subtenon space, ma'am. Then, ma'am, blunt cannula or needle is inserted in the posterior subtenon space. And after the negative aspiration, ma'am, we can inject the drug, ma'am. 2 to 3 ml of drug is local anesthetic drug is injected in this space. And advantage of this block, ma'am, as this increase the chances of OCR, ma'am, and decrease chance of post of nausea and vomiting, and also provide good analgesia in the post-operative period, ma'am.
Right. Okay. You forgot, Dr. Pankaj, to give an important drug which would be especially indicated in strabismus surgery after induction. Can you recall what that would be? Something to do with post-operative vomiting.
Injection dexamethasone can be given 0.15 mg per kg, ma'am. After the
can be given, you will give it.
Yes, ma'am, I will give.
Because we talked about combined antiemetic therapy with dexamethasone as well.
Injection ondansetron, ma'am.
Yes. So what dose are you going to give it after induction?
Ma'am, dexamethasone given at a dose of 0.15 mg per kg just after the induction, and ondansetron 0.1 mg per kg before the end of surgery, ma'am.
All right. Okay, the surgery has been completed now. And how will you extubate or remove the LMA?
Ma'am, I will reverse the neuromuscular blocking agent actions by giving injection neostigmine at a dose of 15 micrograms per kg and injection glycopyrrolate 10 micrograms per kg. Then I will, ma'am, when the patient, I will watch for the respiratory efforts, and if child is following all the commands, ma'am, then I will remove the LMA and switch off all the gases.
You will switch off all the gases, and then when the child is awake, you're going
Yes, ma'am.
to
Maintain
remove
the
the
patient.
LMA. Okay. So how will you manage the case post-operatively?
Ma'am, post-operatively, I will see for post of nausea, vomiting, and post of anesthesia, ma'am. Or if there's, ma'am, in post-op case there's, ma'am, nausea and vomiting, then I will give injection metoclopramide at a dose of 0.1 mg per kg.
Okay. What will you do for analgesia?
We can give, ma'am, ketorolac eye drops.
Okay.
And injection paracetamol at a dose of 15 mg per kg.
How much?
15 mg per kg.
Paracetamol, you've already given it. After 4 hours or 5 hours, the child can take orally, right? You can give oral paracetamol, or you can give oral ibuprofen as well, 10 milligrams per kg.
Yes, ma'am.
Okay. And you also given subtendons block. So you asked the surgeon to give subtendons block. So that should take care of the analgesia. What kind of pain is there after strabismus surgery post-operatively? Is it mild? Is it moderate? Is it severe?
Ma'am, sorry, ma'am. Can you repeat the question?
How much pain does the patient have? Is it have post-operatively after strabismus surgery? Is it mild? Is it moderate? Is it severe?
Ma'am, maybe mild.
No, it is not mild. Mild pain is after cataract surgery. It is moderate in intensity, and therefore the analgesics, and it can last from 1 to 9 days. So analgesics should be prescribed for a minimum of 3 days at least.
Yes, ma'am.
And the child should be nursed in a comfortable position with a parent in the post-operative room.
Yes, ma'am.
Okay.
Yes, ma'am.
Just we should know about forced duction test. What is forced duction test?
Ma'am, this test is usually done to differentiate between the paralytic squint and the restrictive type of squint, in which the ophthalmologist, ma'am, hold this grasp the sclera and move the eye in the each field of gaze to know the, ma'am, exact location of paralytic or restrictive type of squint, ma'am.
So do you need to give neuromuscular blocking agent for this?
Yes, ma'am.
Yes, the surgeon will request you to give a neuromuscular blocking agent. But what is the role of suxamethonium? This is just a theoretical thing, because you're no longer using suxamethonium in children for elective cases, right?
Ma'am, usually this test cannot be performed after giving the succinyl choline, because it causes the, prolonged depolarization and contraction of the extraocular muscle. So it will be performed after the 20 minutes if we will give suxamethonium.
If for some reason, if the child is syndromic and we wanted to use suxamethonium for a difficult airway, then forced duction test should be done after 20 minutes to get the correct results.
Yes, ma'am.
Okay. Thank you so much, Dr. Pankaj, for your presentation and good answers to all the questions. And also, Dr. Jyoti has helped a lot in the preparation of this case posted for squint. I thank Dr. Jyoti as well. If there are any questions, I would like to take them.
Thank you, ma'am. There is a question, ma'am, from Dr. Sanjay Prakash.
Yes.
Do we have to give injection glycopyrrolate prophylactically to prevent oculocardiac reflex in adults also?
No, leave alone adults, not even give prophylactically in children, because it may or may not occur. By gentle handling of the muscles, the incidence can be decreased. And if it occurs, we have this drugs drawn up, glycopyrrolate or atropine, and it can be administered and will act in 10 to 20 seconds. So prophylactically, we are not giving. Especially it has the disadvantages in adults. Anticholinergic agents, it can cause dysrhythmia while giving it itself. And in the hot environment of summers, it can cause hyperpyrexia as well. So we're not giving it prophylactically, but we are prepared to inject it immediately when required. Are there any other questions?
Right, ma'am. There are no other questions. Thank you, ma'am, for this informative discussion. I'm sure the delegates will now be better prepared with this case. Thank you, ma'am. Now it is time for a quick quiz. So the questions are: controlled preeclampsia without any severe features would be categorized as which ASA physical status class? Would it be A, ASA class 1, B, ASA class 2, C, ASA class 3, or D, ASA class 4? And second question is, which of the following drugs is most likely to cause tachycardia? A, fentanyl, B, meperidine, C, morphine, or D, sufentanil? Kindly put in your answers in the chat box. Moving on now, I would now like to invite Dr. Jayashree Sood to chair this next session. Dr. Jayashree ma'am is Chairperson, Department of Anesthesiology, Pain and Perioperative Medicine, Sagangaram Hospital, New Delhi. Her areas of interest include anesthesia for transplant, thoracic and laparoscopic surgeries, and pain management. She has received multiple awards and accolades. I welcome you, ma'am. Jayashree ma'am, would you please unmute yourself? I think Jayashree ma'am is having some connection issues.
Madam is coming. Just. Madam is coming. Just wait a minute.
Yes, sir. Yes.
Good morning. Hello. Good morning, ma'am. Devang, can you hear me?
Yes, ma'am. You're audible, ma'am.
Good morning, everybody. And sorry for this little delay. Just rushed from the OT. Would like to congratulate Dr. Kaur and her team for this excellent CME that she has conducted all these days. Congratulations. And I am so happy that you've asked me to chair this these lectures today, in which there are two luminaries, Dr. Sunanda and Dr. Pradeep Jain. Dr. Sunanda needs no introduction at all. When you talk about obstetrics, whether it is India or abroad, Sunanda's name comes. So I'm so happy I'm chairing this session. And she is in Udaipur. She is heading the department in Gitanjali Medical College. And of course, her area of interest, I mean, she is an expert in so many fields, but obstetrics is her heart is all in obstetrics. So thank you and welcome, Sunanda ji. And you will be talking about anemia, such an important aspect, especially in our country. Yes, Sunanda, please. We are very keen to hear your lecture.
Good day to all the organizers, dear students and delegates. At the outset, I thank Dr. Kaur and her team for this excellent yearly PG learning sessions and for providing me an excellent platform to interact with you all. So today we are going to understand what are our concerns when an anemic participant is referred to us for labor analgesia or operative delivery. And apart from our practical concerns, this is a topic which is invariably asked during the postgraduate exams when you get a long case for a pregnant woman. As in our country, nearly 38% of our parturients suffer from anemia, and iron deficiency anemia constitutes about 15 to 18% of the total population. So before we start, I bring to you greetings from my medical college, Geetanjali Medical College and Hospital, situated in Udaipur, surrounded by the beautiful Aravalli mountain range. It has about 1,200 beds, and it's all the super specialties are present here. So what to expect in the next 30 minutes or so? We'll look at the current definition, what is the pathophysiology, especially regarding oxygen delivery and iron metabolism. We'll look at acute and chronic anemia and then talk about 3 case reports along with its management. And to wind up, we'll have a take-home message. So if you look at the world figures, anemia and pregnancy makes up about 38% of the total pregnant women worldwide, and iron deficiency anemia is about 15 to 18%, and most of this is concentrated in countries like South Asia, Central and West Africa, and nearly more than 50% of these patients are here. If you look at the maternal mortality rates, this is an interesting article which came in Lancet in 2018, and they found that maternal death was nearly up to 3% in the anemic women, while those without severe anemia, the mortality rate was less than 1%. So they concluded that prevention and treatment of anemia during pregnancy and in the postpartum period should remain a global public health and research priority. So how does one define anemia? It comes from the Greek word without blood, and anemia in pregnancy is defined as a hemoglobin level which is less than 10 gram per dl with a qualitative or quantitative deficiency of hemoglobin or red blood cells in the circulation, resulting in reduced oxygen carrying capacity of the blood to tissues and organs. So in the first trimester, the hemoglobin levels fall to less than 11 gram percent, while in the second and third trimester, they go down to 10.5 gram percent. And in the postpartum period, it further reduces to less than 10 gram percent. And in the low resource countries, the cutoff level is somewhere around 10 gram percent. What is the normal requirement in pregnancy? The total iron requirement for normal pregnancy is close to 1 gram. And if you look at the left box, for fetus growth, placental development, and blood loss, which is expected in vaginal delivery, it is somewhere around 500 milligram. On the right box, if you see, the total volume of RBC has increased by 450 ml. So about 1 ml of RBC will contain 1.1 milligram of iron, and this, when calculated, goes up to nearly 500 milligram. And above this, about 1 gram per day is required for lactation. So an average increase occurs from 0.8 milligram per day to 7.5 milligram per day in the third trimester. So another question we ask is, where is iron stored in the body? So remember, 65% is stored as hemoglobin in the hemoglobin in RBC, while in the myoglobin it is up to 10%, and then it is also stored in the liver as ferritin or transferrin, and in the reticuloendothelial system it is stored as in the macrophages. A classification of anemia which has recently come is according to the ICMR. It has been classified right up to the 4th one. That is very severe, means about less than 4 gram percent, and it ranges from 10 to less than 7 gram percent in the WHO classification. So how is iron metabolized in our body? And this is one of the most important steps we need to know in an anemic parturient. So inorganic non-heme iron is predominantly in the ferrous form. Remember, it is in the ferrous form, and to be absorbed, it has to be decreased to the ferric form. And sorry, it is present in the ferric form and it has to be reduced to the ferrous form by brush border ferrireductase. And vitamin C again enhances this process. Now, once inside the enterocyte, the iron is liberated, and this is stored either as ferritin, or it is utilized for cell function, or then it is exported across the basolateral cell membrane by a transmembrane exporter, ferroperatin 1, into the portal circulation. Now, outside the basolateral membrane, this is the basolateral membrane, it is oxidized back to the ferric form. And this is helped by hephaestin and the circulating celluloplasmins. Now, once inside the portal blood, all the iron which is circulating is bound to transferrin, which can bind 1 or 2 molecules of the ferric iron. And 75% of this is transferrin bound. It is bound to the transferrin receptors on the cell membrane, and this complex is internalized as an endosome till it is released, reduced to the ferrous state, and it is used by the mitochondria for formation of hemoglobin and iron sulfur crystals. Now, the liver stores about ferric iron. It stores it in ferritin, and about 1 molecule of ferritin will have about 4,000 molecules of iron. The macrophages, again, they destroy the senescent red blood cells, and they also store the iron as ferritin. Now, hepcidin is one of the majority of that iron regulation at a systemic level is controlled by hepcidin. And it is a peptide hormone which is produced by the hepatocytes. And the major function of this hepcidin is to inhibit the movement of iron into the blood from the hepatocytes, from the macrophages, and from the enterocytes. And so this is how it regulates the amount of iron that is present in the blood. Now, if there is an erythropoietic stimulation, then this hampers the production of hepcidin from the hepatocytes. Now, how does hemoglobin in the RBC act as a transporter of oxygen? Now, hemoglobin is a tetramer, and it consists of 2 alpha chains and 2 beta chains, and each consists of a heme group which combines with 1 oxygen molecule. You can appreciate it here. So 1 heme tetramer will consist of 4 oxygen molecules. This is how oxygen is transported. So in the lungs, there is oxygen loading of the hemoglobin, while in the tissues, the oxygen is released by the hemoglobin. And this is what is appreciated in the oxyhemoglobin curve. We'll talk about it later. So anemia, basically, it is a transportation breakdown where this is because of low hemoglobin levels and low iron levels in the body. So basically, a fine balance has to be created between the oxygen demand and the oxygen consumption, and this depends upon the oxygen delivery. Now, oxygen delivery further depends upon the cardiac output, the total arterial oxygen content, along with the degree of affinity of hemoglobin for oxygen, and the tissue oxygen extraction. So what is Fick's principle and what is its significance here? So apart from the content of oxygen, the hemoglobin and the product 1.34, the saturation of hemoglobin with oxygen, and this product and the PO2 levels. So 1 gram of oxygen, 1 gram of hemoglobin normally carries about 1.34 mil of oxygen, and 15 grams will carry about 19.8 ml. So in a 5-liter blood, there is approximately 1 liter of oxygen that is transported. While if the patient is anemic, it is only 5 gram of hemoglobin. Remember, 100 ml of blood will carry only 6.7 ml of oxygen. So if you want to understand this fixed principle, we'll look at some examples. This is helpful in understanding the oxygen debt, the delivery of oxygen versus the consumption of oxygen. So this is a normal scenario where the cardiac output is 5 liters, hemoglobin is 15, the PaO2 is 80, and you get a delivery of oxygen which is more than 1 liter. Now, supposing the cardiac output is 5, but hemoglobin is, this is a 1 liter delivery of oxygen. But supposing the hemoglobin goes down, it is just 4 gram percent, the cardiac output was maintained. So the delivery of oxygen goes down to 288 mil oxygen per minute. PaO2 is also normal, but then the hemoglobin levels are low. If the cardiac output increases, the hemoglobin is still low, the delivery of oxygen will improve if your cardiac output improves. But if your cardiac output is also low, hemoglobin is also low, you can see the delivery suffers maximally. So what are the compensatory mechanisms in an anemic patient? There's a shift of the oxygen dissociation curve to the right. There's an increase in cardiac output, increase in 2,3 DPG levels in the RBC, increase in P50. The viscosity of blood has to be decreased. There has to be an increase in tissue blood flow, and the erythropoietin stimulus from the kidney to the bone marrow produces additional RBC. So what is the significance of oxygen dissociation curve in anemia? You'll appreciate in the normal scenario, and in an anemic patient, the right shift of the ODC occurs so that is whatever oxygen is available is tried to be delivered to the tissues. So what are the harmful effects on the two lives? According to an article in Lancet 2018, apart from increase in maternal mortality, which we talked about, the patient is fatigued and depressed. There is a chance of cardiac compromise in labor, more chances of puerperal sepsis and delayed wound healing. More effects occur on the fetus. There are increased chances of maternal and perinatal and neonatal mortality, premature delivery, and low birth weight. Apart from this, there is a risk to the developing neural structures, so cognitive dysfunction can occur. Now we look at 3 case reports here. One is the patient is lying comfortably. She has been planned for vaginal delivery, and we have to do a pre-anesthetic evaluation. So you should focus on the history, try to find out what was the reason for this anemia which she is facing. Maybe there is worm infestation or CHF, bleeding. What is the current status? Then complaints, focus on her complaints, tiredness, EC fatigability, breathlessness, dyspnea or palpitations, and routine investigations should include the blood investigations, renal and liver function tests, along with ECG. So if you look at the normal indices in pregnancy, this comes from the American College of Obstetricians and Gynecologists 2021. What we are worried about is, apart from the hemoglobin levels, the serum iron, the total iron binding capacity, the transferrin saturation, the serum ferritin levels, the red cell protoporphyrin. Now, in iron deficiency anemia, what we find is that there is a low hemoglobin with low microcytic hypochromic anemia, along with low plasma iron levels, low serum ferritin, and there's an increase in the free erythrocyte protoporphyrin, and that is because protoporphyrin is a precursor of heme. And since there is no iron, formation of heme is hampered, and the high total iron binding capacity. So with these figures of hemoglobin, serum iron, serum ferritin, and transferrin saturation, she is anemic, and now how will you manage her? And since she's at 28 weeks of gestation. So we start with oral iron. We have the options of parenteral, injectable, human recombinant erythropoietin and blood transfusion. We start with oral iron, and remember it is 100 milligram per day. We give prophylactic, while otherwise we combine it with folic acid. The ferrous salts are given. Rise in hemoglobin expected is 0.8 gram per DL per week. But the GI upset is very common, and so if she has more of GI upset, we'll have to switch over to parenteral therapy. And severe anemia, now pregnant women with severe IDA who present late in pregnancy, who are expected to bleed profusely, all these patients can be taken up for parenteral therapy. So again, what we ask is, what are the latest drugs that we use for parenteral therapy? Feri-inject monofers, and they have low sensitivity and less chances of reactions. Ganzoni formula is another formula which is commonly used in most of the institutions, wherein body weight into the target hemoglobin minus actual hemoglobin into 2.4 plus 10 milligram per kg of the body weight. Along with this, or we give 1000 milligram or 500 milligram for the iron stores. This infusion should be given at a rate of 10 drops per minute and completed in 30 minutes, or you can increase it to 45 drops per minute if you find there is no reaction. And iron dextran or iron sucrose, it's safe with less side effects, but what we need to look at is chest pain, rigors, chills, fall in BP, dyspnea, hemolysis. All this should be making us cautious. So here the hemoglobin rise is 50% in the first week and 75% in the second week. The NATA consensus guidelines, which came in 2018, gives a comprehensive review of this. Oral iron should be 80 to 100 milligram per day, along with folic acid for 400 microgram per day. Parenteral iron should be resorted to in these situations we talked about. And erythropoiesis stimulating agents can be given if there is no response to parenteral iron. And there should be a very low sensitivity to transfusing blood. However, if it is less than, hemoglobin is less than 7 gram percent, or there's late gestation, more than 34 weeks, we need to give transfused blood. But then iron deficiency anemia should not influence the mode and timing of delivery according to the UK guidelines, which came in 2020. So now our hemoglobin levels are better, 9 gram percent, and she wants to go in for a normal labor. So during the first stage, remember, you need to have an individualized plan. You can give an epidural. Oxygen should be given along with it. You should be very careful about the fluid infusions that you give so that you do not send her into pulmonary edema. Steroids, antibiotics, and digitalization if already she is heading for pulmonary edema. In the second stage, it needs to be shortened by forceps. And the third stage, you should do an active management like using uterotonics and early clamping of the umbilical cord extract. You should be aware of PPH and according to the UK guidelines of 2020. In the puerperium, again, rest, iron, and folic acid for 3 months are advocated. The second case report here, the patient is being planned for cesarean section and her hemoglobin is 8 gram percent. So we need to do a preoperative assessment. We have already, in the previous case, we had seen the signs and symptoms, and any sign of high cardiac output, tachycardia, wide pulse pressure, and systolic ejection murmur, all should be noted in your records. A preoperative assessment, investigations, blood grouping for cross-matching, other investigations we talked about should be completed. And here the serum iron is less than 30 microgram per DL, your ferritin is less than 15 microgram per DL, TIBC was 400 microgram, and transferrin saturation was less than 20%, confirming that she's a chronic anemic. So now your choice will depend upon the severity and type of anemia. How much is the physiological compensation? Is there any comorbid condition? And is she along with preeclampsia, or does she have any percreta or any PAS? So remember what we are battling against in the intraoperative period may be uterine inertia, atony, congestive heart failure, PPH, obstetric shock, abruptio placentae, and pulmonary embolism. We need to be very cautious during this period. So a very good monitoring can assess the adequacy of perfusion and oxygenation. Now, non-invasive monitoring, regular 5-para monitoring that we do, and invasive monitoring, apart from the intravenous lines, we should also be recording the SVO2 and the SCVO2, which proves to be a surrogate marker for transfusion requirements. Serial hemoglobin and hematocrit values to monitor the ongoing blood losses. So the choice of anesthesia technique, what are the advantages of regional anesthesia? There's less interference with hemodynamics, especially if we are giving intermittent epidural low dose spinal with adjuvants. And also there's a decrease in blood loss with this. But however, whenever the vascular tone returns, we need to be cautious that hypotension, hemodilation, heart failure, and PPH can occur. With general anesthesia, the advantage is that if there are going to be major blood losses, if she's a comorbid patient, you can manage her better, and especially in symptomatic, severely anemic patients, always resort to general anesthesia. Now, the goals during general anesthesia, whatever you give should be given very slowly and very cautiously. You should avoid hypoxia, hyperventilation, and hypothermia. Remember, hypothermia is going to prevent optimization of the coagulation factors. Pre-oxygenation with 100% oxygen, maintaining the airway. Volatile agents should be used cautiously because they are cardiac depressants. And factors which lead to the left shift of the ODC should be avoided so that adequate tissue perfusion occurs, avoid hyperventilation, and maintain normocapnia. And improvement in the microcirculation will be obtained when you have an increase in systemic oxygen delivery. So minimize any drug-induced decreases in the cardiac output. Intravenous agent should be given very slowly and cautiously. And also be careful while positioning these patients because volume shifts can occur. And don't try to deepen the level of anesthesia because mild tachycardia and wide pulse pressure may be physiological. The third case report is a 28-year-old, 36-week gestation for LSCA. She has had 2 bouts of bleeding at home, and at present her hemoglobin is 5 g/%. So this patient, so why do an article which comes in 2017 in BMC, why women bleed and how they are saved, a cross-sectional study. So they say that a rising cesarean section rate increases not only the number of cesarean sections currently, but adds women with previous cesarean section to those who will become pregnant in future. So we have to be cautious that do not do the cesareans in the first instance. Women with anemia will be twice as likely to need transfusion after cesarean delivery. So what should be our priority? Improve the hemoglobin levels through transfusions in this patient specifically, and we need to prevent tissue ischemia so that multi-organ dysfunction doesn't step in. So adaptations in acute anemia, here the respiration, there is an increase in minute ventilation, and this increase in minute ventilation along with increase in ventilation perfusion matching in that causes increase in PaO2 and SaO2. In the cardiovascular system, there is increase in sympathetic nervous system activity, and hence there's an increase in venous return, decrease in systemic vascular resistance, decrease in blood viscosity, all will help in increasing the cardiac output. And third important factor is the increase in tissue extraction of oxygen, which is helped by the right shift of oxygen dissociation curve. This can be brought about by, and also by increase in tissue blood flow and increase in the capillary recruitment and density. The compensatory mechanisms in acute anemia involves sympathetic stimulation leading to hyperdynamic circulation, redistribution of blood to the vital organs, and there is an increase in osmotic pressure with water and electrolyte conservation. And since aerobic metabolism needs oxygen, anaerobic metabolism is resorted to by the body. An interesting concept where microvascular response to oxygen demand shows us the role of RBC. RBC acts as a mobile sensor, and when the blood reaches areas which have a high demand for oxygen, you find that the oxygen extraction by the tissues where there is high oxygen demand causes a decrease in PO2, and this decrease in PO2 also decreases the saturation of oxygen in the RBC. This leads to an increase in ATP production, and so this erythrocyte produced ATP combines with the pyrogenic receptors on the vessel wall and causes release of vasodilators, which causes retrograde vasodilatation. So this improves the circulation in areas which have a poor supply of tissue where the requirement of oxygen is much higher. So in an acutely hemorrhaging anemic parturient, what are the risks? First of all, acute hemorrhage will reduce the cardiac output. It will bring down the hemoglobin levels to less than 5 gram%, and you tend to infuse large amounts of stored blood, which have a low affinity, or should I say, which have a high affinity for oxygen. So the oxygen delivery is reduced. There is an increase in oxygen extraction. So there's an imbalance and tissue ischemia occurs. So these patients can go in for cardiac failure, pulmonary edema, and MODS. So be very careful while overloading the circulation because they are prone to going for pulmonary edema. Now, in this situation, in this patient, since you are expecting a massive hemorrhage, general anesthesia is preferred. Hemorrhage protocol should be in place. Send your investigations, keep your blood ready, IV lines and intra-arterial lines, and everything ready for your cardiovascular resuscitation. Apart from this, general measures like left uterine displacement, urinary catheter, high flow oxygen, aspiration prophylaxis, a rapid sequence induction, and intermittent mixed venous PVO2 and ABG should be estimated. Avoid hypothermia. All the fluids that you give should be warm. So finally, a take-home message. You need to evaluate extent of activated compensatory mechanisms. Each patient should have an individualized treatment or management protocol. Monitor the adequacy of tissue perfusion and oxygenation. Don't forget that tissue perfusion, if it falls, the patient will go into multi-organ dysfunction syndrome. Anticipate and prevent decompensation, and anesthetic choice will always depend on the individual patient and her clinical and hematological condition. So anemia should never be regarded as an innocent bystander. Thank you.
Thank you so much, Sunanda, for that excellent lecture. No need, I mean, it's just too good. And after listening to your lecture, the students will be able to, of course, understand, plus they should be able to answer each and every question that is asked in the exam. Thanks a lot. Sunanda will be taking the question answers at the end, Devang, am I right?
Yes, ma'am.
Yes, yeah. So now we go. Thank you, Sunanda. And of course, you need to stay on for the question answers. And next, we have another very important lecture, which is going to be given to us by a very eminent personality, Dr. Pradeep Jain. And whenever anything comes to pain management and anything to do with pain, it is Dr. Pradeep who is consulted in not only in our hospital, but even in Delhi. He is the vice chairperson of the Department of Anesthesiology, Sir Gangaram Hospital. Plus, he is the director of the pain medicine department of our hospital. Today, he shall be talking about labral analgesia, which again is very important, not only for the practical point of view, but students, you will definitely be asked this question. Both, it can be either in the theory or in the practical. Pradeep, we are very keen to hear your lecture.
Good morning, everybody, respected chairpersons and friends. I really thank the organizer for giving this opportunity to speak on labor analgesia. If you go into the history, J.Y. Simpson, professor of midwifery at the University of Edinburgh in 1847, first time gave diethyl ether for labor analgesia. And John C. Stone, 1853, used chloroform for labor analgesia in Queen Victoria, and the Prince Leopold was born. Why there was requirement of labor analgesia in labor when the patient is having labor pain? Because labor pain is the most painful experience in a woman's life. After causalgia and traumatic pain, it is the most painful thing to undergo. And there are various harmful effects of labor pain on the mother and the fetus. Because as the pain is there is a suffering, loss of morale, there is a sympathetic stimulation. The sympathetic stimulation leads to increased cardiac output, increased peripheral resistance, increased blood pressure. So in decompensated heart disease, it is detrimental for the patient. There is an increased adrenocortical output, increased lactic acid, increased free fatty acid when the pain is very severe in labor, and that leads to maternal metabolic acidosis. The pain leads to hyperventilation, there's increased oxygen consumption, there is a hypocarbia, and increased catecholamine release leads to impaired uterine contraction also. So the decreased uteroplacental blood flow, maternal metabolic acidosis leads to decreased fetal pH and decreased fetal oxygen consumption. This is a case scenario where a 22-year-old primary gravida is admitted with full-term pregnancy and labor pain with 3 centimeters cervical dilatation. Patient was diagnosed to be suffering from rheumatic heart disease at 2 months of pregnancy when she consulted cardiologist for progressively increasing dyspnea on exertion. Her 2D echo showed moderate mitral stenosis with left ventricular ejection fraction 46%. Means she was hemodynamically unstable with a pulse rate of 106 per minute. BP was approximately 102/70. There was tachypnea with a respiratory rate 26 per minute, and the peripheral oxygen saturation was 95%. What should be the plan of action? Should we allow the lady, parturient, to undergo normal delivery, or we should provide labor analgesia? The answer lies in labor analgesia. What are the beneficial effects of relieving labor pain? The beneficial effects are it relieves pain, anxiety and fatigue, prevent dysfunctional labor, decrease catecholamine and hydroxycorticosteroid level, the uteroplacental blood flow is maintained, reduce maternal oxygen consumption, prevent hyperventilation, eliminate fetal acidosis and hypoxia. But before we provide labor analgesia, there are prerequisites. Though it should provide adequate analgesia, but the safety to mother and fetus is of paramount importance. There should be minimal effect on the progress of labor, allows the mother to participate in the birth experience, no weakening of muscle power, and the technique that is used should be capable of extension for emergency, LSCS. Now, the pain in labor is divided in providing analgesia. It is divided into 2 stages. First stage of labor, which is a visceral pain mechanism, and second stage of labor, which has the somatic pain mechanism. The first stage of labor is the beginning of uterine contraction to 3/4 dilatation of the cervix. It's a visceral pain mechanism. I already told you there is a uterine contraction, there is a cervical dilatation. The patient feels the dull aching pain in abdomen, groin, and back, and it is due to the A delta and C visceral afferent nerve fiber accompanying sympathetic nerve going from uterus to the spinal cord. So segment involved, the spinal segment involved in the first stage of labor is the T10 to L1. Where it is in the second stage of labor, it is basically the perineal pain, and the S234 segments are involved. Pudendal nerve is involved. The second stage of labor start with the 3/4 dilatation of the cervix to the delivery of the fetus, and the pain is due to the descent of the presenting part. There is a somatic pain mechanism, and because there is a distension of the pelvic floor, vagina, and perineum, pudendal nerve is involved. I already told you. Along with that, the genitofemoral, ilioinguinal, and the posterior cutaneous nerve of thighs are also involved in the second stage of labor. A 34 weeks pregnant executive in the private firm, a diagnosed case of PIH, came to the pain clinic for consultation queries about the modality of labor analgesia. She wants to know. She wants to know how I'll be. What are the different techniques or methods by which I'll be provided labor analgesia. So the methods of pain relief in labor are non-pharmacological and pharmacological. The non-pharmacological techniques are specialized technique, non-specialized techniques, and the pharmacological via systemic drugs, inhalation agent, and the regional analgesia. In the specialized technique, we have acupuncture, transcutaneous electrical nerve stimulation, intradermal saline injection, and the hypnosis. Non-specified are hydrobath, hot packs, ball exercises, yoga breathing exercise, and the prenatal classes. But in non-pharmacological technique, the modern approach is the psychoprophylaxis. It teaches normal anatomy and physiology of labor and pregnancy, training in relaxation techniques, and the breathing technique, especially by Dick and Dick method. Pharmacological techniques. The pharmacological techniques providing labor analgesia is related to the cervical dilatation. It's to the stages of labor. In the first stage of labor, it is a systemic medication that are being used commonly. And the second stage of labor, the volatile and gaseous agents can be used. But in any stage of labor, the neuraxial techniques or the technique can be used, and whether it is the 3/4 cervical dilatation or the descent to the present part, the epidural techniques are good for providing labor anesthesia, whether it is first stage or the second stage. The systemic medication that are being used are opioid, non-opioid, ketamine, dexmedetomidine, benzodiazepine, phenothiazine, and the barbiturates. Fentanyl is the most commonly used opioid for providing labor analgesia nowadays. It is a potent, short-acting opioid. Onset of action 3 to 5 minutes. Peak effect comes in 3 to 15 minutes, 5 to 15 minutes. Half-life is 1 hour. The advantages are there is no active metabolite. It is suitable for PC and PCEA. The bolus dose is given as 25 to 50 mics every hour, and the continuous infusion of 0.25 to 0.5 mics per kg per hour. There is a less nausea, sedation, vomiting than morphine, and it can cause but hypotension, bradycardia, chest rigidity, and the respiratory depression. Remifentanil, because of ultra-short-acting synthetic opioid, it has got rapid onset of action. It is readily metabolized by plasma and tissue esterases. The effective analgesic half-life is 3 minutes. Local interval is 3 minutes, and it is given as a continuous infusion, initially as 0.025 mics per kg per minute to a maximum of 0.15 mics per kg per minute. This is to be used, is a promising solution when neuraxial techniques are contraindicated. Ketamine is another drug that is sometimes used for the imminent vaginal delivery, patchy epidural anesthesia, and the bolus dose is 10 to 15 milligram IV, and advantages being it maintains verbal contact and the monitoring. Tramadol provides satisfactory analgesia for first stage of labor, but not for second stage of labor. It has got the minimal, it caused the minimal respiratory depression, but limitation of the nausea and vomiting, and given in an IV dose of 1 milligram per kg. Patient controlled analgesia. This technique never established as an ideal technique for labor analgesia, but it enables mother to tailor her analgesic needs. Poor efficacy of and because it has got the neonatal effect of opioid, respiratory depression, etc., expensive, and it is only indicated where regional techniques are contraindicated or technically difficult. Inhalation analgesia techniques. These are the Antonox, sevoflurane, isoflurane, desflurane, and of course, nowadays not trilene, methoxychloroform are not used, but it used to be there in past for the labor analgesia. Antonox. It is a patient-controlled intermittent inhalation analgesia technique. It is self-administered. The onset of action is in 30 seconds. and the maximum analgesic effect come in 45 to 60 seconds. And the rapid onset of action is due to the low blood gas solubility of nitrous oxide. It diffuses rapidly, induce induction, and there is a rapid diffusion, induction, recovery. And the advantages are easy of use, self-titration, but it causes only moderate analgesia. And of course, the side effects are giddiness, nausea, and dysphoria there. Desflurane, enflurane, and isoflurane effectiveness is comparable to that of nitrous oxide. Recent studies suggest sevoflurane in inspired concentration of 0.8% to be accepted and effective. It provides superior pain relief but more intense sedation. Isoflurane in concentration of 0.2 to 0.25% in nitrous oxide, which is known as Isonex, is also used, and desflurane in 1 to 4.5% with nitrous oxide, but their use is limited by drowsiness, unpleasant smell, and high cost. Now, after systemic medication, inhalation agents, what neurological techniques can be used providing liver analgesia? But we must first understand how the neurological anatomy in pregnancy differ from the normal patient. In parturient, there is a lumbar lordosis. There is a widening and rotation of the pelvis. Tuffus line crosses spine at a heart level at 3-4 space level. There is the engorgement of epidural veins, difficult identification of ligamentum flavum, and increased sensitivity to local anesthetic, which causes the reduction in intervertebral gap. There is an enhanced rostral spread and the narrow epidural space. So the dose requirement definitely decreases as compared to the normal patient. The neurological techniques that can be used are the lumbar epidural, combined spinal epidural analgesia, caudal epidural, single shot spinal, and the continuous spinal analgesia. In the epidural method, we can either provide a liver analgesia as an intermittent bolus dose, continuous infusion, dual puncture epidural technique, computer integrated background fusion, TCEA, and program intermittent epidural boluses, and the combined spinal epidural analgesia. The indication for lumbar epidural analgesia are maternal request alone is sufficient, preeclampsia, diabetes, morbid obesity, non-reassuring fetal heart, and the maternal cardiovascular disease. The obstetrical indications are incoordinate uterine contraction, dystocia, and from the fetal side is the prematurity, multiple pregnancy, and the intrauterine growth retardation. The contraindications are patient refusal, uncooperative patient, coagulopathy, hypovolemia, the skin infection at the site, deformity, and the lack of resuscitation equipment and drugs, and the unskilled or inexperienced anesthesiologists. So before giving epidural analgesia, providing liver analgesia, there are prerequisites. There has to be the PNS checkup must be done, consent of the patient, intravenous access, monitoring. It should be done under total aseptic techniques. There is a controversy regarding now the test dose to be given in liver analgesia. Trained staff should be there. Resuscitation equipments are mandatory, and the bed or the OT table maneuverability to that tenant position should be there. Nowadays, traditionally, what used to be done for providing liver analgesia was local anesthesia concentration was used in 0.2 to 0.25%. And that used to cause basically sensory loss or difficulty in walking and the prolongation of liver. But with the advent of understanding of basic pathophysiology of acute pain, where now the minimal local anesthetic drug and minimal local anesthetic volume is used, it has been seen that only C fibers can be blocked, then the liver analgesia can be provided, the pain relief can be provided. So these C fibers can be blocked with the levobupivacaine or the bupivacaine concentration of 0.0625% to 0.125%, or ropivacaine of 0.1 to 0.2%. So the total dose of local anesthesia decreased. The side effects related to motor blockage, because we are using less doses, and the concentration is considerably reduced, which only blocks C fibers, and there is no loss of sense of proprioception. Another advantage nowadays is the use of opioid. Fentanyl is a very good drug. It has got the short duration of action. The immediate onset of action is there. So the low dose mixture of local anesthesia and opioids are used. And the opioid that is used is the fentanyl that is used with the epidural technique is 2 mics per ml of fentanyl. And the infusion is given at 6 to 8 ml per hour. Patient-controlled epidural analgesia can be used. There is a feeling of control. The advantages are there is a immediate access to additional doses of epidural. There is a less blockage. The ambulation can be done. Lower drug use, minimal sympathetic block, and the lower staff workload. A call received from obstetrician to anesthesiologist about a primary gravida with 5 centimeters cervical dilation in labor pain. Patient is very uncooperative with very low threshold of pain. Which neuraxial technique to be used in this patient? So the technique of choice would be combined spinal epidural analgesia. This technique has got 2 components, subarachnoid component as well as epidural component. And it is the most important new technique in obstetric analgesia, dubbed as walking epidural. The advantages of this technique are rapid onset of pain relief, better perineal analgesia, higher ambulatory potential, and the lower drug use. There's an endpoint where if the CSF comes, then probably the epidural catheter will also be in situ. The dose regime for combined spinal epidural analgesia are initially fentanyl is given generally as a 25 mics and bupivacaine in doses of 1.25 milligram, followed by a continuous infusion of 0.065% bupivacaine with 2 mics per ml of fentanyl, 8 to 10 ml per hour, or PCA with 6 to 8 ml with lockout interval of 20 minutes. So what is the difference in epidural versus CSCA? CSCA is a sure technique. It has got the rapid onset of action. Epidural catheter placement is confirmatory. Where epidural is slow onset of action, but it is provide graded block and the less hypertension are there. There is a reduced motor blockage with CSCA and the preservation of proprioception is there. The ambulation is possible with combined spinal epidural analgesia. There are specific complications of combined spinal epidural analgesia. It's led to the PDPS, fetal bradycardia, neurological injury, meningitis, and the high spinals. Computer integrated patient controlled epidural analgesia. An alternative approach to determine the background fusion rate during PCA and the use of a computer program to automatically adjust the background fusion rate according to the amount of local anesthetic used in the previous hour. Program intermittent epidural boluses is a new technology in which boluses of epidural mixtures are delivered at predetermined interval. Nowadays, we provide ambulatory analgesia. The patient is allowed to walk, but there are basically criteria before we allow the patient to walk. That these criteria are: there is no obstetrical contraindication, no change in lying to sitting blood pressure, ability to perform straight leg raising test, and that means the motor strength is enough, and someone should be available to walk with the patient. And this is basically done with the modified Bromage score, where Bromage 0 is the subject is able to move the hip, knee, ankle, and able to lift his leg against gravity. So the patient must have Bromage score 0, and where the Bromage 4, there is a complete paralysis, and the weakness is there in Bromage score 2 and 3. So we ideally require Bromage score 0 for letting the patient to walk in epidural. Sometimes when the systemic medication techniques, inhalation techniques, and neuraxial techniques are not available or cannot be used, then in a fast setup, the regional techniques are also used in the different stages of labor. In the first stage of labor, paracervical block can be given, and in the second stage of labor, pudendal nerve block and the perineal infiltration can be done. Paracervical nerve block is an alternative technique who cannot receive neuraxial block. It is used in the first stage of labor. There is no somatic or motor block. It halts transmission of visceral afferent impulses from uterus and cervix through paracervical ganglia. 5 to 10 ml of local anesthetic are deposited in left and right vaginal fornix. But the side effects are local anesthesia toxicity, sacral plexus trauma, and the hematoma, and the fetal bradycardia is generally seen with the paracervical nerve block. Pudendal nerve block to be used in the second stage of labor. It provides analgesia for the sensory innervation of lower vagina, vulva, perineum, and the motor to the perineal muscle and external sphincter. The approaches are transvaginal or the transperineal route, 7 to 10 ml of local anesthetic on each side, medial and posterior to the ischial spine are deposited, and this causes analgesia to the perineum and the lower vagina. It is also used in the forceps delivery and the episiotomy, and the side effects are local anesthesia toxicity, infection in the hematoma. So there are various myths associated with the use of labor analgesia. And these says with the use of the local anesthetic, there is increased chances of a lower segment injection, prolonged labor, increased intervention delivery, backache, headache, and effect of the baby like hypothermia are there. But these are only myths. It has been proved now with the various systemic studies, various studies, that the less concentration of local anesthesia and the dose that is nowadays used for providing local anesthesia, there is no increased chances, and these are only myths. So what is new in labor anesthesia is maternal request alone is an indication, ultrasound rate guided blocks, minimal local anesthetic drug and minimal local anesthetic volume of local anesthetic. There's new advent safe opioids are available like fentanyl and remifentanil, ropivacaine and levovacaine, which has got more sensory affinity, combined spinal epidural technique, and more awareness about providing labor anesthesia and the usefulness of labor anesthesia in a parturient. Thank you very much for the listening. Thank you very much.
Thank you so much, Pradeep, for that
Thank you.
Excellent lecture in which you went into the details right from anatomy and the practical aspects. Devang, can we take some questions? Are there any questions in the
Actually,
chat?
there are no questions.
Okay.
There are no questions.
I think everything was so clear, starting from Sunanda, talked all, in details. These are the questions that we ask, and I'm sure once the students read your lecture, the ones who haven't heard it today, they will be able to answer all the examiners. And so also Pradeep, all the myths, he went right up to the end about the myths and the wrong information that is given to the patients, and they even come to us in our practical, in our OPDs, and with all these illusions that they have. So I don't think, Devang, there's any question from my side. Everything was so clear. Okay, so thanks a lot, Sunanda, and thanks, Pradeep.
Thank you. Thanks, the organizer. Thank you, Dr. Sood, for excellent moderation.
Thank you all the respected chairpersons and speakers. Thank you so much.
Thanks a lot. Thank
you.
Thank you, ma'am. Now, before proceeding further, let me announce the winner of the morning quiz. The winner is Dr. Sarvanan Srikumar from Pandit Madan Mohan Malviya Hospital, New Delhi. Congratulations. Now, moving on to the long case presentation on preeclampsia, I would like to welcome Dr. Ranju Singh, Director Professor, Lady Hardinge Medical College and Associated Hospitals, New Delhi. Her areas of focus are pediatric and obstetric anesthesia and life support. She will be moderating the session along with Dr. Tina Khurana, Associate Professor, ABBMS and Dr. RML Hospital, New Delhi. Dr. Tina Khurana.
Thank you, Dr. Devang.
Ma'am, please continue.
Dr. Tina is an associate professor in the Department of Anesthesiology at Dr. Atal Bihari Vajpayee Institute of Medical Sciences and RML Hospital, and her areas of interest are airway management, and she's a certified ALS and BLS instructor. Me and Tina will be taking you through the case of PIH, and I request Dr. Praveen to please begin his presentation. Thank you so much.
मैम सॉरी वो खाने थोड़ा लेट हो गया आने में.
कोई बात
Shall I get it for you? मैं आपको थोड़ा सा
Good morning, ma'am.
Praveen, can you increase your volume a little bit?
Good morning, ma'am. Can you hear me, ma'am?
Yes, I can, Praveen.
Shall I start, ma'am?
Yes, please.
A 24-year female, Mr. Shama, a homemaker by occupation, a resident of Wazirpur industrial area, a primary gravida with 36 weeks period of gestation, came to the casualty with complaints of amenorrhea for 9 months, headache for 2 days, and blurring of vision for 1 day. History of presenting illness. The patient was apparently well 2 days before, developed a headache which was sudden in onset, throbbing in nature, severe in intensity, localized to bilateral frontal area, non-radiating and non-pulsatile in nature, slightly relieved by rest, not relieved by painkillers, and was aggravated by exertion, and it had no diurnal or postural variation. There was no history of fever, nausea, vomiting, or ringing sensation in ears. There was no history of slurring of speech, facial, or limb weakness. She
Okay,
also
okay,
had
Praveen,
blurring of vision since
Praveen,
yesterday, which was not.
wait. Praveen, why all this history? Fever, nausea, vomiting, ringing in the ears, slurring of speech.
Ma'am, I am trying to exclude the other causes of headache, ma'am.
Okay, okay. So now that the patient has come with a history of headache, she's pregnant, your history should be aimed at reaching a differential diagnosis related to the headache first. So what other causes of headache come to your mind when a pregnant patient comes to you and says, I have headache for the past 2 days?
Ma'am, it can be a case of pregnancy-induced hypertension. Then the patient can have meningitis, fever.
Okay, she can have meningitis. Anything else which is very common? I mean, what are the common causes of headache? Why do you jump to PIH at the first instance?
Ma'am, migraine,
You
visual
started with your
disturbances.
predetermined notion of PIH. Are there any simple causes of headache in any patient? Such as?
Ma'am, like if she is having some vision problems because of that eye strain.
Okay, anything else?
Migraine,
Can she have a
pre-existing
migraine?
migraine. Yes, ma'am.
Yes, can she not have migraine or cluster headache or any other simple causes of headache rather than first jumping at PIH? Okay. So
Okay.
besides this, when you've asked her nausea, vomiting, these are good things to ask. These are there in migraine. You can ask for any postural variation. You can ask for any location specific headache. That is it in the frontal area? Does it have, she have in occipital area, any other specific area where she has the headache? Is it associated with vomiting? Is there any photophobia along with the headache? Any other cause? Don't jump to PIH. Okay, so your history now should elicit other causes of headache. As you rightly said, you've taken a history of fever, nausea, vomiting. Does she have any form of meningitis, meningism? Is there any involvement of the limbs? All this is okay. Okay, so please don't start with PIH in your mind.
Yes, ma'am.
Okay, please continue.
The patient also complained of blurring of vision since yesterday, which was not associated with double vision, increased sensitivity to light, haze, glare. There is no history of trauma to the eyes. There was no history of visual difficulty earlier.
Okay.
And the patient wasn't using spectacles or contact lens earlier.
Okay.
And there is no
Why
history of,
have you taken this history?
ma'am, for blurring of vision. If she was
Okay.
using some spectacles and she just left using it, there may be difference in the eye power, and because of that, she might be having this headache.
Okay. Okay, fine.
Then there was no history of upper abdominal pain, or reduced urine output. There was no history of any abnormal body movements or yellowish discoloration of eyes or itching.
Okay, why this history? Why this history?
And in case if this patient had any pregnancy-induced hypertension, I am trying to rule out the severity, ma'am, whether it is severe or
Okay.
without
So
severe
you've
disease.
already concluded she has PIH. Okay, that is all right. Okay, so a pregnant patient coming with history of headache. Yeah. You were trying to rule out if she has any involvement of any systems which probably may be affected by PIH.
Yes, ma'am.
That is what you're trying to rule out? Okay, carry on.
There is no history of perirectal or perivaginal bleeding.
Okay.
Past history. The patient had no history of diabetes mellitus or hypertension prior to pregnancy. The patient is not a known case of chronic kidney disease, hyperthyroidism, epilepsy. The patient also has no history of COVID-19 infection. There is no history of any blood transfusion or any surgeries in the past.
Okay, the right way to say this is there is no history suggestive of. The patient will not come and tell you I am hypertensive. That's very few patients will actually come and tell you things like this. So there is no history suggestive of hyperthyroidism or epilepsy. Okay. Okay. Carry on.
Okay, ma'am. Okay.
She had no history suggestive of hypertension prior to this? No, she's never had these kind of headaches before?
Yes, ma'am.
No history of trauma? Okay. Carry on.
Moving to obstetric history, her LMP was on 20th of June 2021 and her EDD is on 27th of March 2022. History of first trimester. Her pregnancy was confirmed by urine, dipstick, and ultrasound. There was no history of excessive nausea, vomiting, fever, rashes, radiation exposure, or bleeding of a vagina. There was no history of any drug intake except folic acid in the first trimester. Second trimester, she was able to feel fetal movements from the 5th month of pregnancy. Her second ANC visit was at 22nd week of gestation, and at that visit, she got her anomaly scan done. There was no history of breathlessness, fatigue, weakness, or drowsiness, and there is no history of abrupt increase in weight or bleeding or leaking PV. She got immunized with 2 doses of tetanus toxoid during her second trimester, and she was advised iron and calcium tablets during her second trimester. Third trimester.
Okay, so she appears to be a booked case. She appears to be a booked case.
Yes.
Yes. So when you begin your obstetric history, Praveen, when you're starting your obstetric history at the time, you must mention that she is a booked case. That is how all this ANC visit, folic acid, calcium, whatever you are giving later in the history, please let us know that she's a booked case right at the beginning. Okay?
Okay, ma'am.
Okay. Yes, please carry on.
Okay. Third trimester history. In her ANC visit at 32nd week, she was informed that her BP was higher and she was started on tablet labetalol 100 milligram TDS, and she didn't come for the next ANC visits. She didn't have any history of headache or blurring of vision earlier to this episode. There was no history of upper abdominal pain or reduced urine output, and she was able to feel the fetal movements continuously.
Okay. Did she tell you?
Menstruation.
Did she tell you that I have been taking tab labetalol? Did she name the tablet and tell you I've been taking tab labetalol TDS?
Ma'am, I saw the prescription.
You saw the prescription. But here, when you're telling the history, unless the patient gives you a definitive indication that she knows the drug, you know, the patient, this is history in patient's words. So does the patient tell you that I'm taking tab labetalol TDS? Unless that happens, you say that she's taking medication 3 times a day. Okay, these are medical terminologies which the patient doesn't tell you. She doesn't say I'm taking tablet so-and-so TDS. So she's taking an antihypertensive tablet, which I found out to be labetalol 3 times a day. Okay, that's a better way to present this. Please carry on. Anything significant in the menstrual history?
No, ma'am.
Okay, carry on. Skip that and we'll go to the next slide.
In her family history, the patient's mother
Anything
had...
significant?
Yes, ma'am. The patient's mother had hypertension during...
Her mother had hypertension during her first pregnancy. Okay. Any other significant history of hypertension in the family?
No, ma'am.
Okay. 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 Move ahead. If this is not significant, please move ahead.
Marital history and personal history.
Not important. If there's nothing significant, please go ahead.
Yes, ma'am.
Okay. Treatment history. Yes.
She was on regular supplement of folic acid for 8 months and iron and calcium tablets for 5 months. From 32nd week, she was started on tablet labetalol 100 milligram TDS.
but she was not complying to that medicine and she was not taking it regularly.
Next.
General examination.
Okay, wait. From the history, now you've come to the conclusion that this is a pregnant patient who's come to you close to term and she's complaining of headache, and she has already been told that she has raised blood pressure during her pregnancy, for which she was put on treatment. Right? That is the synopsis? Okay, please carry on with the general physical examination.
The patient was examined when she was lying comfortably on bed in left lateral position. The patient was alert, conscious, cooperative, and oriented to time, place, and person. Her build and nutrition were average.
Okay, now you're saying that she's conscious and cooperative. Other than this being a part of general physical examination, is this relevant to this patient in particular?
Yes, ma'am. In case the patient had hypertensive-induced disorder and if she had eclampsia, then she won't be conscious.
Not only eclampsia. Eclampsia is her throwing a convulsion.
Yes, ma'am.
What does the consciousness and cooperative nature of the patient tell you? She's fully conscious, right? She's oriented, she's fully conscious. Does that give you any indication of her status, mental status? Does it rule out anything very significant?
Yes, ma'am. She is not having any signs of intracranial hypertension, intracranial hemorrhage.
Very good, very good. The fact that the patient is conscious and oriented is a very, very good indicator that her ICP is not raised. One of the best clinical indicators of raised ICP is a patient whose consciousness is blunted. So in this particular patient, this is a very important point which will actually impact your conduct of anesthesia. Okay, this shows that her ICP is not raised. We'll come to this ICP later and talk about it once we come to the investigations. Okay, carry on.
Her build and nutrition were average. She had no pallor, no cyanosis, no clubbing. She was not icteric, and she had no lymphadenopathy. She had bilateral pedal edema, which was mild pitting type. Her neck veins were not dilated, and no carotid groove was present. Her height was 160 centimeter. Her weight was 58 kilograms. Her BMI was found to be 22.6 kilogram per meter square. She was afebrile by touch. Pulse rate was 80 per minute and regular in rhythm, normal in volume and character. And there was no radial or radiofemoral delay. Her blood pressure was 150 by 98 millimeter mercury, which was
is this rate of 80 per minute significant? Her pulse rate is 80. Does it give you any information?
It's in the normal range. She is not having tachycardia.
She's not having tachycardia. Can you put it any other way? What do you expect her to have? Is this a normal pulse rate for her?
Usually in pregnancy, there will be sinus tachycardia.
Okay, so she doesn't have sinus tachycardia. So this pulse rate in pregnancy, does it indicate
I think she might have been on some. I think she might be on some beta blockers.
The pulse rate is very important because it will give you an indication of how strongly beta blocked she is. She is on labetalol, according to you, an alpha plus beta blocker. So her pulse rate would be less than what you would find in a normal patient. Okay, so you need to have a very sharp eye to know her pulse rate and find out whether she's actually beta blocked or not by this time. Okay, so since her pulse rate in pregnancy, there is relative tachycardia, so her pulse rate would have been higher. It is normal range. For this patient, it may be towards the lower range. Okay, if she's now been taking labetalol regularly. So pulse rate is indicative of her status relative to the alpha plus beta blocker she's taken. So that is why it should raise a red flag in case it's too low or too high. Okay, next.
Okay.
BP is?
The blood pressure was found to be 150 by 98 millimeter mercury, which was measured in right arm in left lateral position.
Her BP is almost 160/100. Is this on treatment? This is when you examined her, she was taking labetalol?
Yes, ma'am.
Okay. Okay. So this BP is on treatment.
On treatment.
Okay, carry on.
Her respiratory rate was 17 per minute, which was regular in nature and a thoracoabdominal pattern. Coming to AV examination, there was
No obvious facial deformity of cheeks, lips, or jaw. Her nails were normal. There was no flaring, deviated nasal septum, or any growth in the nails. Mouth opening was more than 3 fingers. She belonged her modified Mallampatti class was 2. Her oral hygiene was good. There was no missing or loose teeth, and there was no artificial dentures. There was no oral mass or oral slur.
What? Okay, fine. What out of these is the most important thing in airway examination? All this that you've done, if I had to pick 2 or 3 things that were most important, and I tell me only these, which 3 will you pick?
I will see for the mouth opening.
You will see for the mouth opening, and please let me tell all the PGs who are listening in, mouth opening should not be measured in fingers. Nowhere is it recommended that you measure mouth opening in fingers, please. The question of whether it is your finger or patient's finger does not arise. The finger width of any patient, whether it is yours or the patient, is different. Thin people will have 3 fingers which are 4 centimeters, and people who are obese will have 3 fingers which are 8 centimeters. So please measure the mouth opening in centimeters. Do not measure it in fingers. It is irrelevant whether it is your finger or your patient's fingers. Okay, do not measure in finger breadth. So 1, mouth opening. Second important thing.
Then I will look for the modified Mallampatti class.
Mallampatti classification, and each of the PGs must be able to enumerate the Mallampatti classification when asked. Please do not try to make up the Mallampatti classification. It's something which you need to learn and mug it up. So do know the Mallampatti classification verbatim. There is no excuse for not knowing it when asked. Okay. The third important thing.
Ma'am, the ability of the patient to protrude the mandible.
No. If you're thinking of airway in this patient, what should be the most important thing after these 2 things?
Ma'am,
The neck circumference. The neck circumference. No, the neck circumference, which will directly indicate the, what does the neck circumference indicate?
Sorry, ma'am, I couldn't hear you. It's breaking.
What does the neck circumference indicate for a difficult airway? It is one of the predictors of difficult airway. Out of all this, one of the very important predictors of difficult mask ventilation as well as difficult intubation is increase in neck circumference. Okay, so more than the other things, yes, you need to do the complete airway examination. But if I ask you to pick 2 or 3 important things, then neck circumference should come higher up in the list. Okay, both in males and females. Now, neck circumference is a very important parameter which helps you decide difficult mask ventilation as well as difficult laryngoscopy and intubation. Okay, go ahead. Next. Okay, so there is nothing very significant in her airway examination. Okay, go ahead. Anything significant? Anything significant? In the systemic examination, fundal height corresponds to 36 weeks. Next, please. Next slide.
Corresponds to 36 weeks of gestation.
Okay. Next slide. Did you do a fundal grip? Did you do a fundal grip, Praveen?
Yes, ma'am.
Okay. So all PGs must be able to do a lateral grip as well as a fundal grip. So right lateral, left lateral, as well as a fundal grip. If you can't do it, please don't mention. If you've written it, you're saying it, then you should be able to do it if the examiner asks how you've done it. Okay, just don't write it or say it for the sake of saying. Okay, next, please. Is there anything significant? FHR is 145. Go to the next slide.
Yes, ma'am.
Anything significant?
It was normal. No, ma'am.
Okay, next.
Cardiovascular system, the apex beat was shifted to the fourth intercostal space and left mid-laterally.
Okay, which is normal in a pregnant patient?
Yes, ma'am.
Okay, go ahead.
In central nervous system, there was no negative finding. Everything was good.
Okay, her consciousness status is okay. Did you see her reflexes?
Yes, ma'am.
They were okay?
Yes, ma'am. It was normal.
Okay, fine.
Yes, ma'am.
Go ahead.
Examination of back. There
Go
was
ahead.
exaggerated lumbar lordosis and mild fetal
Okay.
sacral edema was present. Yes,
Okay, go ahead.
yes, ma'am. My provisional diagnosis is we have a 24-year primary gravida with 36 weeks period of gestation. Most probably a case of preeclampsia with severe features.
Okay, so you've reached a diagnosis of preeclampsia merely on history and examination?
Ma'am, I would like to say this case is a case of pregnancy
What
induced
should not
hypertension rather
happen?
than
See,
preeclampsia because
PIH
to
as
confirm
yes. So, what type of hypertensive disorders do you find in pregnancy? What categories of hypertensive disorders do you find?
ma'am, the hypertensive disorders in pregnancy are classified as gestational hypertension, preeclampsia. Preeclampsia is further classified as preeclampsia without severe features and preeclampsia with severe features.
Yes.
Then there is chronic hypertension and chronic hypertension with superimposed preeclampsia.
Okay, fine. So, what is the difference between each one of them? What is gestational hypertension?
I mean, gestational hypertension, the patient will be found to have a BP of more than 140 by 90 mm mercury for the first time after 20 weeks of pregnancy, measured at two separate occasions, at least 4 hours apart. And the BP will return to normal after 12 weeks of pregnancy, and there will be no proteinuria.
There is no proteinuria. Okay. And then what is PIH? Same blood pressure with proteinuria.
With proteinuria.
So is proteinuria not a finding on investigation?
So then we can look for the other
have it on
alternatives.
history. Wait. You can't have proteinuria on history and examination, no?
Yes, ma'am.
If PIH requires the diagnosis requires an investigation, how can you have a diagnosis of preeclampsia on history examination? You understand what I'm trying to say?
Yes, ma'am.
For diagnosis of PIH, you require proteinuria as a characteristic feature. Rising blood pressure with proteinuria. So as of now, you don't know whether this patient has proteinuria.
Yes, ma'am. But
So how do you reach a diagnosis of preeclampsia?
ma'am, in the absence of proteinuria, this patient is having a neurological or visual disturbances, ma'am. She's having headache and blurring of vision.
Okay.
So
Okay.
based on the time
So-
range she's having.
So can she not have hypertensive encephalopathy because of chronic hypertension? Can she not have a hypertensive crisis because of chronic hypertension superimposed with preeclampsia? Any of these can happen. So in the diagnosis, it is preferable that you say this is a patient who's a primary gravida at 36 weeks with a hypertensive disorder,
Okay, ma'am.
instead of saying preeclampsia.
Okay.
Okay. Now you've said there is chronic hypertension, there's preeclampsia, there is eclampsia with severe and chronic features. Everybody probably knows the diagnostic features, so we'll not waste time going over that. Is there any other thing in preeclampsia classification which you know of besides severe features and without severe features? Now, please, I wish to emphasize there is no mild and severe preeclampsia. Preeclampsia with severe features and without severe features. These are the two classifications now. Do you know of type 1 and type 2 preeclampsia?
Yes, it is early onset preeclampsia, which is
Very good.
before 34 weeks of gestation.
Yes. So, and type 2 is late onset,
Late onset,
after 30.
more than
Is there
34.
any other difference between the two besides the onset and timing?
And they say type 1 is mostly associated with the genetic features,
Yes, yes. And type 2?
with placental features, like placental origin.
Metabolic. There is a lot of metabolic component in type 2 and there is a lot of genetic component in type 1. Okay. Complications, both maternal and fetal, are more in type 1. In type 2, the type 1, the early onset, and less in type 2. Okay. The outcome is also worse in early onset and the outcome is much better both for the mother and the baby in type 2. Okay, so now when you are describing PIH, can you tell me all the systemic manifestations of PIH? Which all systems does it affect in the mother and how? Very briefly and quickly.
Yes, ma'am. First, I will start with the neurological system, ma'am.
Okay.
The mother will be having headache, hyperreflexivia, and hyperexcitability.
These are clinical features. I want to know the pathophysiology. These are clinical features that she has headache. What happens in the CNS?
Ma'am, due to the endothelial dysfunction and there will be disrupted cerebral autoregulation and there will be a hyperperfusion state. Because of that, there will be vasogenic edema
Okay. There is vasogenic
And this will lead
edema.
to edema.
There is
And
vasospasm. There
this
is
will lead to
vasogenic
this
edema.
symptom.
Okay. What else? There is hyperreflexia. There is hypotonia.
And that can due to this due to this increased perfusion, there can be posterior reversible encephalopathy syndrome also, ma'am.
Please, why do you mention posterior reverse encephalopathy? Is it a normal feature in patients of PIH?
Right.
Then your entire viva will go towards press, and then you will fall in a ditch which you've just dug for yourself. Nobody's asked you about press. Press is not a normal feature in patients of PIH. It is a complication which is rarely seen in some patients. Okay. So we are asking you the common manifestations of systemic involvement in PIH. What normally happens in a patient of PIH is that there is vasogenic edema, there is vasoconstriction, cerebral vasoconstriction, there is decrease in seizure threshold, there is hyperreflexia, there is hypertonia, there is damage to the blood-brain barrier. All these things happen, right? Okay. What happens in the cardiovascular system?
I mean, cardiovascular system, the patient will be having increased systemic vascular resistance.
Right.
And increased blood pressure, and the cardiac afterload will be increased, and the cardiac output can be either normal or hyperdynamic.
Okay.
And the patient can have both systolic and diastolic dysfunction.
Okay.
At
She can have
later
systolic, right, systolic or well as diastolic. Some amount of cardiomyopathy can take place. These patients have an increased afterload due to the severe vasoconstriction. What else? What else? What about the intravascular volume, which is of relevance to you?
Then the intravascular volume will be depleted in this patient.
Okay. So they have a depleted intravascular volume. Yes, they have a depleted intravascular volume. Okay. What about the respiratory system?
In respiratory system, there are more chances of pulmonary edema in this patient due to the decreased oncotic pressure and increased hydrostatic pressure.
Why does the oncotic pressure decrease?
Ma'am, the liver is also affected in preeclampsia, and there will be decreased albumin production. Because of that, the oncotic pressure will
Is
be
it a
reduced,
decreased
and there will be
production?
proteinuria also.
No. Is it a decreased production or is it an increase in loss?
Increase in loss, mainly.
Yeah, there is no decrease in albumin production. The liver function may be deranged in the terms of manufacture of coagulation factors. There is effect on the platelets in the hematological system, but protein production per se does not decrease. So there is an increase in loss of proteins. That is why they have hypoalbuminemia. Okay, that is what decreases the plasma oncotic pressure. What else happens? Why there is pulmonary edema, you said?
And there will be increased hydrostatic pressure due to this hypertension.
Okay. Increased capillary hydrostatic pressure, decrease in plasma oncotic pressure. What else? Why pulmonary edema? Okay, what else?
Then leaky capillaries are there. And
leaky capillaries, okay. Because of dysfunction in the endothelial glycocalyx, pulmonary endothelial glycocalyx, they have leaky capillaries. This is why they are more prone to develop pulmonary edema. Okay, what else? What other systems are affected? What about the hematological system?
In hematological system, there will be thrombocytopenia.
Okay.
And microangiopathic hemolysis will be there.
Okay, there is hemolysis and there may be thrombocytopenia. Okay, what about the coagulation system?
Ma'am, there will be decrease in the coagulation factors, fibrinogen, and increase in the fibrinogen degradation products. There will be decreased antithrombin 3.
Okay, very good. There is decreased antithrombin 3. Fibrinogen is affected. Fibrin degradation play down. So, is pregnancy normally a hypercoagulable state or no?
Ma'am, pregnancy is normally a hypercoagulable state.
So, what happens in these patients? Do they stay hypercoagulable then?
No, they become hypo, the clotting factors will reduce.
So it's only in severe PIH that they become hypocoagulable. Otherwise, pregnancy is a hypercoagulable state. So their coagulation system can be very dynamic, from hypercoagulable in mild or without severe features to severely hypocoagulable in patients who have PIH with severe features. and anywhere in between. Okay, so the coagulation system is extremely dynamic. Any other system which is affected? So you've said CNS, CVS, respiratory, hematological, coagulation, any other?
Liver.
Liver. What happens in the liver, in the hepatic system?
Ma'am, first the hepatic dysfunction will be there, ma'am. Liver functions will be deranged.
In patients with severe PIH.
Liver enzymes will be elevated. Yes, ma'am.
Okay. Okay. And
liver enzymes will be elevated in these patients. Then that can be periportal hemorrhagic necrosis.
Okay.
And subcapsular hematomas, which will cause stretching of the liver capsule, that is the Glissen's capsule.
So they can have subcapsular hemorrhage.
This is the reason being the
okay, periportal necrosis, hepatocellular damage. They can have subcapsular hemorrhages. They can have a decrease in coagulation factor production. Can they have an increase in bilirubin?
Yes, ma'am.
Because of the hemolysis, they will have an increase in bilirubin. Okay. Okay. What about the renal system?
Ma'am, in renal system, due to this glomerular capillary endotheliosis, there will be decreased. Ma'am, there will be decreased glomerular filtration rate, and there will be decreased urine output.
Yes.
And hyperuricemia will be there, ma'am.
Okay, so they have a decrease in GFR, and they have a decrease in urine output, increased serum creatinine levels, and increase in uric acid levels.
Proteinuria.
Okay. Okay. So you should also be able to identify all these features which indicate severe PIH. Okay. Out of all these, which features are directly correlated or parallel the severity of PIH? Any of these features can tell you the severity of PIH. Do they parallel the clinical disease?
Oliguria.
Very good. Oliguria and very good. Oliguria, and one more thing parallels the severity of the disease.
I don't know.
Oliguria and platelets. Okay, so the fall in platelets and the fall in urine level are two features which directly indicate or parallel the severity of the disease. Okay. Okay, so now once you've identified all the systems that are affected, what all are your concerns in anesthesia? Can you list the problems in anesthesia if your examiner asks you?
Yes, ma'am. First of all, this patient will be having a difficult airway, ma'am.
Very good. She'll be having a difficult airway. What all in difficult airway? Difficult airway is a very diffuse term.
Yes, ma'am. First, the patient will be having pharyngolaryngeal edema.
Very good. She has pharyngolaryngeal edema.
Pharyngolaryngeal edema, and there will be mucosal friability and hyperemia.
Very good.
So that
mucosal,
we have to do a gentle laryngoscopy.
Right, right. What
then
else?
The patient will be, then during pregnancy, the patient will be having enlarged breast. So like inserting the laryngoscope will be difficult.
Okay. Anything else which is important besides large breasts?
Ma'am, then while doing laryngoscopy, the patient can go for exaggerated hypertensive response, which can cause intracranial
That is not
hemorrhage.
airway. Please, Praveen, that is not airway. Laryngoscopic responses. You are talking of difficulties in airway. So let's enumerate the difficulties in airway and its clinical significance. So one, the difficulties occur because of pharyngolaryngeal edema, because of mucosal friability, because of weight gain, increased neck circumference, large, heavy breasts, okay, and some amount of subglottic edema also develops. These are the causes. How is this clinically relevant to you is a separate thing. Because she has pharyngolaryngeal edema, she has a large tongue, which is edematous, difficulty in visualization, that is laryngoscopy is difficult. Because she has a friable mucosa, the incidence of trauma is higher and you have to be very gentle with your laryngoscopy. Because there is subglottic edema, you may need a smaller size tube because of the pharyngolaryngeal edema also, and they have a chance, a propensity to develop postoperative respiratory airway obstruction. Okay, and because of the increase in neck circumference, because of the large breasts, because of the weight gain, both mask ventilation and laryngoscopy are difficult. intubation may not be difficult. Okay, so there is a cause and it has a clinical relevance. Laryngoscopic response is not part of the airway difficulty. Okay, so she has a difficult airway, number one. What else? Other problems in anesthesia? Jaldi jaldi batao, we're running out of time.
Then comes the laryngoscopic response.
Very good. She has an exaggerated response to laryngoscopy. Why is it detrimental?
Ma'am, before during laryngoscopy, the patient is already having hypertension and will cause an increase in blood pressure. Because of this, intracranial
Obviously,
hemorrhage
that
can
is why
happen.
there is an exaggerated response. Why is it detrimental?
And this patient is already having high blood pressures. And we are adding more.
So how is that increase in blood pressure relevant to you? बढ़ने दो ना, क्या फर्क पड़ता है? Already 200 है, 220 हो जाएगा तो कितना फर्क पड़ेगा?
And can cause intracranial hemorrhage.
It can cause intracranial hemorrhage. Very good. So increase in blood pressure that is caused by the laryngoscopic. What is it called? What response is this called?
Sorry, ma'am, I can't hear you.
It's called the pressor response. Okay, this pressor response can produce what all side effects? One, you said it can cause intracranial hemorrhage. What else? What else?
Ma'am?
Anything else which the laryngoscopic response can cause? Any other systems which will be affected? Any damage?
Ma'am,
The stress
there can be chance
response-
of increased bleeding also.
Surgical bleeding you mean? अभी तो surgery शुरू ही नहीं हुई, कहाँ bleeding होगा?
No, mucosal fibrillation.
The laryngoscopic response is when you
Because
put a laryngoscope in the patient's throat. Because of the
Yes, ma'am.
laryngoscopic bleed. Because of the laryngoscopic response. Why should it bleed? Unless you've caused trauma, why should it bleed? Any other problem which is directly because of the laryngoscopic response, pressure response. These patients can develop hypertensive encephalopathy. Okay, they can develop an intracranial hemorrhage. They can develop myocardial ischemia. They can develop myocardial infarction. They can go into congestive heart failure because of the increase in hypertension. They can develop vasogenic cerebral edema. Okay, all these are directly related to her increase in blood pressure at the time of laryngoscopy. Right? All these things, hypertensive encephalopathy, stroke, congestive heart failure, myocardial infarction, cerebral edema, pulmonary edema, all these features are related directly to her rise in blood pressure at the time of laryngoscopy. Out of this, it is very important to prevent the rise in blood pressure because it is the rise in blood pressure which is directly related to her incidence of developing intracranial hemorrhage. And the single largest factor responsible for mortality in patients of severe PIH is developing intracranial hemorrhage. And your laryngoscope is directly responsible for causing that increase in blood pressure, which can precipitate an intracranial hemorrhage. In producing an intracranial hemorrhage, what is more important? Systolic blood pressure or diastolic blood pressure? Systolic. Studies have shown that it is the systolic blood pressure which is far more important as a predictor of occurrence of intracranial hemorrhage than the diastolic blood pressure. Okay, and then once we discuss GA, we'll talk about how to attenuate these reflexes. Now we are listing the problems. One problem you said was occurrence of a difficult airway. Then you said laryngoscopic response. Any other problem?
This patient might be having deranged coagulation profile. So,
Okay, so
it will affect my
right.
choice of anesthesia.
It will affect your conduct of anesthesia. So deranged coagulation.
Then
What
these
else?
patients are more prone for pulmonary edema. So I have to be careful about the
Increased
fluids.
chance of developing pulmonary edema, which has its own influence. In GA also, that is, if the patient comes with pulmonary edema, it will decide your course of anesthesia. Intraoperatively, preoperatively, you can precipitate pulmonary edema. So it affects your conduct of anesthesia. What else?
And then the patient is on magnesium, it will interfere with my drugs.
Very good. If the patient is put on magnesium, it will affect your conduct of anesthesia because it has wide-reaching influence on drug interactions. We'll discuss that also. Okay, so she has multiple drugs on her which can affect the conduct of anesthesia. What else?
And magnesium
So
can
she had.
also.
We'll come to magnesium. So she has magnesium therapy, which will have drug interactions. She has liver dysfunction. She has renal dysfunction problems, which will affect your conduct of anesthesia. So somebody asks you to list the concerns, or your question, long question says anesthetic concerns. You should be able to list all these one by one. These are your concerns in anesthesia. Now you have this patient who comes to you now, say her BP is 180 by 110. Okay. She has been put on tablet labetalol, as you said, and she's taking it irregularly. And she comes to the emergency with headache and say some amount of photophobia. For the past 2 days, she's having headache, she's having photophobia, she's on irregular therapy. When the obstetricians see her, her BP is 180 by 110. They call you for expert advice. What are your goals of management now, and how will you achieve them? Jaldi karenge, Praveen.
My primary goal in this patient will be to control the BP and to prevent the occurrence of seizures.
Okay, your primary goal is to control the blood pressure and prevent occurrence seizures. Other goals of management: evaluation of and correction of coagulation status. Okay, these are also your goals. Now, how will you control her blood pressure?
First, I will start her on labetalol.
Okay, how much?
20 mg
by
IV.
what route? Huh?
20 milligram. 20 milligram intravenous route. Then I will wait
Bolus
for 10
infusion?
minutes.
Bolus infusion? Bolus. Over
Bolus.
how long? Bolus over how long?
Rapidly.
Immediately, rapidly. Bolus over 2 minutes.
Okay.
A bolus of labetalol 20 milligrams given over 2 minutes. Kitni der baad blood pressure loge?
Ma'am, after 10 minutes.
After 10 minutes. Then the BP is not controlled. What next?
Then again I will give labetalol 40 milligrams.
Now you will give labetalol 40 milligrams IV over a period of 2 minutes. Take the blood pressure after?
10 minutes.
After 10 minutes, BP is still not controlled. What next? What next? The internet connection is not stable. Then what? After you've given 40 milligrams, the BP is still not controlled.
Ma'am, then I will go for 80 milligrams. Labetalol.
Okay. Now you will give 80 milligrams third dose labetalol over 2 minutes. So the BP has marginally decreased. From 180, it has become 170 systolic. Systolic is still 100. What next? You've given 20 milligrams. You've then given 40
Next also
milligrams.
I can repeat that.
You can now repeat 80 milligrams. Okay, the BP is still not coming down. The BP is still not coming down. How long?
I would like to. Then the recommendation is to start hydralazine, ma'am.
Okay, now you will shift to another drug. So that means if you have started labetalol, you can start in a dose of 20 milligrams. After 20 minutes, you can double it to 40. After 20 minutes, you can double it to 80. You can repeat a dose of 80. But if all this does not bring down the blood pressure significantly, this is the time to shift over to a second antihypertensive, which is hydralazine. You will start with how much hydralazine?
5 milligram hydralazine through intravenous route.
No, if you have already given labetalol for so long and not had a rise in fall in blood pressure, you will give 10 milligrams of hydralazine. If the initial drug had been hydralazine, if your first choice of drug had been hydralazine, then the first dose is 5 milligrams. Okay, when you shift over to a second drug, the first dose is 10 milligrams because already there is no response to. This is what the ACOG guidelines say. Okay. Now, if you had started hydralazine as a first dose, as a first drug, then you would have given 5 milligrams. If there was no response, what do you do?
And then after 20 minutes, I will again
repeat how much? 5 milligrams.
Ma'am, repeat 5 milligrams.
Okay. And then measure the blood pressure after
20 minutes.
20 minutes. If no response, what will you do?
Then we can give hydrogen up to maximum of 20 mg. So
20 mg. So if you've given 5 milligrams, wait for 20 minutes. In labetalol, you measure the blood pressure after every 10 minutes. In hydralazine, you measure the blood pressure after every 20 minutes. So 5 milligrams, wait for 20 minutes, repeat the blood pressure. If it doesn't fall, give 5 milligrams again, 20 minutes, 10 milligrams. Again, if you measure the blood pressure and it does not come down, you change over to labetalol. So 20 milligrams of hydralazine maximum, and then shift over to labetalol. When you shift from hydralazine to labetalol, the first dose is 40 milligrams. Okay. And the measurement on labetalol is every 10 minutes. In hydralazine is every 20 minutes. Now, is there any alternate drug other than hydralazine and labetalol which you can give?
Sorry, ma'am. I couldn't hear you.
Does nifedipine have a role? Does nifedipine have a role?
Yes, ma'am. We can use 10 milligrams per hour.
Yes.
Up to
As
maximum 50
per
mg.
the recent ACOG guidelines and NICE guidelines, oral nifedipine, not sublingual. Sublingual is totally contraindicated, but oral nifedipine is as effective as hydralazine and labetalol given intravenously. Okay, you can give 10 milligrams followed by 20 milligrams, followed by 20 milligrams to a maximum of 50 minutes apart. Okay, now what blood pressure are you aiming at? Till what do you want the blood pressure to fall?
Systolic blood pressure less than 150 and diastolic less than 100.
Okay,
And
so
diastolic
range
should
of
not fall below 80.
Yes, so 140 to 150 systolic and up 90 to 100 diastolic. How rapidly do you want the blood pressure to fall? ये सब तुमने drug शुरू किया. How fast do you want the BP to fall? Is there any guideline, any recommendation?
I'm not aware of that.
Okay, so it is recommended that the fall in blood pressure be between 15 to 25% in the first half to 1 hour. Not more than 25% fall of the patient's blood pressure in the 30 minutes to 1 hour. The remaining 6 hours, you can bring the blood pressure down further with an aim to bring it to 140/50 systolic and 90 to 100 diastolic. Anything else which you should be careful when you're starting these antihypertensives?
The patient should not throw seizures. So
no, should not cause seizure. उसको क्या करोगे? अगर उसने seizure throw कर दिया तो घर भेज दोगे?
No, ma'am. I will start.
I don't want you to throw seizures. Take care of. I'm happy. Anything else you would like to do when you start these antihypertensives? We'd like to ensure that the patient has replenishment of her intravascular volume simultaneously. The patients are hypertensive, but they have very, very severe vasoconstriction and intravascular volume is hugely depleted. And believe me, the gynecologists do not give fluids. They're very scared seeing the BP case. Ka to BP already 180 hai, isko fluid kyun dena hai? So you have to give some amount of fluid to these patients. Make sure that the intravascular volume is slowly replenished when you give these antihypertensive agents. You do not want a rapid fall in blood pressure, and you do not want an excessive fall in blood pressure. For what reason? Why? Why don't you want the BP to fall? I mean, you give one drug and it falls to 150, you should be happy. Why are you wanting this gradual fall and not below 150?
And because cerebral autoregulation has been set to a higher value.
Okay, very good. One, their cerebral autoregulation curve has shifted to the right, which means that what is hypotension for them is different from what is hypotension for other patients. They will develop hypotension and decreased cerebral perfusion at a much higher blood pressure as compared to normal patients because the curve has been set and shifted to the right. Anything else?
And then sudden hypotension will also compromise the uteroplacental blood flow.
Very good. It's going to compromise the uteroplacental circulation because the uteroplacental circulation is not autoregulated. The uterine blood flow increases in pregnancy. It increases maximum during term. but the uterine blood flow is not auto-regulated. The placental circulation is not auto-regulated. It is dependent on the pressure head. It is dependent on the total blood pressure the mother has. That determines the intervillous blood flow. So rapid crash in the maternal blood pressure will decrease the pressure head and affect the uteroplacental circulation, which you do not want because it is not auto-regulated. Okay, now you've started these drugs, you've produced a fall in blood pressure, the blood pressure has started following. What is your frequency of measurement of blood pressure? तुमने वहां अपने first year PG को बिठा दिया कि इसका BP measure करके मुझे बताओ. How frequently is he supposed to measure that blood pressure?
At least every 15 minutes.
Okay, every 15 minutes, he has to measure the blood pressure every 10 minutes for the first half an hour, every 15 minutes for the next 1 hour. If the BP remains stable, every half an hour for the next 1 hour, and then every hour for the next 6 hours. These are ACOG guidelines. Every 10 minutes, stable for half an hour, every 15 minutes, then every half an hour, and then hourly for the next 6 hours.
Okay.
Okay, as per the OCG. Up fluid, you said I want to give a little bit of fluid to fill up the intravascular space. How much fluid is fluid? How much do you want to give? 1 to 2 ml per kg. Not more than 80 ml per hour. Approximately 1 to 2 ml per kg is enough fluid to expand the intravascular space. If the patient has simultaneous oliguria, this will respond to another fluid challenge. If the oliguria does not respond to fluid challenge, that is one indication for going in for invasive blood pressure monitoring. Okay, would you like to give fluid as crystalloid or colloid? Crystalloid or colloid? What do you want to give?
Crystalloids.
Crystalloids. So balanced salt solution, isotonic, glucose-free, balanced salt solutions are the fluids of choice. Amount 1 to 2 ml per hour. Look for the urine output and monitor the blood pressure. Do not give glucose-containing fluid. It produces hyperglycemia in the mother and hypoglycemia in the baby. Do not give colloids. These patients have a propensity to develop pulmonary edema. And if they do, colloids will make it worse in spite of increasing the colloid oncotic pressure, osmotic pressure. Okay. Now, the BP has almost got controlled, but it is in the process of being controlled. And the obstetrician comes and says that there is very rapid fetal decelerations. The mother is exhibiting fetal decelerations and they want to do a section now. The BP is not very well controlled. It's still high. What is your choice? How will you investigate this patient now? And what is your choice of anesthesia? So say her BP is still 160 by 100, as is your patient, 160, 100 is the BP. How will you investigate her and take her up for a section? What is your choice of anesthesia?
Yes, ma'am. I would like to ask for a complete blood count, including hemoglobin, hematocrit, total leukocyte count, and platelet count. Okay. If the platelet count is more than 1 lakh, I don't want a coagulation profile.
Okay. Okay. If the platelet count, but still, first initial karvaoge ki nahi, irrespective of what the platelet count is, would you like to first initially get a PT-INR also done, coagulation? Yeah. Don't say that you will not like to get anything done, please. Okay. At least for a PIH with severe features, एक baseline coagulation तो करवाओगे ना? Okay. So 1 hemogram, coagulation profile.
Then peripheral smear.
Peripheral smear. Right.
Then,
what else?
Liver function test.
Liver function test, including bilirubin and serum proteins and enzymes.
Yes, ma'am. Kidney function test.
What else? Kidney function test, including urea, creatinine, uric acid, urine albumin, sugar.
Yes, ma'am.
What
then
else?
I will ask for urine analysis to see the.
Urine albumin sugar ho to kya? Or?
Blood grouping and cross matching.
Blood grouping, cross matching.
Blood grouping and cross matching.
What else?
ECG.
ECG. Okay. ECG will tell you the heart rate. It may tell you rhythm abnormalities. You're going to give her magnesium. You would like to have probably a baseline level. Okay. So you will get all these investigations done. And then what is your choice of anesthesia? Any drug which you should have started along with the antihypertensives? in this patient who was having
Ma'am, I would have
magnesium sulfate.
magnesium sulfate.
Magnesium sulfate. What is the dose of magnesium sulfate you would have started it?
Ma'am, I would have started the patient with 4 gram IV magnesium sulfate over 10 minutes, followed by 10 gram IM.
Followed by 1 gram.
Then every
You-
4
you
hours, I
want
would like to give 5 gram.
You like to give the IM regimen as an anesthesiologist. You want to follow the Pritchard regime in a patient who is probably going for section or has such severe hypertension. You are not a gynecologist. Would you like to stick to the IV regimen? I would prefer that you stick to the IV regimen. None of the anesthesiologists actually follow the Pritchard regime, which is IM. Only the gynecologists do it, and I still fail to understand why. They are scared of giving IV magnesium and they give 4 times the dose in IM. See, when they give IM drug, they give 4 gram bolus IV, then they give 5 gram in either buttock, which is 10 grams. So 5 plus 10, 4 plus 10, 14. And then they give 5 gram every 4 hourly. They give much more than you would have given in a controlled IV infusion. So you start with 4 grams IV bolus, followed by infusion of 1 gram. Then you must know how magnesium, it's very theoretical, but you must know how magnesium sulfate acts. What are the therapeutic levels of magnesium? What is the therapeutic level?
4 to 7 milligrams per liter.
4 to 7 milliequivalents. How does the milliequivalent correlate to milligram? How many milliequivalents is equal to milligrams of Maxulf?
I'm not sure about it.
Because some books say milligram 1.2. 1 milliequivalent is 1.2 milligrams. So you must know what is the therapeutic level and what are the toxicity levels. How do you monitor this patient on Maxulf?
Ma'am, first I would monitor the respiratory rate of the patient. Then I will look for the urine output. Then deep patellar reflexes.
Urine output. What should be the first?
Urine output.
No.
Patellar reflexes.
No. Patellar reflexes should be the first in your list. Patellar reflexes, urine output, heart rate with ECG, and magnesium levels. What is the first to go when toxicity begins? What is the first sign? Patellar reflex. So that you should be in the first in the list. No, patellar reflexes starts going at what level of magnesium?
Ma'am, 7 to 10 milligrams per liter.
No, 10 to 12. More than 10. It's more than 10. So 10 to 12 milliequivalents per liter. The patellar reflexes go. And then you have respiratory arrest at what level?
Around 10 to 13.
So it's a guessing game you play with the examiner when he asks you these questions with the levels. So
even
if you can't remember, let's make it very simple. Different books give different thing. You remember something, you say something else. 10 is patellar, 15 is respiratory, 20 to 25 is asystole. So, okay, 10, 15, 20, you can remember, you won't go wrong. So if there is toxicity, what do you do?
First I will stop the magnesium infusion. Then I will give 1 gram of calcium. Then I will give calcium gluconate.
1 gram of 10% calcium gluconate over a period of 10 to 20 minutes and support respiration if required. Give oxygen if required. So everything about magnesium you should be able to say. Therapeutic levels, mechanism of action, toxicity, management of toxicity, and what interaction does it have with your anesthetic agents?
Ma'am, it will potentiate the action of both the depolarizing muscle relaxants and non-depolarizing muscle relaxants.
Does it actually potentiate non-depolarizers also? Or depolarizers? It increases the duration and it enhances the onset and increases the duration of non-depolarizers. But it does not do anything to the first bolus dose of depolarizers. So, succinylcholine can be given in the required doses. Okay, mechanism of action, you please read from the book of how magnesium sulfate acts. Okay, so now this patient has been started on magnesium. This patient has been started on antihypertensives. This patient has to be taken up for a section. You've done these investigations. What is your choice of anesthesia?
Ma'am, if the platelet counts and coagulation profile is fine, I would suggest I would like to go for regional anesthesia, which is the subarachnoid block.
INR is 1.5, platelet count is 95,000. What is your choice of anesthesia? Regional?
Yes, ma'am.
What is the advantage of regional anesthesia over GA?
Ma'am, we will be avoiding the difficult airway and aspiration risk.
Okay. Yes.
Then
Avoiding GA, avoiding aspiration risk.
Then GA is said to have more chances for postpartum hemorrhage also, and we will be avoiding the intracranial hemorrhage
Okay.
associated with
So
laryngoscopy.
you don't avoid intracranial hemorrhage, you avoid response to intubation.
Yes, ma'am.
You avoid the problems of aspiration, all the problems with GA, all the problems of aspiration, problems of difficult airway, problems of laryngoscopic response to intubation, multiple drug interactions which occur because of GA. You will avoid that. You have better pain relief. The most important part out of all this is that you have better uteroplacental blood flow. The intervillous blood flow will improve with regional anesthesia as compared to general anesthesia. The neuroendocrine response, which is a very characteristic feature of general anesthesia, can be avoided. And transient respiratory depression in the neonate can also be avoided. So better uteroplacental flow, transient neonatal depression is avoided, better postoperative pain relief, avoid stress response to surgery, avoid all the complications of GA, laryngoscopic response, etc. So all these are advantages of regional anesthesia. Out of regional, which will you choose? Spinal or epidural?
Now, in this patient, I will choose spinal anesthesia.
Why spinal and why not epidural?
This patient is having fetal distress and INR is 1.5.
Is that the reason? Is fetal distress the reason?
Epidural has more cancer.
Is fetal distress the reason?
No.
The single shot epidural
My main is like quite different from it.
Any neuraxial block, spinal anesthetic is far simpler. It's easy to give, it's faster, it's shorter, it has a definitive endpoint, does not produce a patchy effect, and the trauma that you cause with a thin needle is far less than you would have caused with the larger epidural needle. And the coagulation profile is very dynamic. Currently, the platelets are 95. By the time you take her up for surgery and start the surgery, probably in 1 hour, it may have come down to 80,000. Okay, so spinal, the best choice, best epidural because reasons. Are there any concerns in spinal anesthesia that should be of importance to you? Any concerns in spinal anesthesia? You've decided you want to give spinal, you want to give regional, not GA. Amongst the regional, you decided you want to give spinal for its advantages as compared to GA. In spinal, are there any concerns that you have? One is the proposed hypotension that occurs with spinal anesthesia, right? So in epidural, in spinal anesthesia in eclamptic patients, the incidence of hypotension is far less as compared to non-pre-eclamptic patients. Okay, the normal pregnant patients who are normotensive have far greater fall in blood pressure as compared to pre-eclamptics who undergo a spinal anesthetic. This is because of larger circulating number and amount of vasopressors. And in not, some people say that it is a decrease in uterine size because these patients have IUGR. They have smaller uterine size and smaller baby size, smaller gestational babies. That's why they have less hypotension because the iotocaval compression is less. But there are studies which have shown that this is not true. It is the preeclampsia per se which is responsible for the decrease in less incidence of hypotension. And even if hypotension occurs, it is very minimal and easily brought back to normal levels with small doses of vasopressors. Which vasopressor will you give if there is some amount of hypotension during spinal?
Phenylephrine.
How much?
25 to 50 micrograms.
Okay. 25 to 50 mics of phenylephrine. Even ephedrine is a good drug. It's not bad. 2.5 to 5 milligrams of ephedrine can be given. 25 to 50 mics of phenylephrine can be given. What about fluid preloading related to spinal?
I will try to avoid. I will go over the way.
You have to give some amount of preload. Cardiac output studies in these patients have shown that they are vasoconstricted. If you do not give some preload, they will have a greater fall in blood pressure as compared to giving preload. So small amount of preload can be given. 250 to 500 ml of crystalloid can be given as preload, but you have to be very careful and monitor. Do not overload.
Okay.
See, the hypotension which occurs is a direct correlation with the amount of bupivacaine you give. It is a reflection of the dose of bupivacaine which you give. Since you end up giving less dose of bupivacaine in cesarean patients these days, along with an additive, the hypotension produced will be less. Also, because as we've said, the circulating factors are higher, the sensitivity is higher, these patients will have less hypotension. And if you further reduce the dose of bupivacaine by using an additive, the amount of hypotension will be less. You don't need too much of fluid in them. They will not have hypotension. But some amount of preloading, 250 ml of fluid crystalloid can be given. Okay. Now, and as you've said, ephedrine and phenylephrine both can be used for treatment of this hypotension. Agreed? Anything else about regional anesthesia which is of concern? You were talking about the platelet count. As you probably wanted to say, we're running out of time, so I'll just summarize it for you. Platelets counts more than 1 lakh are safe. Platelet counts less than 50,000 are unsafe. No regional is to be given if the platelet count is less than 50,000. Between 50,000 to 80,000, which is the cutoff value, it is a patient-to-patient decision. If you think that it's a patient who is full stomach, who has a difficult airway, probably regional will be better as compared to GA, you go give regional. But platelet counts prior to giving a regional are required. So if the platelet counts are falling, at least 1 to 3 hours prior to the spinal anesthetic, you must have a platelet count. If the platelet counts are stable and they're not falling, then the last platelet count can be 6 hours prior to the spinal. But if the platelet counts are rapidly falling, then the last platelet count should be at least 1 hour prior to giving the spinal anesthetic. And in case the platelet counts are falling, as we said, spinal is a better option as compared to epidural. You cause less trauma. The other thing that is you need to be careful when you're giving a spinal, as I've said, is you should give with a thin needle. Only an expert should give it. Minimal number of attempts. First pass success rate should be high. And give a low dose of local anesthetic so that you can monitor these patients for the development of an epidural hematoma in the post-op. Regular neurological monitoring every 2 to 4 hours in the post-op for the first 24 hours should be done to monitor if any epidural hematoma develops. Okay. Now, if this patient had thrown a convulsion, suppose this patient of yours with a BP of 160 and 100, she had thrown a convulsion at home and then come. She threw a convulsion, had this headache, photophobia, rise in blood pressure and came. What will be your choice of anesthesia? You just take 5 minutes.
Check the patient's consciousness level.
Okay, very good. You will see the patient's consciousness level. Anything else?
Consciousness level.
Anything else? So you have to see whether the patient falls into the category of what is known as stable eclampsia. A stable eclamptic is a patient who's had a convulsion, say 10 to 12 hours prior. Now the duration has been reduced to almost 6 hours prior. If the patient is fully conscious oriented, there is no obtunding of her higher mental functions. It means that her ICP is normal. Okay. You can also do a fundus examination to see that there is no increase in ICP. So conscious patient without any rise in ICP, once you put her on Magsalv, put her on antihypertensive with adequate amount of urine output and no other significant systemic dysfunction, including coagulation system, platelet counts more than 80,000, falls into the category of a stable eclamptic. And a stable eclamptic can be given a regional new GA has all these sorts of, it's only when a patient actively throwing convulsions, has thrown a convulsions just previously, her consciousness status is deranged, only then you should go for GA. The other indications for GA in such patients is a patient who has very rapid and acute fetal distress like cord around neck, maternal hemorrhage, severe coagulation dysfunction in the mother. These are the only indications for giving general anesthetic in the mother. Then when general anesthesia is given, your examiner is going to ask you about how you deliver general anesthesia, what airway assessment will you do, which you've already done, what difficulties in airway you are anticipating, how you will give Sellick's maneuver, what is the advantage of Sellick's maneuver, etc. You should be able to describe the technique of general anesthesia in stable acclimatic if you are, or an unstable patient if you're deciding to give her general anesthesia, and compare general anesthesia with regional anesthesia. Okay, what post-operative pain relief will you decide for this patient? Suppose you're giving her GA. She threw a convulsion, or her platelet count is now, say, 60,000. She has thrown a convulsion. She's unstable. You've given her GA. Okay. What pain relief measures would you like to take for her?
I would like to give her paracetamol, and NSAIDs I will prefer over opioids.
Why do you want to give her NSAIDs when she has borderline renal dysfunction? She's gone into HELP. Ye to help you, na? She has coagulation dysfunction, she has convulsions, she's now severe pre-eclamptic. So why do you want to give her NSAIDs when her renal function is probably just borderline? Maybe her creat is 1.2 or 1.4. Can you give her a block or
Yes,
no, with coagulation dysfunction? So this is the next area of discussion with your examiner. You can give her a tap block. But remember, whenever you give a block, even for block, the coagulation should be okay. There are no separate guidelines for peripheral nerve blocks. Same guidelines as for central neuraxial block are followed for a tap block. So if a severely dysfunctional patient with coagulation dysfunction, probably you would like to avoid any block. For that patient, paracetamol or a fentanyl infusion in the post-op will probably be useful for pain relief. It's only when the coagulation is okay that you can give ultrasound guided nerve blocks. Whether you want to give a tap block, whether you want to give a ilioinguinal iliohypogastric block, the coagulation should be okay. So all the ASRA guidelines which define coagulation and blocks should also be read by the PG. Okay. So regional versus spinal, advantages of spinal, management of hypotension, problems with general anesthesia, pain relief, management of a convulsing patient, MagSalf, all of this should be covered at least theoretically when you are preparing for a patient of PIH. Okay, what care will you take in the post-op? What about post-op?
In this patient, I will continue the antihypertensives and magnesium sulfate for at least 24 hours.
You will continue magnesium sulfate for at least 24 hours. There is some recent literature which says you can continue it for 12 hours also, but majority of your textbooks say you will continue magnesium sulfate for 24 hours after the last convulsion or after delivery, whichever is later. Continue antihypertensives, continue monitoring of blood pressure, monitoring of urine output, monitoring of magnesium levels, and respiratory rate, heart rate, and patellar reflexes. Another problem with GA, which you had not outlined, was that in GA, it is difficult to detect a convulsion under anesthesia with muscle paralysis. It is very difficult to detect a convulsion. It's easier to detect a convulsion under spinal anesthesia as compared to general anesthesia. Okay, and you should be able to tell the examiner what are the second line of drug if the patient continues to throw involution in the post-op. After magnesium sulfate, after the infusion, loading dose, if she continues to throw a convulsion, then which is the second line of drug you would like to add?
Diazepam, phenytoin.
Pens or diazepam. Very good. Midazolam infusion probably. If it's still not controlled, then probably phenytoin. And lastly, thiopentone. Okay, so monitoring of these patients in the post-op and continuation of MagSalf and antihypertensive with fluid status should continue. Anything else? We've already run out of time. Tina's looking furiously at me from the side because she has her small presentation to make. Any questions from the students or any question from you, Praveen? Somebody is asking me, what is the minimum platelet count in spinal anesthesia? As per the guidelines, the cutoff is 80,000. Between 50 to 80,000 is a clinician's decision depending upon the advantages and disadvantages of the particular patient. Below 50,000 is absolutely contraindicated. Somebody else is asking, what is the dose of magnesium IV? The dose of magnesium IV is 4 gram to 6 gram intravenous bolus over a period of 20 to 30 minutes, followed by 1 to 2 gram IV infusion. If there is a repeat convulsion, repeat the bolus of 4 milligram, but in the first hour, do not exceed 9 grams of magnesium sulfate. That is the maximum bolus dose in first hour of magnesium sulfate that you can give. Any other questions, Tina, in the chat box, which we've missed? So we've generally covered antihypertensives, we've covered magnesium, we've covered spinal, we've covered regional anesthetic. You can also be asked something about labor analgesia. Please read labor analgesia, the first stage, the second stage, what is the drug you will give, what infusion will you give, and the advantages of epidural in a patient who's coming to you with PIH. Then GA/spinal, the complications, postoperative management, and management of an eclamptic patient. Any other question? Ma'am, do you want to add anything? Mohandeep, ma'am, do you want to add anything?
Dr. Anju,
thank you for this wonderful opportunity.
Yes, Dr. Anju, I am really pleased with this case presentation. And I really hope the PGs must have gained a lot. And from, the teachers and faculty like you in the chair, it is always an honor. Thank you so much, Dr. Anju.
Thank you so much. Thank you, ma'am. Thank you, ma'am. Thank you. Thank you. I hand over to Tina for continuation of a short presentation for 5-7 minutes to sum up the case. Thank you so much, Praveen. You did a fantastic job. My best wishes to you. Thank you.
Thank you, Ranju ma'am. Good afternoon, everybody. I will quickly summarize the presentation. In this case,
Unmute ma'am, please. Unmute ma'am. Unmute, please.
She's not audible. Dr. Tina is not audible.
ma'am, am I audible now?
Yes. You're audible. Yes.
Ma'am, I've unmuted. Am I audible now?
Yeah, yes,
Please
ma'am.
continue, please.
Okay. I'll begin my presentation again. I'll quickly summarize. Now, for preoperative assessment for such a case, detailed history and examination is to be done. Investigations, complete blood count, urine routine microscopy, 24-hour specimen for protein and creatinine clearance, liver function test, kidney function test, blood urea nitrogen, serum creatinine, uric acid, serum electrolytes, BT, CT coagulation profile to be done, blood grouping and cross-matching to be done. Neuraxial anesthesia is preferred. Hyperbaric bupivacaine with fentanyl is the drug of choice. Now coming to the advantages of neuraxial anesthesia. Neuraxial anesthesia avoids the possibility of difficult tracheal intubation, avoids the hypertensive response to laryngoscopy, tracheal intubation, and extubation seen in GA cases. So risk of intracerebral hemorrhage is reduced. There is decreased blood loss and PPH. It improves fetal placental blood flow. We have a better fetal outcome. Spinal is much better than epidural. We have a smaller needle size. There is less trauma, less chances of epidural hematoma. Faster onset, and spinal, there is more reliable anesthesia. Traditionally, the view was that spinal anesthesia causes sudden onset of hypertension due to sudden onset of sympathetic blockade. But we have seen that spinal anesthesia causes lesser hypotension in preeclamptic versus the healthy patient. The vasopressors which we can use are ephedrine 5 to 10 milligram IV or phenylephrine 25 to 50 microgram IV. Restrictive fluid therapy is to be used. 500 ml of crystalloid preloading can be done. The general consensus regarding platelet count is that platelet count more than 80,000, neuraxial procedures are preferred. With platelet count less than 50,000, neuraxial procedures are avoided. For platelet count between 50 and 80,000, the risk and benefit of neuraxial versus GA is to be assessed. Suggestions for I'll just continue. Suggestions to reduce the chances of epidural hematoma with platelet count less than 1 lakh. The most skilled anesthesia provider available to perform, and spinal is much better than epidural. We monitor for the neurologic signs. Imaging studies and neurologic or neurosurgical consultation can be done whenever there is doubt of epidural hematoma. Platelet count should be at least 75,000 to 80,000 before removal of the epidural catheter. Labor analgesia. Continuous lumbar epidural or combined spinal epidural CSE analgesia are the preferred methods for labor analgesia. The advantages are it gives high quality analgesia which attenuates the hypertensive response to pain. There is reduction in circulating catecholamines and stress-related hormones, improvement in intervillous blood flow, and we have a means for administration of local anesthetic for emergency cesarean section. Considerations before administration of labor analgesia: assessment of coagulation status is to be done, intravenous hydration before the epidural administration of a local anesthetic, treatment of hypotension, use of epinephrine containing local anesthetic solutions. Local anesthetic solutions containing epinephrine should be avoided. Now coming to general anesthesia is preferred in whenever patient maternal hemorrhage is going on, severe ongoing maternal hemorrhage, sustained fetal bradycardia with a reassuring maternal airway examination, severe thrombocytopenia or coagulopathy in cases of sepsis, and those who refuse for a regional block. The problems of general anesthesia: they are difficult airway, risk of aspiration, stress response to laryngoscopy, intubation and extubation, exaggerated response to sympathomimetics and methyl ergonovin, uterine atony and PPH, greater sensitivity to non-depolarizing muscle relaxant with magnesium therapy, and fetal compromise. Now, the anesthetic implications of a patient on magnesium sulfate. Most important is interaction with the muscle relaxants. Non-depolarizing muscle relaxant, there is increased potency and duration, so smaller doses should be used. Monitoring. The mechanism of action: it inhibits the presynaptic release of acetylcholine at the neuromuscular junction, decreases sensitivity of presynaptic receptor to acetylcholine, depresses the excitability of the muscle fiber membrane. Depolarizing muscle relaxants: the onset and duration of a single intubating dose is not changed. Succinylcholine mimics acetylcholine at the nerve terminal. Now coming to the effects on uterine tone. Magnesium sulfate has a tocolytic action because magnesium depresses the smooth muscle contraction. The risk for uterine atony and PPH is much increased. Now, magnesium sulfate is used for seizure treatment and for prophylaxis. The mechanism of action is it acts centrally at the NMDA receptors to raise the seizure threshold. It has cerebral vasodilating properties. It is initiated with the onset of labor till 24 hours postpartum. For cesarean section, it is started at least 2 hours prior till 24 hours postpartum. Various regimes are there for magnesium sulfate. Pritchard and Zuspan are some of the common ones which are used. Pritchard regimen, we have a loading dose of 4 grams slowly within 3 to 5 minutes IV, followed by 10 grams deep IM. Now maintenance dose is 5 grams deep IM on alternate buttock every 4 hours. Zuspan, we give 4 grams IV in 100 ml of fluid over 15 to 20 minutes as a loading dose, and maintenance dose is 1 gram per hour in 100 ml fluid IV. The monitoring to be done when the patient is on magnesium therapy is deep tendon reflexes, respiratory rate, urine output, and serum magnesium levels. Now coming to the technique of GA. In such a case, we will titrate the systolic blood pressure between 140/90 to 160/110 before induction. Lower the MAP by not more than 15 to 25%. The antihypertensives which we can give to lower the blood pressure are labetalol, 20 milligram IV injection, then 40 to 80 milligram every 10 minutes up to maximum of 220 milligram. Hydralazine can be given 5 milligram IV every 20 minutes up to maximum 20 milligram IV. Nifedipine 10 milligram oral can be given every 20 minutes, maximum up to 50 mg. Thiopentone sodium or propofol either can be used for induction. Etomidate is preferred for heart failure patients. Succinylcholine is the drug of choice for intubation. Now coming to the measures to reduce the stress response. Labetalol 0.4 to 0.75 mg per kg IV is to be given 2 to 5 minutes prior to laryngoscopy and intubation. Magnesium sulfate 40 milligram per kg IV 1 minute prior can be given. Esmolol injection 1.5 to 2 mg per kg IV 2 minutes prior to laryngoscopy and intubation can be used to blunt the stress response. Now, smaller size endotracheal tube should be used and a difficult airway cart should be kept ready. For maintenance, a smaller dose of non-depolarizing muscle relaxant should be used. After delivery, we will decrease the volatile agent to prevent uterine atony and administer an oxytocin agent. Oxytocin 15-methyl prostaglandin F2 alpha is preferred. We avoid methergin because it can lead to hypertensive crisis. Magnesium sulfate or antihypertensive should be continued. For extubation, patient should be fully awake, following commands, and neuromuscular blockade should be fully reversed. The monitoring to be done in such a case is non-invasive blood pressure monitoring, pulse oximetry, ECG, respiratory rate, urine output, and fetal heart rate. Now coming to the invasive monitoring. The indications for invasive monitoring are discussed. Arterial line, the indications are severe refractory hypertension, use of rapidly acting vasodilators, hydralazine, sodium nitroprusside, frequent ABG samples, need for continuous BP monitoring during induction and reversal of GA, BP measurement difficult, like in cases of obesity. For CVP, persistent oliguria, difficulty in fluid management, or pulmonary edema are the indications. PA catheter, the risk-benefit ratio is to be assessed. Patients with congenital or valvular heart disease, severe multiple organ failure, or critical cardiovascular instability. Transthoracic echocardiogram, non-invasive monitoring for cardiac chamber size, wall thickness, ventricular function, and volume status. Now coming to the postpartum management, which will be done in the HDU or ICU setup. Adequate analgesia should be given. Strict input-output charting should be done. Continue magnesium sulfate for at least 24 hours. Continue antihypertensives and hemodynamic monitoring. Increased risk of OSA is there in these patients. So close monitoring should be there for generalized edema, airway swelling, snoring, and with obesity. Thank you everyone for a very patient. Now I hand over to Dr.
Just a minute, Devang. Thank you so much, Tina. There are two questions in the chat box which I would like to answer. There are some things which were not done in the case discussion, and Tina has covered them in her talk. These are indications for invasive monitoring, both CVP as well as PCWP. And invasive monitoring is not recommended in these patients unless there is a specific indication. Rather, TEE is a non-invasive monitor, which will tell you everything about the ventricular size and chamber size, the fluid status, and any other cardiac information you want can be done non-invasively with the TEE. The other thing which she has covered very well is the drugs which are used to blunt the intubation response. That I didn't discuss in the case one by one because it was all being covered in her presentation. So indications of invasive monitoring and pressure response every PG should know. The other thing I would like to highlight is why NP as routinely used by obstetricians is not a good drug to control blood pressure. They don't address the basic problem. See, SNP is a venodilator and your problem is arteriolar vasoconstriction. So don't use that drug. Plus, it produces fetal cyanide toxicity. Also, SNP produces cerebral vasodilatation and can increase the ICP in these patients, which can be really detrimental. Agent, and studies have shown that continuous use of NTG can increase the incidence of cesarean section. These are not drugs to be used for acute control of blood pressure. They can be used for control of laryngoscopic response. Two questions which are there in the chat box is the minimal platelet count for epidural, which is the same as we've mentioned for a spinal. The platelet counts in toto are the same for a central neuraxial block, whether you're giving spinal or giving epidural. Spinal is better because the needle is thin and the trauma is less as compared to a thicker 18 gauge 2-hit needle. The second question somebody wants to ask is how to detect a convulsion under general anesthesia. Now that is not possible. If the patient is under anesthesia, unconscious and paralyzed, it is very difficult to monitor and detect a convulsion under general anesthesia. That is the reason why spinal anesthesia is preferred many of these patients. If your patient doesn't wake up post-operatively, it will raise a query of why the patient hasn't woken up. Probably did she have a convulsion under GA? Is she having cerebral edema? Many of these patients who are given GA have delayed awakening, and one of the differential diagnosis you should keep in mind is the edema. We have a detailed paper from Harding which talks about the rapid occurrence of cerebral edema in patients receiving GA and how they need to be monitored by radiological means. Your examiner may also ask you some details of PRESS, which Praveen was trying to elucidate. You can please read the details of PRESS from your textbook, and that can be one of the causes of delayed awakening in patients post-operatively after GA. I think that sums up all the questions. Probably ETCO2 may rapidly rise under GA, but other than that, it's very difficult to monitor for convulsions under GA. Thank you so much. Thank you to Team Appec, and thank you to ma'am for having me over. It was a wonderful session, and I'm sure the students will benefit from the case discussion. Thank you and wish you a good day.
Thank you, Ranju ma'am. Thank you, Tina ma'am, for this in-depth discussion about the case. Thank you so much. I'm sure delegates would be much benefited by this discussion. Thank you. Now moving on, I would now like to invite for our next session, Major General retired Dr. Rashmi Datta. She is a professor and head Department of Emergency Medicine at Hamdard Institute of Medical Sciences and Research at New Delhi. Her special areas of interest are critical care, pain management, and obstetrics. I welcome you, madam.
Thank you very much. Am I audible? Am I audible?
Yes, ma'am, you're audible.
Thank you very much. It was an extensive and a very detailed lecture by Ranju, Dr. Ranju, and I'd like to compliment Dr. Mohandeep and her entire team for a wonderful session, which I've been seeing from the last about 2 days, and it will continue. It's an academic feast, and I'm sure all the PG students will really, truly benefit, and even I'm sure experienced people who are into the specialty will also benefit. Thank you very much for 2 things. Firstly, for giving me an opportunity to be part of such a wonderful program. And secondly, for giving me the honor to introduce somebody who actually needs no introduction, Dr. Anju Grewal. For those few people who may not sing, I'll just tell you about her. She's at present the professor and head at the Anand Medical College and Hospital in Ludhiana. She has varied interests, and that has been, and each interest she's gone into the depth of it. Her obstetric anesthesia, she's a founder member of, she's in part of the governing body of the Association of Obstetric Anesthetists. The airway management, she's been the founder member of the Airway Management Foundation in India. Her CPR, her scientific communications, trauma management and acute pain management has been extensively done. She's got so many papers and books and chapters to her credit. Most important, she has been associated with the Journal of Anesthesia and Clinical Pharmacology from 2002, and also has been the chief editor there. So without much ado, and I'll just hand over the mic to Dr. Anju. She'll be telling about obstetric patients for coming in for non-obstetric surgery. Dr. Anju.
A very good afternoon to my respected chairperson, Major General Dr. Rashmi Datta ma'am, respected seniors and dear friends. At the outset, I'd like to take this opportunity to thank the entire organizing team of Appec 2022, especially Dr. Mohandeep Kaur, for kindly inviting me to talk to you on anesthetizing an obstetric patient for non-obstetric surgery. I bring you greetings from the Anand Medical College and Hospital, the place where I work. In the next 30 minutes, we'll look at why are we talking about non-obstetric surgeries in an obstetric patient? Are there some fears of teratogenicity really founded? What are the timing and need for such kind of surgeries? And then, of course, we'll look at maternal and fetal safety concerns and with specific concerns for laparoscopic procedures. As we all are aware, that nearly up to 2% of pregnant women would need to undergo non-obstetric surgeries anytime during their pregnancies. And of the type of surgeries that they undergo, the usually common surgical procedures that we encountered are either surgical procedures secondary to obstetric or gynecological conditions like cervical incompetence or ovarian torsions, or more commonly, the non-gynecological surgeries for appendicular perforation, cholecystitis, trauma, and so on and so forth. The only thing we have to fear is fear itself. Now, what are the fears in our minds? In the minds of the patient are concerns mainly for her fetus in the form of pregnancy loss, preterm birth, or teratogenicity. Will the disease or the underlying surgical condition affect my fetus? This is what the mother thinks as she encounters this problem. How to safely give anesthesia while caring for 2 lives is a fear or a question that arises in the minds of an anesthesia provider, while the surgical provider is faced with the dilemma of when to allow non-elective, non-urgent surgery safely in this unique population of patients. We look at the fetal safety concerns or teratogenicity. We need to define what is teratogenicity. Any significant postnatal change in function or form in an offspring after prenatal treatment amounts to teratogenicity. And it can manifest either in the form of death, structural abnormality, growth restriction, or a functional deficiency. Now, if we look at the factors that influence the potential of any drug to be teratogenic, they are as wide and ranging from species susceptibility, a genetic predisposition, to the threshold of the amount or dose of exposure of the drug to the individual and the duration and timing of administration. And therefore, in humans, if we look at the varying period of gestation, structural abnormalities are more commonly occurring due to exposures during the period of organogenesis, which actually ranges from day 31 to 71 from the first day of the last menstrual period. The picture depicts the bars. The solid bars are the more vulnerable period, whereas the lighter bars are the lesser vulnerable periods. Functional deficiencies, as you can see here, may occur on exposure during late pregnancy till as long as second year of life, because the human brain continues to grow and marinate till the second year of after birth of life. Now, there have been various concerns and various literature reviews which have looked at maternal anesthesia and fetal neurodevelopment, have looked at teratogenic effects of various anesthetic agents, right? And so we really need to find answers to these questions. In 2016, the US FDA indeed issued a drug safety communication warning that repeated or lengthy use of general anesthetic and sedation drugs during surgeries or procedures in children younger than 3 years or in pregnant women during the third trimester may affect the development of child's brain. Now, this actually raised many questions, but we need to step back and look at literature reviews. We need to look at studies where they have more often found that the offenders can be pain per se due to the underlying deranged surgical pathophysiology or the deranged maternal physiology secondary to all the surgical issues that the patient is facing. Hence, if we look at the entire gamut of literature, there is still not enough adequate data to extrapolate all the animal findings to humans. And till date, no anesthetic agent has been shown to be clearly teratogenic or dangerous to human fetus in clinical doses. Indeed, the GAS and the PANDA trials, which were large trials and moved across larger time periods, determined that a brief single exposure to general anesthetic drugs in clinical doses does not lead to poor neurodevelopment outcomes in children, and therefore allaying our fears of both morphological teratogenicity as well as functional deficiencies. Hence, if as a composite result of all the outcome studies, they have found, which of course includes epidemiological studies, they have looked at prospective and retrospective data. None of the studies have found any evident increase in congenital abnormalities to offsprings of women who undergo anesthesia for non-obstetric surgical procedures. Indeed, there is a slightly higher incidence of growth restriction, low birth weight, fetal loss, and preterm labor. And these adverse outcomes can indeed be attributed, one, to the maternal condition which requires surgery. And this is more often exacerbated during pregnancy by diagnostic and therapeutic delays, with other contributing factors like procedure, this proximity of the uterus to the site of the surgery, the derangements in the maternal physiology which result into either severe hypoxemia, hypotension, hypercapnia, hypothermia, hypoglycemia. So all those 5 and 6 H's that we are talking about, which can eventually lead to fetal asphyxia and therefore growth restriction, low birth weight, fetal loss, or preterm labor. So what should be that, actually brings to our mind the question on what should be the optimal timing for surgical procedure to happen in a pregnant patient. Now, elective surgery should be deferred during pregnancy until 6 weeks postpartum. So we are left with necessary surgery or an urgent or an emergent surgery. Now, urgent and emergent procedures should indeed, as we understand, proceed without delay, regardless of the gestational age, because not doing them would pose more risk to the mother and the fetus. We need to remember that the period of organogenesis, as I alluded to previously, is between 3 to 8 weeks of gestation and is, of course, most concerning for all of us as being a potential teratogenic exposure period. Now, surgery during third trimester has raised concerns for an increased risk of preterm labor mainly. And of course, they will also have to consider administering corticosteroids to facilitate fetal lung maturity if indeed this patient ever goes into preterm labor during surgery in this trimester. So basically that leaves us with a period of second trimester as a period where necessary surgery can be allowed or permitted. So this is a period where the risk of teratogenicity and preterm labor are lowest. The uterus is small enough and does not interfere in the visualization of the operative field, and therefore there is less manipulation of the uterus per se itself, and therefore is the preferred time to undertake non-elective, non-urgent surgeries when possible, answering the question to the dilemma of the surgical provider. So if you look at this beautiful decision-making algorithm, if it's an elective surgery, we delay it until 6 weeks postpartum. If it is an essential or a necessary surgery, we look at the risks. If the risks to the mother are minimal or none, then we consider delaying it to mid-gestation. When I talk about risk, the risk to the mother because of the underlying surgical condition. If the risks to the mother are greater than minimal, right, because of the underlying surgical condition, say the mother is in malrotation of gut and the gut is obstructed now and is getting gangrenous, so, or there is an emergency surgery, we need to proceed regardless of the gestational time with an optimal anesthetic technique, which is modified according to the considerations of the maternal physiological changes and with a lot of emphasis on fetal well-being. We have to remember that while we are anesthetizing these two lives, our major concerns and goals are, one, to sustain the pregnancy post-surgery, and of course, look at maternal safety concerns and fetal safety concerns. And we look at fetal safety concerns, we really need to provide the fetus an environment where there is no impairment of the uteroplacental circulation and therefore fetal asphyxia would not occur. And two, we need to avoid factors that will predispose this mother to preterm labor or abortion. Now, as I said before, tailoring the anesthesia to the physiological adaptations of pregnancy is extremely important. We all understand that the mother does, pregnancy imposes physiological changes onto the mother, and therefore our aim would be to maintain hemodynamic stability, adequate uteroplacental perfusion, uterine relaxation, normothermia, normocarbia, and prevention of hypoxemia, which are the keys to sustaining pregnancy. So if I were to talk about 3 goals of this non-obstetric surgery as for an anesthesiologist would be 1, maternal safety, fetal safety, and sustaining the pregnancy. Now we come to the physiological adaptations of pregnancy and therefore look at them, how they would impact anesthetic management. And we all are aware that there are various physiological and anatomical adaptations that occurs during pregnancy to the mother across all organ systems. And these changes are mainly either hormonally driven, which occurs from the first trimester. They are also imposed because of the increased metabolic demands of the growing fetus, which are further compounded with the mechanical effects of the enlarging uterus during the second half of pregnancy. And of course, there are hemodynamic consequences of the low resistance placental circulation. So all of these contribute to the changes that we all need to evaluate and comprehend for our mother, right? If we look at the cardiovascular system, we all know that the cardiac output starts to increase and the blood volume both rise from the 5th to 8th week until 28 to 32 weeks to as much as 50% of the baseline pre-pregnant values. On the contrary, the systemic vascular resistance decreases because of the presence of that low resistance placenta and of course the effect of progesterone and prostacyclin. And this in combination with a 20% reduction in hematocrit, which leads to dilution and anemia. All these changes basically try to keep the hemodynamics in an optimal place for a pregnant mother. Now, anesthetizing this mother for a non-obstetric surgery will lead to a compromise, especially in the presence of anesthetic induction agents and maternal positioning. All of these together can compromise the pregnancy-induced changes in the mother. Of these, position takes major importance, and something that is many a times not alluded to very accurately by most of anesthesia providers. We need to remember that there is an entity called supine hypotensive syndrome, where there is a compression of the aorta and IVC, which leads to a decrease in the cardiac output by around 30%, leads to a fall in blood pressure and adverse maternal hemodynamics and fetal oxygenation if you were to induce and maintain anesthesia or the entire perioperative period, I would say, in the supine position for the mother. Hence, to correct it, we all know we need to provide a lateral uterine displacement, so which could either be in the form of a tilt in the table or a hip or a wedge beneath the right hip. Right now, what studies have found is that a 30-degree tilt relieves compression completely. However, at times this may not be conducible to do surgeries, and hence what is recommended is that a tilt between 15 to 30 degrees should be allowed. And the providers, both surgical and anesthesia providers, should note that they would need to, increase the tilt in case there are adverse maternal as well as fetal hemodynamics up there. In addition to that, there's an increased dependence on sympathetic nervous system as the pregnancy progresses, and this results in severe hemodynamic changes and an increased vasopressor requirement after a central neuraxial block. There is a compensatory downregulation of the parasympathetic nervous system at term gestation, and this attenuates the maternal hemodynamic response to spinal-induced sympathectomy and mitigates the bradycardia after spinal blockade. So, in absence of any contraindications, we really need an active management of hemodynamic changes in these mothers during induction, either after general anesthesia or after central neuraxial blocks, with the help of intravenous fluids and vasopressors, so much so that we can maintain the hemodynamics at baseline values at all times. The other major change that comes and affects anesthesiologists is on the respiratory system. We are aware that there is a restrictive ventilatory defect occurring because of the decrease in the FRC by the growing uterus, which splints the diaphragm, and this decreases by as low as 20% or more. And this would mean that there is a less reservoir of oxygen in the lungs. And as the mother becomes supine or is morbidly obese, or you put them into various positions, especially the Trendelenburg or the lithotomy position, this would further lead to a precipitous hypoventilation or desaturation and hypoxemia coming in, right? And compounded with the increased oxygen demand, all these things are going to occur very rapidly and quickly. We are also aware that there is an increase in the minute ventilation, mainly by the increase in the tidal volume. And therefore, there is a state of chronic respiratory alkalosis with some compensatory renal excretion of bicarbonate. This implies that there will be decreased buffering capacity of the mother during periods of hypotension or hypoventilation. And therefore, we really need to be careful while anesthetizing these patients. That would mean that as we induce general anesthesia to this patient, we need to meticulously prepare, plan, and execute the process, which means that we pre-oxygenate and para-oxygenate with a tight-fitting mask for a minimum of 5 minutes, and employ either a simple nasal prongs or a high-flow nasal cannula to have a simultaneous para-oxygenation occurring during periods of apnea, which helps an apneic oxygenation. In a head-up position, either in a head-elevated laryngoscopy or ramp position, that's a 20-degree head-up position, that would be ideal for these patients during pre-oxygenation. And during process of airway management, apneic flow would occur at all times. In the post-op period, it's extremely important to titrate your potent opioids so that there is no hypoventilation occurring. Remember, hypoventilation can cause fetal acidemia and myocardial depression. And on the other hand, hyperventilation, extreme hyperventilation, which leads to a carbon dioxide level below 23 millimeters of mercury, can indeed compromise uterine blood flow and fetal oxygenation. So you really need to have a balance. The increased minute ventilation that we talked about, and in combination with the decreased functional residual capacity, allows a faster equilibration of the inhaled agent. And we also need to remember that the MAC value of majority of the volatile anesthetic agents is decreased by as low as 30 to 40% during starting from early gestation, and therefore not only will be the induction of anesthesia accelerated, there could be severe hemodynamic effects coming in if you were to use higher MAC values for volatile agents. But this does not imply that we start to dose them lower on, because what has been reported is a high incidence of awareness occurring under anesthesia for these patients, and hence we need to titrate our anesthetic regimens very vigilantly. We also need to remember that whilst we are administering sub-anesthetic doses of either analgesics or sedative drugs or anesthetic agents, unconsciousness can occur quickly and unexpectedly, and hence we need to be vigilant at all times. The major contributor to failure or problems or complications that occur, especially hypoxemia, is because we all know that a pregnant female is 8 to 9 times more, has a more difficult airway than the non-pregnant counterpart. And this has been contributed, one, by generalized weight gain, presence of full dentition, fluid retention issues, which leads to edema of the airway mucosa, friability of the mucosa, and capillary engorgement. And of course, if the mother gets later on in the third trimester into labor, we know that the Mallampati scores keeps worsening as the labor progresses. So what you really need is proper planning, an expert airway team, and not individuals, but team on the floor. And you need to incorporate each step of airway management, from assessment, preparation, positioning, pre-oxygenation, having backup, and availability of video laryngoscopes that you are familiar to use with. All of them together is something that we really need to allude to our algorithms and have a successful airway management and avoiding hypoxemia in these patients. Compounding the difficult airway issues are the issues of increased risk of regurgitation and aspiration that start to occur from 18 to 20 weeks because of the decrease in the lower esophageal sphincter tone, either because of progesterone effect, and later on in the later stages of pregnancy and the last trimester of pregnancy because of the distortion of the gastropyloric anatomy. This is further compounded by increased gastric pressure from the gravid uterus or during bag mass ventilation. So all of these predispose this mother to increased risk of regurgitation and aspiration, meaning thereby that we really need to employ modified rapid sequence induction techniques with cricoid pressure, and of course need to give them antacid prophylaxis as well. We are all aware of the increased risk of thromboembolic complications that occur because of the increase in fibrinogen levels, factor 7, 8, 9, 10, 12, and FTP products. We know that there is a more predisposition to thromboembolic complications, and hence, wherever needed, sequential compression devices or pharmacological prophylaxis would be needed in these patients. And one of the most important hematological changes that we need to be aware of is benign leukocytosis. It's just what makes it difficult to differentiate it from underlying infection. But remember that this is something that you really need to look at in an entire clinical picture to come to an early diagnosis of the underlying surgical issues. Apart from that, there are certain altered responses to anesthesia. As I talked about earlier, the MAC of volatile anesthetic agents decreases because of the higher serum progesterone levels. There has been concerns on dosing of succinylcholine. However, we must remember that though the plasma cholinesterase level decreased by 25% from early pregnancy until 7th postpartum day, this is offset by a large volume of distribution, and hence the dosing needs to be as in a non-pregnant or a pre-pregnant time. But it is important that if you are if the mother is undergoing a prolonged non-obstetric surgery, monitoring the neuromuscular block with help of neuromuscular monitoring is important, especially at the time of extubation. There are concerns about decreases in requirements for thiopentone and sometimes in propofol, but these can be safely used by titrating them to end effects. Ketamine is one drug that needs to be avoided because of its property of tachysystole, especially in vulnerable parturients where there is chances of preterm labor are high. However, in such special circumstances, like, for example, in a hemodynamically unstable patient with reactive airway disease, we really need to look at the benefits outweighing the risks in these particular category while using ketamine, though it is best avoided. While employing regional anesthesia technique, we need to be aware that there would be an increased sensitivity to neuraxial and peripheral neural blockade because of the decreased local anesthetic dose requirement, which occurs secondary to anatomical, mechanical, and biochemical changes. And also there is an increased chances or risks of local anesthetic systemic toxicity occurring, especially during placement of epidural venous plexus, because we know that the epidural venous plexus distension occurs especially in the later stages of pregnancy. Hence, having understood and comprehended the entire anatomical physiological changes and the impact they have on the anesthetic management, we really need to approach this pregnant mother who is scheduled for a non-obstetric surgery by doing a thorough, detailed pre-anesthesia evaluation. And you really need to pick a technique which tailors to accommodate the maternal physiological changes, the presence of fetus by avoiding fetal asphyxia and maintaining the uteroplacental perfusion and fetal oxygenation at all times of the perioperative period. And therefore, we need to optimize maternal physiology, optimize the uteroplacental blood flow, avoid the unwanted drug effects, and avoid awareness. So we need to create a balance by titrating our drugs to proper effect, avoid any maneuvers or measures which can stimulate the myometrium, and therefore the whole game and the whole goal is basically to optimize oxygen delivery. General anesthesia would be needed for many procedures. However, where feasible and possible, depending upon the site of surgery, regional anesthesia techniques score better over general anesthesia techniques. Coming to monitoring, maternal monitoring would involve use of a non-invasive blood pressure, electrocardiography, pulse oximetry, capnography, temperature monitoring, and the use of peripheral nerve stimulator. And of course, we need to monitor the blood glucose levels at regular intervals. Fetal monitoring is extremely important. If we look at the ACOG recommendations, the ACOG recommends that continuous fetal monitoring be employed to all mothers who are beyond the gestational age of 24 weeks. However, it is important that a FHR be monitored either using an electronic fetal heart monitoring or a Doppler ultrasound before or after the procedure, the surgical procedures, regardless of the gestational age. And we need to add uterine contraction monitoring in a viable fetus. If you are going to employ continuous fetal heart rate monitoring in the entire perioperative period, we really need to have, one, the technical feasibility to do so. Two, there has to always be a presence of an obstetric provider who has a privilege to perform an emergency cesarean delivery should there be a need during the intraoperative period, and that the procedure should also permit safe interruption of the surgical procedure to provide access for an emergency cesarean section. So it's important that a provider who is familiar with the interpretation of baseline FHR and the anticipated changes that are associated with general anesthetic agents should be available. They should be able to understand that the loss of beat-to-beat variability and a decreased baseline FHR are going to occur with majority of the anesthetic agents, especially high-dose opioids or volatile anesthetics. And therefore, the provider should actually be very expert in interpreting these changes. FHR variability is a good indicator of fetal well-being beyond 25 weeks. A persistent change in the FHR, say a persistent fetal bradycardia or a sinusoidal pattern, are something that will tell you that there is a true fetal compromise. The good thing about fetal monitoring is that it can alert and help us to optimize and employ optimizing measures so that reversible causes of fetal heart rate variability, loss of variability can be addressed. Of the maneuvers that we can employ for intrauterine resuscitation during non-obstetric surgery, are increased left uterine displacement, increasing the oxygen concentration, treating hypotension. It's very important to maintain a target baseline blood pressure, coming back to your baseline blood pressure, releasing the surgical traction or manipulation or the abdominal insufflation, ensuring appropriate end tidal carbon dioxide, that is the pregnancy levels, that is 28 to 32, not good, not reaching hypo or hypercapnia, and of course looking at any aspects of blood loss, or the last would be to consider medications to improve uterine relaxation. That brings us to the question on the role of tocolytic therapy in these procedures. So published evidence does not support routine use of prophylactic tocolytics. Monitoring uterine contractions in the intraoperative period and in the postoperative period should be recommended, especially when the fetus is viable. And additional surveillance is necessary if we plan to give potent postoperative analgesics, especially for major surgical procedures. And magnesium sulfate is one versatile tocolytic agent which has also anticonvulsant and fetal neuroprotective agents. However, this decision needs to be done in consultation with the obstetric provider and, of course, the neonatal team together. Coming to a specific considerations in laparoscopies for non-obstetric surgery in obstetric patients, we have to understand that though there are advantages of shorter hospitalization, lesser postoperative pain, less risk of DVT, and faster return to normal activities, there is a downside in the form of possibility of uterine or fetal trauma, fetal acidosis because of absorbed carbon dioxide, and of course, decreased maternal cardiac output and uteroplacental perfusion from an increased intra-abdominal pressure. So there are a few recommendations that we must keep in mind for maternal and fetal well-being during laparoscopic procedures in these mothers. So one is preference to use an open method, especially during the second and third trimester of pregnancy, the Hassan's method for port insertion. Application of compression devices throughout the process and maintenance of left uterine displacement is extremely important and needs to be re-emphasized again and again. Insufflation and deflation should be gradual, and we must try to limit the intra-abdominal pressures to, I would say, less than 10 to 12, though they have been safely recommended range is 10 to 15 millimeters of mercury. Various surgical providers have also tried to look at gasless laparoscopic maneuvers as well. Our aim should be to ventilate our patients so that, one, the ventilation does not have any adverse hemodynamics, and two, it maintains your carbon dioxide levels between the end tidal carbon dioxide levels between 32 to 34 millimeters of mercury. All forms of maternal positioning, whether Trendelenburg or reverse Trendelenburg, should be managed very slowly and diligently and gradually. And of course, as I said again, maintenance of adequate volume status and hemodynamics is extremely important. In the post-operative period, these things will continue. So we will continue to give oxygen to our mothers with the help of nasal prongs or whatever, titrating to a SpO2 of at least 95% with a left uterine tilt at all times. Remember, adequate pain relief is extremely important because pain per se can also cause a risk of premature labor because it does lead to increase in uterine irritability and, of course, decreased uteroplacental perfusion secondary to increased levels of plasma catecholamines. So a balanced anesthesia balanced analgesia techniques employing regional nerve blocks wherever feasible should be employed. NSAIDs on the other hand should be avoided, especially if the surgery is done after 32 weeks of gestation because of concerns of premature closure of ductus arteriosus. It is pertinent to continue your obstetric consultation in the postoperative period for monitoring of fetal heart rate and uterine contraction activity. And indeed, we need to continue to employ sequential compression devices or DVT prophylaxis and try and have fast track these patients to early mobilization and ambulation. To just summarize, anesthetist needs to, as anesthesiologist, we need to adjust our plans according to the specific surgical context and the maternal. Of course, keep in mind this underlying physiological changes that have occurred during that particular trimester of pregnancy. Non-elective surgery should never be denied to the patient. So emergent surgery, urgent surgery should be done irrespective of the period of gestation. However, elective cases need to be postponed to 6 weeks postpartum, right? As is very important and critical to patient care is obstetric and neonatal consultations. So that would mean that a multidisciplinary team is essential to patient good outcome. A pre-anesthesia evaluation and informed consent are paramount, and it's important to remember that we need to inform our mothers that the doses of anesthetic agents that we use are not teratogenic to them, and have less likelihood of causing any morphological or functional disabilities. However, we need to understand that there would be risks involved because of the underlying anatomical and physiological changes, which needs to be kept at optimal conditions at all times.
Can you?
Therefore, the type of anesthetic does not influence neither the teratogenicity nor the preterm labor, but it is the way you administer the anesthesia, how it needs to be tailored to the surgical context and to the physiology of the mother is what makes the difference. Regional anesthesia should be preferred as usual if feasible, and anesthetic management should focus on avoidance of maternal hypotension, maternal hypoxemia, hypercarbia, hypocarbia, I would say, as well as occurring secondary to hyperventilation, hypo and hypothermia, hypo and hypoglycemia, acidosis, stress, and pain. So all of these needs to be taken care of, and that would help us to treat our mothers safely and lead them to sustain pregnancy to term. Thank you all for a patient hearing, and looking forward to meeting you all in the next year. Thank you so much.
Thank you, Dr. Anju. It was very, you have elaborated the whole thing very nicely. I don't think so. There was just one question in the chat box, which you have already replied to. Since there are no other questions, in case there are no other questions, I would like to thank you for covering the topic so nicely that, it's very crystal clear for everybody. Thank you very much. So over to the host, Dr. Devang, anything?
No, ma'am. Thank you so much. Thank you, both of you. We'll now move on.
Thank you so much. I will need to thank the organizing team and especially Dr. Rashmi Datta ma'am for such a generous introduction. And I'm really honored to be delivering this talk under your chairperson, as you being my chairperson. And it was indeed it's a very heartening thing to come back to postgraduates and be teaching them. But I really wish we'll meet each other soon. Thank you so much. I think there was this question about, I did answer it in the chat box, but I believe they wanted me to talk about it as well.
That would be better, ma'am.
Yeah, this how we need to keep. So basically, what she's asking is if the MAC is low, that means you need to keep your MAC values at a lower, because the MAC is reduced. So you won't be keeping it at normal 1 to 1.5 MAC. But having said that, I would recommend that if it is a prolonged surgery or and you have concerns about awareness, employing monitoring for awareness, especially BIS monitoring, would be better, because there have been multiple reports of mothers being awake, having awareness under anesthesia because of all these issues. So that is what my answer would be. Thank you. Thank you so much. Thank you, ma'am.
Thank you very much. And I hand over the session now to the organizers. Thank you.
Thank you, ma'am. Thank you. Now it's time for the second quiz of the day. If that can be displayed, please. So there are two questions. The first one is the universal technique that would not, I repeat, that would not be expected to provide appropriate analgesic benefit during the first stage of labor is, the options are A, lumbar epidural, B, pudendal nerve block, C, lumbar sympathetic block, or D, paracervical block. The second question is, which of the following is not associated with oxytocin administration? Again, emphasis is on not. Which of the following is not associated? A, myocardial ischemia, B, respiratory depression, C, hypotension, or D, tachycardia. The answers to these questions can be posted in the chat box and winners will be declared shortly. Now moving on to the long case presentation on MS in pregnancy. This session will be moderated by Dr. Kavita Sharma and Dr. Jyoti Singh. Dr. Kavita ma'am is Director Professor, Vardhaman Mahavir Medical College and Safdarjung Hospital. Her areas of interest are pediatric anesthesia, airway management, and life support. She has multiple publications and paper presentations to her name. She is also an AHA certified ACLS instructor. I welcome you, ma'am. Also, Dr. Jyoti ma'am is Associate Professor, ABVIMS and Dr. RML Hospital, New Delhi. Her areas of interest include transplant and pediatric anesthesia. And the case will be presented by our final year postgraduate trainee, Dr. Amit Kumar Sharma. Over to you, ma'am.
Hello. Good afternoon, everyone. First of all, I thank the organizers here and Dr. M.D. Kaur for inviting me for this session. And it's a very important topic what has been given to me, that is a pregnant patient coming in with a rheumatic heart disease and a mitral stenosis. So before we go on to the case presentation, I think the student is ready. So we can have the case presentation. Dr. Amit?
Yes, ma'am. Shall I start, ma'am?
Yes, Dr. Amit, you may start.
Good afternoon, everyone. Today I'm going to present a case of 26-year-old female, Bimla, resident of Paharganj, Delhi, postgraduate, housewife by occupation. She is presented with amenorrhea since 8 months. Presented to OPD with 8 months of amenorrhea for safe confinement. Pregnancy was confirmed by urinary pregnancy test and ultrasonography at 2 months of amenorrhea. At 5th month of pregnancy, she had breathlessness, which was insidious in onset, progressive in nature, aggravated on exertion, relieved by rest. She was admitted in hospital and found to have heart disease, managed conservatively, and symptoms improved on medication. At present, no history of chest pain, awareness of one's own heartbeat, dry cough, blood in sputum, abdominal pain, fainting, swelling of legs, bluish discoloration of tongue, waking up in the sleep with complaints of breathlessness.
I think there's some network issue.
Yes,
Dr.
ma'am.
Amit?
Yes, ma'am.
All well, we go to the next slide. I can't hear you, Dr. Amit.
Ma'am, there is no network issue, ma'am.
Okay, now, so go to the previous slide, one before this. Yes, please.
Says Gravida
Yes.
1. Says Gravida 1. Last menstrual period 24 June 2021. Expected date of delivery 31st March 2022. History of present pregnancy, primary, book and immunized. First trimester was uneventful. On second trimester, cardiac evaluation done and diagnosed with heart disease. On third trimester, she continued her medication. She had regular cardiac and antenatal OPD follow-ups. No history of bleeding per discharge per vagina or abdominal pain. Menstrual history says regular menstrual history, past medical history, history of recurrent sore throat and fever with joint pain 14 years back and was diagnosed with rheumatic fever. Took treatment in the form of penicillin injections every 21 days for 8 years till age of 20 years and then discontinued. No history of cyanotic spell, no history of hypertension, diabetes mellitus, tuberculosis, jaundice, asthma, COPD, seizure, and thyroid disorder. Personal history, normal bowel and bladder habits, good appetite, vegetarian, no history of any addiction, normal sleep habits, marital history, married since 2 years, not following any contraceptive methods, non-consanguineous marriage, belonging to lower middle class according to modified Cocosom scale, family history, no history of similar complaint was noted. Treatment history, patient came to casualty at 5 months of pregnancy with complaints of breathlessness and was admitted in cardiac care unit at RML hospital. Patient was treated and discharged on following medications with regular cardiac follow-ups. She was on tablet digoxin 0.25 milligram OD 5 days in a week, tablet furosemide 20 milligram BD, tablet metoprolol 25 milligram BD. On general physical examination, patient is conscious and oriented to time, place, and person, moderately built and nourished, sitting comfortably at rest in chair, height is 154 centimeter, weight 60 kg, BMI 25.29 kg per meter square, no pallor, edema, icterus, cyanosis, lymphadenopathy, and clubbing. JVP was not raised, no sinuses, visible venous pulsation. On vitals, pulse rate 78 beats per minute, right radial, regular, normal in volume, all peripheral pulses palpable, no radio-radial or radiofemoral delay. Blood pressure 100/60 millimeter of mercury in right arm sitting position. Respiratory rate 18 per minute, regular, thoracoabdominal. Airway examination, on visual examination, no obvious facial deformity, no loose teeth, no artificial denture. Mouth opening more than 3 fingers, modified Mallampati grade 2, thyromental distance 6 cm, sternomental distance 12.5 cm, thyroid distance normal, full range of neck mobility. On CVS examination, inspection, neck veins are not engorged, precordium no deformity or bulging, no scars, sinuses, and engorged vein. On palpation, apex bit at left fourth intercostal space, 2 cm lateral to midclavicular line, left parasternal heave absent, palpable diastolic thrill present in mitral area, best felt in lateral position in full expiration. On percussion, cardiac area of dullness from second to fifth intercostal space. On auscultation, heart rate 76 beat per minute regular. S1 is loud, S2 is normal. A low pitch, rough mid-diastolic murmur with pre-systolic accentuation, with no radiation heard over mitral area. Opening snap not heard. Respiratory system examination, no tracheal deviation, movement of chest bilateral symmetrical, no sign of accessory muscles used, respiratory rate 18 per minute, thoracoabdominal, no area of tenderness, trachea central, chest movement bilaterally equal, vocal fermatus bilaterally equal. On percussion, bilateral resonant nodes present over all areas. On auscultation, normal vesicular breath sound over all areas, no added sound noted. On abdominal examination, inspection, abdominal is distended, moving well with respiration, flanks are full, umbilicus central and everted, stria gravidum and linea nigra present, hernial orifices full. On palpation, no local tenderness present, symphysiofundal height just below the xiphisternum. On auscultation, fetal heart sound at left supraumbilical line, 140 beats per minute. CNS examination says conscious oriented, higher mental function normal, no sign of any cranial nerve abnormalities noted, no sensory, motor, and focal neurological deficit. Examination of back, spine appears normal, no scoliosis, kyphosis, gibbous, no deformity of shoulder, no scar marks, visible venous pulsation, hyperemia, and sinuses. The provisional diagnosis is 26-year-old female, gravida 1 with 8 months of amenorrhea, with known case of rheumatic heart disease, with mitral stenosis, no sign of cardiac failure with normal sinus rhythm on medical treatment.
Dr. Amit, very well presented.
Yes,
in the history, we ask some specific questions, so that
yes,
we can grade the severity of the disease. You have made a diagnosis of pregnancy with rheumatic heart disease with moderate mitral stenosis.
Yes, ma'am.
Can we, how do we say it's a moderate mitral stenosis?
Ma'am, on mild, moderate, and severe, it will classify according to echocardiographic. In echocardiographic report, ma'am, with mitral valve area with pulmonary artery, systolic pulmonary artery pressure and gradient. Ma'am, mitral valve area, if mitral valve area is more than 1.5, it is mild, and valve gradient is 0 to 5 is mild, and pulmonary artery pressure between less than 30 is under mild. Moderate mitral valve area is 1 to 1.5 centimeter square. Pulmonary systolic pressure is 30 to 50 mmHg, and gradient is 5 to 10. In severe mitral stenosis, mitral valve area is less than 1 centimeter square. Pulmonary vascular gate, systolic pulmonary pressure is more than 50 mm of Hg, and valve gradient is more than 10 mm.
Okay, so these are the echocardiographic findings on the basis of which it is made mild, moderate, and severe.
Yes,
however, on the basis of history and examination, can you classify like this patient is likely to be more sick, or this patient is likely to have a mild disease?
Yes, ma'am. With
yes.
history, according to patient is present with breathlessness, ma'am. With breathlessness, I quantify the breathlessness according to NYHA grading.
This patient is?
Ma'am, she is belonging to NYHA grade 2, ma'am.
Okay. So grade 1 and grade 2 we usually consider as mild ones, and
Yes,
the grade 3 and 4 we consider as moderate to severe ones. Okay. So
Yes,
according to history, on examination also, can we have some findings which point towards
Yes,
a more severe disease?
Yes, ma'am. On examination, there is S1 is loud. I mentioned that on auscultation, S1 is loud. There is more severity of murmur. The duration of murmur is more, and there is the opening snap. Duration between the second heart sound and opening snap is decreased. That will create the more severity towards the more severe disease, ma'am.
Okay. I don't think personally that on examination we can actually make out the differences to make it a mild or a moderate or a severe with respect to the cardiac examination. More important is that in case you have some signs of cardiac failure, in case you see some of them, this patient did not have any of those signs. No, JVP was normal.
No, ma'am. Yes,
JVP was normal. It was not raised. So any signs which point towards probably a failure are the signs that this patient has gone probably into a severe disease, because mild patients are unlikely to go into severe disease. Okay.
Yes.
So
then signs which shows the towards the severity or in failure, there is
Yes.
a raise of JVP. There is a loud P2, ma'am, because of pulmonary hypertension. There is
Yes.
peripheral pedal edema, epigastric pain.
Yes. Any sign or symptom which points towards a pulmonary artery hypertension means that the patient is going towards a severe disease. Okay. You have already given the classification according to the echocardiography, and most of the literature, wherever we read, gives it like this only, the way you have said. But for the postgraduate students, like if you are reading your standard Miller textbook, there they have added on another group in between, that is moderately severe. And
yes, ma'am.
So they have added on another group, but mainly it is the same, like the normal, the diameter or the surface, the area of the mitral valve, which is normal, is between 4 to 6. And from 2 to 2.5 below that, we say like it becomes, there is a stenosis. So most of the places it gives you like less than 2 is stenosis. But your Miller textbook actually says less than 2.5 is also called as a mild stenosis. So that's the only difference for people like who are reading the textbook. So Miller has a slightly different variation, but rest it is all okay. So do you think that this particular patient also has a component of mitral regurgitation?
No, ma'am. In our clinical examination with history and clinical examination, because if there is a mitral regurgitation is there is a widening of the S2, ma'am, and there is a pansystolic murmur because of the mitral regurgitation. In our clinical finding, patient don't have that finding also, so I'm not
Yeah, it's unlikely that the patient has any mitral regurgitation. With this history and examination, can we actually predict the maternal risk in these patients? Like most of these patients are coming for anesthesia or for labor analgesia. Based on the findings here, can we predict the severity, the risk to the patient?
Yes, ma'am. There's two classification is there for the prediction of severity. In this case, there's one score that is Wilkinson score, that is echocardiographic score. Other one is a Clark classification. Ma'am, in Wilkinson score, there is a 4 parameter for the wall thickness.
We stop here. Dr. Amit,
Yes,
Dr.
ma'am.
Amit, we stop here because Wilkinson score is for something else. When it comes in the discussion, we will discuss it. Okay. So like suppose this patient is coming in for LSCS.
Yes,
okay. The patient, you get a call that we have a patient who is admitted in the ward. She's 36 weeks and this particular patient is admitted and they say we may land up for a cesarean. So please do a pre-anesthetic checkup and we may take her up in due course of time for a cesarean. So can we optimize this particular patient or can we work up this patient that we have to give anesthesia to this patient?
Yes,
Anything
ma'am,
else you
definitely.
would like to do other than history examination?
Yes, ma'am.
Yes.
For my workup plan, I will, other than history and clinical examination, I go for some investigation. That will be complete blood count for
Yes.
the hemoglobin, because the pregnancy itself is, there's a mild anemia, physiological
Okay.
anemia is there. Then, ma'am, for TLC count to see the leukocytosis is there or any infection is there or not. Ma'am, for platelet, because there's chances of patient is on metal stenosis, thrombosis, chances of thrombosis is there. So I might be on anticoagulants. So I look out for the platelet count. And for anesthetic concern, because I have to give the regional or the general anesthesia. So that point of view, I look for the platelet count. Then, ma'am, for LFT, as a patient is on digoxin and diuretics. So I look out for the serum electrolyte and LFT as a institutional protocol. I will go for the LFT. Then, ma'am, ecographic, again, I will go for the echocardiographic changes if patient is same as earlier or any changes is there. So I will prescribe for the echo also, ma'am. And ma'am, I will go for the cardiology reference also because optimization, it is important. Patient is on beta blocker, digoxin and furosemide and with moderate mitral stenosis. So cardiology opinion is also needed in that case.
Okay. Do we need to get an ECG done in this particular patient?
Yes, ma'am.
What information you will get from an ECG?
Ma'am, in ECG, I will look for some changes because in MS, there is a left atrial dilatation is there. So due to the dilatation, there is a P mitral is there.
Okay.
P wave changes in P wave is seen, ma'am. And also there is a right axis deviation. If ECG also rule out, ma'am, if absent P wave, there is chances of fibrillation. And
one thing, the left atrial dilatation or hypertrophy can be made out. The right ventricular hypertrophy can also be made out by an ECG. But most of the times we are getting an ECG done to look for presence of fibrillation. If clinically you find that it is regular, absolutely regular, we are likely to get a regular pulse. But sometimes we are not very sure and we would like to see in the ECG, then it is confirmed that it is a regular rhythm or a sinus rhythm which is coming. So we need to be sure because this particular patient is on digoxin and fibrillation, not the other ones. Okay. So, this mitral stenosis, it is a valvular lesion which keeps on getting stenosed. Can you tell me what happens exactly when there is a mitral stenosis? What happens physically or anatomically to the leaflets or something? What happens?
Ma'am, I will classify according changes according to the anatomical changes, then physiological changes. Ma'am, in anatomical changes, in mitral stenosis, there is increase of the area, and the papillary muscles and chordae tendineae, which connect the valves at the mitral valve is bicuspid valve. So there is a decrease in area is there, and thickening of the chordae tendineae muscles is also occur, ma'am. That will decrease the area of mitral area, ma'am. In physiological changes, ma'am, one more anatomical changes occur if a prolonged duration of there. So there is a calcification of occur in that area. So that will further reduce the area. And it is a jet flow is there in mitral area. So chances of vegetation formation like thrombus is more in mitral valve. These are the anatomical changes I look and the physiological changes, ma'am. In mitral stenosis, physiological changes is due to increase in the gradient and due to the arterial dilatation. Ma'am, due to increase in gradient, there is a transmission of pressure to the pulmonary vascular, increase in pulmonary venous pressure, then pulmonary artery pressure. Increase in pulmonary artery pressure causes pulmonary arterial hypertension. That will further transmitted to the right ventricle. It will lead to the pressure gradient in the right ventricle, and it further transmitted to the tricuspid area that cause tricuspid regurgitation and signs of the right-sided heart failure. Ma'am, due to the left-sided arterial dilatation, due to increase in the size of the arterial chamber, chances of fibrillation is more, and thrombus, due to stasis of blood, thrombus formation will be more.
Very good. So you've explained it in details. I'll just summarize. So there is a decrease in the opening in the mitral valve. The leaflets which are moving, the anterior and the posterior, the movements become less. There is a doming, there is a calcification, and the commissures start getting fused. So there's a fish mouth kind of a deformity which is coming. The chordae tendineae which are there, they will also get calcified, and they will get fused and thickened and shortened. And the left atrial changes, you have already said. The back pressure changes. Why do we get actually this murmur? What is a murmur?
Ma'am, actually this murmur is due to gradient, ma'am. Changes in the left artery and left ventricle gradient, ma'am. Because of the increase in, ma'am, because of the arterial, most of the blood flow in this murmur because of the arterial contraction, ma'am. So that this flow of jet will create the murmur in mitral stenosis.
A murmur is a sound. It is
Yes.
being produced by something. Whenever there is a smooth flow, there will never be a sound. So whenever there is a turbulent flow, because the valve is getting fused, so the orifice is less. So the movement of the flow of the blood is not laminar. It becomes more and more turbulent, and that turbulence leads to these sounds which we detect as a murmur. And this patient, you have also said a thrill, which is very, very rare. In diastolic, we get the thrill very rarely. In mitral regurgitation, the systolic murmur thrill is very, very common. Okay, so most of the things you have already enumerated. So when we are working up this patient, you have got the investigations done. Can we just enumerate various concerns as an anesthesiologist I have, like when I'm planning to get this patient and I'll be the anesthesiologist, can I just classify the concerns I have as an anesthesiologist?
Ma'am, the concern as an anesthesiologist,
just enumerate.
Because of the pregnancy related, due to the mitral stenosis, and due to the surgery.
Yes.
Ma'am, due to pregnancy related, pregnancy itself is a hyperdynamic circulation. There is increase in cardiac output and heart rate that will further causes any arrhythmia. There is a chances of aortocaval further lead to decrease in and increase sensitivity to the anesthetic drugs, ma'am. Increase sensitivity to the local anesthetic, ma'am. And there is a difficult airway, ma'am, and increased chances of aspiration in pregnancy, ma'am. And
okay,
due to
just hold on. You have just enumerated the concerns because of pregnancy. If we say like because of pregnancy, like even if she did not have mitral stenosis, all these concerns would be there. Okay, so they just, can we say them, system by system? One thing is we are taking care of 2 lives. Then we say system by system, like one system, like the respiratory system. You've already said that the airway, upper airway changes, the lower airway changes. So lower airway, what are the problems? The tidal volume is becoming less or more?
Ma'am, tidal volume is more, and respiratory rate is fixed, ma'am. Decrease in total lung capacity and decrease in FRC, but tidal volume is more.
So that is there. So respiratory system, you enumerate those changes. You've already done some of the things. There is one thing that is the functional residual capacity. What is functional residual capacity? It will decrease. So if the functional residual capacity decreases, yeah, you have said it, functional residual capacity has decreased. So what effect, how does it concerns me as an anesthetist that the FRC has diminished?
Ma'am, as an anesthetist, I am concerned that FRC provide the apneic time. Due to decrease in the FRC, the apneic time in this patient will decrease, and that will land in, that patient will land into the hypoxia very early. So the
safe apneic time becomes less.
yes, ma'am.
Okay, so that is one problem. But do I have any advantage also of a decrease in FRC? Whenever we are giving general anesthesia, we're always pre-oxygenating the patient. So decrease in FRC, will it have any effect on the pre-oxygenation or the denitrogenation as we called?
Ma'am, yes, if FRC is decreased, denitrogenation will be fast, ma'am, because
yes, yes. So like you must have seen yourself, most of you would have seen, like when we pre-oxygenate, if it is not a pregnant patient, we go on with our watch for 3 minutes. But usually for a cesarean, what happens? We say like even few tidal volume breaths, vital capacity breaths, few of them taken, usually cause enough pre-oxygenation, and we achieve our goal of that much expired oxygen what we need to after a successful pre-oxygenation. So the pre-oxygenation or the denitrogenation is also faster because the reserve is less. Okay. Okay.
Yes.
So you have said about the respiratory, cardiovascular, you have already said the cardiac output is increasing.
ma'am, cardiac output is increased. It is started increases from 6 weeks of pregnancy.
Yes.
Then reaches maximum up to the 32 weeks, ma'am.
Okay.
And further increase at the time of labor and immediate postpartum.
Okay. So cardiac output is higher. The stroke volume is also higher. The total blood volume is also higher. Blood volume is higher or lower? In a pregnant
It is higher. Ma'am,
it is higher. So these all changes, you should be able to enumerate system wise, like what all can be the changes in a particular patient. So the CVP, what happens to the CVP in these patients? In a pregnant patient, CVP is increased in normal healthy parturients. Normal healthy parturients are not patients. Okay. So the CVP, it increases or decreases?
Ma'am, CVP will
blood volume is increased, heart rate is increased, you know? Stroke volume is also increased, cardiac output is also increased. Okay, we go to the next one. What happens to the total vascular resistance?
Ma'am, it will decrease.
The systemic vascular resistance? Systemic vascular resistance, that will decrease. Why? Because of effect of the hormone. So systemic vascular resistance decreases. So that is why the cardiac output is rising. But you know, the CVP remains unchanged. And even the pulmonary capillary wedge pressure remains unchanged. They remain unchanged. And systolic BP, there is a slight diminution, but by the time term is there, it comes back to nearly normal. Okay. So just remember the CVP remains just the same. The systemic vascular resistance does fall. Okay. I also want you to tell me what are the changes in the GI system.
Ma'am, in GI system, there is a decrease of
whatever are important for us. Tell me those.
Decrease, ma'am, mortality is decreased and acid secretion is increased and chances of aspiration is increased, ma'am, in that patient.
Why are the chances of aspiration increased?
Ma'am, because of the anatomy of esophagus, lower esophageal sphincter is relaxed, ma'am, and the changes in esophagus and the stomach, there is a more entry.
It is pushed up, the angulation changes. Okay. There are increased chances of hiatal hernia. What happens to the gastric emptying time?
Ma'am, it will increase, ma'am.
Gastric motility goes down, but gastric emptying time remains the same. It seems difficult. No? We just think gastric motility is less, so emptying time will also be less. No, gastric motility is less, but gastric emptying time remains the same. So it's of concern to us. That is why when we say fasting time, we say 6 hours in all for light meals. Even in pregnant patients for elective surgery, we say it is the same. In case the solid food is there with high fat content, it remains as 8 hours. When is the gastric emptying delayed in pregnant people? Which conditions or times? It is diminished at some time. When is it diminished?
Can you repeat, please? Ma'am,
When
can you
is-
repeat the question, please?
The question is, when is gastric motility, the gastric emptying time increased in parturients?
Ma'am, at the time of labor and
Yes. Yes, labor, yes. Any other time when they are increased?
ma'am, during first
We do
time,
something as anesthetist and we increase the emptying time. When we give opioid to any patient in any phase, presence of opioids in the body increases the duration of gastric emptying. Okay, so whenever the patient is on opioids or the patient is in labor, we expect that the emptying would be delayed. So we make appropriate changes or we take precautions. Okay.
Yes, ma'am.
So that is why any patient who's in labor, whenever we are anesthetizing them, we are very careful. Okay. So that's fine. Or any other system you would like to say, or we go further?
Ma'am, CNS in CNS in the
Yes.
there's changes CNS, there's increased blood flow, ma'am.
Okay.
Because of the increased blood, the increased sensitivity of local anesthetic also, ma'am. Regional changes, decrease in CSF volume. There is decrease of CSF space, ma'am. Increase in venous plexuses, ma'am, in regional area, ma'am. And lumbar lordosis is also increases, ma'am. Then in
What are our concerns? So that
Ma'am,
means CNS sensitivity is increased. So what
Yes.
happens to the MAC?
Ma'am, it will decrease, ma'am.
Decreased MAC, more sensitivity to opioids, local anesthetics, you have already said. You know, we give very less amount of drug in case for regional anesthesia, especially the
And because
neuroaxial
of
block
the
in
local
pregnancy.
sensitivity of the nerve fiber will increase also, ma'am.
1, 2, why?
CSF volume is also decreased, ma'am. And
2,
CSF
3, why?
Ma'am,
What
due to
happens?
the progesterone, ma'am, there is increase in venous plexuses that pushes the space, epidural space also. So the epidural
Wonderful.
space will narrow. And
Yes.
because of the effect of the progesterone, ma'am, local sensitivity of the nerve fiber will increase, ma'am.
Wonderful. So you have answered most of the things. And now when we are maintaining this mitral stenosis patient, if it is there, and I plan to anesthetize, we have certain goals in our mind. Whatever we plan, regional or general anesthesia, we always have certain goals. What are those goals? Tell me the hemodynamic goals. What are those
Ma'am,
goals? What do we try and attain?
Ma'am, we planning for the anesthesia for this patient. We have to keep that heart rate should be maintained. Heart rate and rhythm should be maintained. Systemic vascular resistance should be maintained. And the patient is not in hypovolemia or hypervolemia. There is euvolemic status. There is chances to decrease the pulmonary vascular resistance also. So the patient is not in hypoxia, hypercarbia, or any acidosis, ma'am. And
Okay. So most important, I'll just summarize, most important, never allow tachycardia in these patients. Maintain your preload and maintain your systemic vascular resistance. Do not let it go high. Do not let it fall suddenly. So once we keep this, so we have to be very careful with our fluid balance also. So in case this patient comes for cesarean, this particular patient, you've got an echocardiography and the mitral valve area in this patient was how much?
1.5 centimeters.
Around 1.5. So she becomes a case between moderate and mild.
Yes.
Okay. Okay. So when these patients come and you are planning a cesarean, okay, what plan you would have? General anesthesia or regional anesthesia?
Ma'am, I will prefer the regional anesthesia because of the benefit of anesthesia there. I will panel because of the graded crisis. There is a decrease in SDR will compensated by the heart because heart that time, and I am not handling the airway, and due to the ventilation related problem will not occur in that patient, and it will also provide the post-operative analgesia also. That will be benefit for the patient.
So as long as we are able to put in an epidural catheter and we have enough time and we are very slow and we are planning to give it appropriate fluid therapy, regional anesthesia becomes very safe. Okay. This is in mild cases. Okay. In case the patient is a severe case, that is grade 3 or grade 4, and the patient comes you early, can we make her life better or the chances risk less for anesthesia? Like she has come to us at 12 weeks of pregnancy and we know that this patient is there and she's a severe case.
Yes, ma'am.
Yes?
Because of, according to the ECOG guideline, ma'am, we can optimize this patient because according to the grading, ma'am, grade 1 or 2, grade 1 or mild disease, it should be admitted 2 weeks prior to the expected date of delivery for the optimization of the patient. And in moderate and severe cases, it should be admitted once the urinary pregnancy test was positive. So from that time, she was totally under the hospital, and optimization will be done according to that.
And optimization requires what all? Medical and surgical therapy. Medical surgical therapy, what all is given?
Ma'am, optimization requires the proper medical and surgical adequate bed rest, oxygen supplementation to avoid any hypoxia, hypercarbia. In medical management, ma'am, I will prevent the chances of heart failure, so I use diuretics, digoxin, and beta blocker to maintain the sinus rhythm. And ma'am, in moderate and severe cases, if moderate and severe cases, chances of fibrillation is there, so anticoagulant will be advocated for that patient.
Okay, so when is the surgical therapy used?
Ma'am, surgical therapy
for these patients in what phase of pregnancy?
Ma'am, surgical therapy is indicated in it's safe in second trimester of pregnancy, and indication of the surgical therapy is severe mitral stenosis, not managed on medical management and still having symptom of proper medical management. Then we go for the percutaneous balloon mitral valvotomy for this patient.
Okay, so the score which you had mentioned earlier, the Wilkins score.
Yes, ma'am.
That is more useful here.
Yes, ma'am. It will guide us to the better acceptance and morbidity of the patient. If the score is less than 9, then chances of balloon mitral valvotomy is better. Outcome is better. If the score is between 9 to 11, then chances outcome is moderate. More than 11, there is a poor outcome with the balloon mitral valvotomy.
Okay. And this score actually checks for the mobility of the leaflets, the subvalvular thickening, and the thickness of the leaflets, as well as the calcification. So the score goes between 0 to 16. It just guides like what is the likelihood of benefits by a surgical procedure, that is a balloon mitral valvotomy. So that is done. You are preferring to give a regional anesthesia for cesarean. Can there be some problems with regional anesthesia in some patients? What are those concerns?
Ma'am, because of the regional, these sudden fall in systemic vascular resistance occur, and these cases are the fixed cardiac output statement.
Yes.
So the sudden decrease in systemic vascular resistance will lead to tachycardia. It will decrease further the diastolic time, ma'am. And then due to this, there is chances of ischemia is there, and arterial dilatation.
One, you have said one is decrease in the SVR sudden, which we should do by putting a graded epidural. What are the other things, other concern?
Ma'am, because of the anticoagulant, these patients are on anticoagulant, ma'am. So,
this one is not, this particular patient is not, but in case the patients are on anticoagulation, then what is my concern?
Ma'am, if these patients are on anticoagulant, so we have to stop the anticoagulant for optimizing the patient. The different and stopping time of different anticoagulant is different. If patient is on
Okay, just hold on. The 4th trimester, the patients are usually on which anticoagulant? First trimester, what is given to these patients?
Ma'am, in first trimester, I will give unfractionated heparin or low molecular weight heparin. And from 12 weeks
And
onward,
to
12
weeks
onward
to
to 36 weeks, ma'am, I switch to the warfarin. And again, from 36 week onward, I will switch to the unfractionated heparin and low molecular weight heparin.
Okay, so the patients are usually anticoagulated most of the time if there is a left atrial dilatation, even if atrial fibrillation is not there. Then also, in case LA is dilated, then anticoagulation is started, and we aim for an INR or an APTT. INR around 2.5 to 3, around 2.5, and APTT of how much with heparin?
More than the control. APTT is more than 2 times the control. Ma'am.
Okay. So we try and keep the patients anticoagulated. So for regional, appropriate stopping and appropriate time gap and reversion of the INR should be there before we plan to put in an epidural or give a regional. But certain advantages you have already said. In case GA has to be given for these patients, then what is the plan? Like the patient suddenly develops fetal distress or something, then what is the plan?
Ma'am,
what would be your pre-operative orders? Start from there. What would be your pre-operative
order? Infuse at least 6 hours. I will give anti-aspiration prophylaxis, like injection ranitidine.
Okay. At least so if the patient comes to NPO for 20 hours? Nahin, beta. Okay.
No,
if the patient comes fasting for 20 hours, it is okay?
No, ma'am, because of chances of hypoglycemia and fetal hypoxia and fetal acidosis will increase, ma'am.
So we always say fasting for clear fluids for 6 hours. Don't say at least 6 hours. So at least means 2 days also patients come fasting. So that is not good. So clear fluids to be restricted around 6 hours, or solid food between 2 or clear fluid is 6 hours or how many hours?
No, ma'am, clear fluid is 2 hours and solid for 6 hours.
Solid for 6 hours or 8 hours depending upon the type of food.
Yes.
Okay. Any patient who is in labor are not to be given solids, to be given only clear fluids. Okay.
Yes.
Any other pre-op order?
Ma'am, I will ensure the patient should take the cardiac medication because of sees on beta blocker and digoxin and diuretics. If I have chances and also an anticoagulant, so I will advise to stop the anticoagulant at least if is an emergency surgery, then I will arrange the APTT or I will ask for the serum electrolyte. If not in emergency, so I would stop the anticoagulant 6 hours. If unfractionated heparin, then I would stop 6 hours before surgery, and long molecular weight heparin, I would like to stop 12 hours before surgery. Ma'am,
Okay.
In other NPO, ma'am, I will advise the high risk, ma'am, written informed consent, high risk consent, and the availability of ICU bed for the post-op care. And the patient should be shifted on the left lateral position, so the aortocabal compression is not.
Okay. For general anesthesia, what is your plan? What in case GA is to be given? Which drugs will you choose?
Ma'am, I will choose the etomidate because it's the more cardioselective. For induction agent, I will choose the etomidate, ma'am. And I will use rapid sequence intubation, for which etomidate, succinylcholine, and for the prevent of the pressure response, ma'am, I would like to give lidocaine 90 seconds before the intubation, and beta blocker, ma'am, like smaller because it's short acting.
Pre-oxygenation, rapid
ma'am,
sequence induction. What is the role of opioids? When to give?
Ma'am, generally in our institution, we will give the opioid after the delivery of the baby because it will cause respiratory depression. But in some cases, it changes because of safety profile. Fentanyl is safe, and we have to blunt the pressure response. In that cases, we do the low dose of fentanyl, like 0.5 to 1 microgram per kg. And pediatricians should be informed that the patient has given fentanyl before the delivery.
Do we have any other opioid which can be given safely before the?
Ma'am, ramifentanil, ma'am.
Okay. Okay, remifentanil can be given. What is the advantage? Will the baby not be depressed with remifentanil?
Ma'am, it will less, ma'am.
With
Respiratory
remifentanil,
depression is less, ma'am.
yeah, because most of the time it is such a rapidly metabolized that you do not have any problem. And if the patient is having uterine contractions, this patient is already 36 weeks plus, then one small trick what our seniors used to tell us, and it works really, like whenever you're giving an opioid in a cardiac patient, try and time it. Feel for the uterine contraction, feel for 1 or 2, just keep your hand on the abdomen, you will come to know. And when the moment the contraction is beginning to start, at that time, just give your opioid. So the uterus remains contracted for next 30 seconds and all the opioid gets deposited in the rest of the body, and the baby always comes out crying without any respiratory depression. So most of the drugs we try and time them with the uterine contraction, that really helps. So we can do it in case like sometimes we are stuck, we have only fentanyl with us and naloxone is a problem and the patient is a severe case. Most of the residents do face that. So you can time it with a uterine contraction. It's very helpful. Okay. So you have said which muscle relaxant will you prefer?
Ma'am, succinylcholine, ma'am, for rapid frequency induction. If
thereafter, after that, long acting.
Ma'am, after the delivery of baby, I will give vecuronium.
Okay. What is the problem with oxytocin in these patients?
Ma'am, oxytocin is, causes systemic vascular resistance, decrease the systemic vascular resistance if we given bolus, ma'am, or fastly. So because of the systemic vascular resistance, decrease preload and afterload also. That will further increase the low tension of the myocardium and tachycardia will occur. That will further deteriorate the.
What precaution? How should we give it so that problem is not there?
Ma'am, I will dilute the oxytocin 10 to 20 international unit in 1000 ml NS, ma'am, and it will leave slowly like 60 to 70 ml per hour.
So in one VAC, that is 500 ml, do not add more than 5 units or 10 units of oxytocin and let it go slowly, not very fast. Okay. So, and even after the delivery of the baby, the reversal, most of the places ensure that tachycardia does not occur, maintain the depth of anesthesia. Opioid based is always better. Inhalational to be used less. Okay. And throughout use proper monitoring. So now what all monitors do you plan to use in this patient?
Ma'am, I will monitor in this patient normal ESA monitor, ma'am, like ECG.
Yes.
I will attach 5 lead ECG, then pulse oximetry.
Yes.
Then, ma'am, base monitoring if is the intubated, then invasive arterial line, ma'am, to the beat to beat variability. I want to say, ma'am, and
what is the role of invasive arterial monitoring or a CVP in mitral stenosis? Do you do it in all the patients? Frankly, tell me truly. Do you do it? Put it in all the patients?
No, ma'am, we don't.
No.
No, ma'am, we don't put the CVP.
So which patient should we put?
Ma'am, in moderate
which
to
patients?
severe. Moderate to severe.
Yes, moderate to severe. Yes.
And we will put
not all the patients.
Yes, ma'am.
Okay. Fine. Any other monitoring you would like to use?
Ma'am, neuromuscular
BIS you have already said.
And BIS,
neuromuscular. Okay.
And side to side, ma'am, I also want to monitor the fetal heart rate all the time. FHR should be monitored, ma'am.
Once you have given anesthesia in 10 minutes, the fetus will become a baby, then we cannot monitor.
Yes, ma'am.
It becomes
before
difficult.
Induction,
okay. And yeah, one more thing, we must be careful while at the time of induction, most of us are very, very vigilant. We are using all drugs to attenuate the pressure response, but that vigilance sometimes becomes less at the time of reversal. At the time of reversal, the depth of anesthesia is usually light. The muscle relaxant is also wearing off. That is the time when patients do get stimulated and do get tachycardia, and especially with the reversal, what we are giving. And avoid giving atropine and use glycopyrrolate instead. Maintain the depth of anesthesia, reverse the muscle relaxant first, and slowly bring out the patient from anesthesia. So those things we have to really take care. We might even use a beta blocker at that time and maintain it. And in case the patient gets hypotension, then which vasopressors to be used? Preference?
Ma'am, phenylephrine, ma'am, if in regional, and
yeah, phenylephrine is preferred in case you have it, then we can use that. So be careful throughout. No tachycardia, fluid should be judicious, no pain, depth of anesthesia has to be maintained. So if you have BIS monitors, start using them. Frankly, tell me, how many times do you use it routinely? In a cesarean, hardly ever.
Ma'am, in normal LACS, we don't monitor, but if in heart disease moderate to severe, we like to use, if in GA, then we use.
If in GA, yes.
Then we use BIS monitoring.
Yes. And if the same patient is coming in for labor analgesia, what options do we have? We are putting an epidural catheter.
Ma'am, for putting epidural catheter, we either combined spinal epidural or plain epidural with continuous and intermittent dose. Ma'am, continuous is safe, so we are preferring the continuous epidural with.
Okay. And the severe is the risk of the patient, the severe is the disease. We try and avoid a sympathetic block, and we try and give more of an opioid-based block. So a single shot, fine needle, maybe an intrathecal block can also be given using an opioid, like fentanyl we can use. So those things can be given. Yeah, that can be used. So more or less you have covered everything. And just tell me one last question. After the delivery, after the patient has been shifted into the post-operative period, you will do all this intensive monitoring for how much more time?
Ma'am, at least 72 hours, ma'am.
Okay.
Because of the chances of.
Yes.
Because of the chances of hypoxia or cardiac event is more in that time. So I will be more vigilant in that time.
Don't say hypoxia.
No, not hypoxia, ma'am. Pulmonary changes and cardiac changes will be more post-operatively 72 hours.
You say that the cardiac output, the increase in the venous return because of the uterus constricting. So the increase in preload and the decomposition of the cardiac system, the chances are high in the post-operative period up to 24 hours. By 24 hours, the cardiac output goes back to which state? The pre-labor values. And then it takes another 1 or 2 days and then it goes down. So first 24 hours are the most crucial. We don't want the preload to go very high and the patient should not decompensate. Keep looking in and keep vigilant around for the signs of cardiac failure. So we are very careful, and you give supplementation. Do not allow any tachycardia. Do not allow any pain. So that we have to do. Okay. So Dr. Jyoti is waiting. Dr. Jyoti will quickly summarize. Very well done, Dr. Amit. You have answered most of it. So now Dr. Jyoti will quickly summarize the mitral stenosis case.
Okay. Thank you, ma'am. Ma'am, very nice discussion between you and Amit, and you almost covered all the aspects. Thank you, ma'am. I will quickly summarize them.
Thank you, ma'am.
Ma'am, mitral stenosis, predominant lesion in rheumatic heart disease, and 99% of stenotic valves. 99% of total number of stenotic valves show rheumatic changes, and 25% of rheumatic heart disease patients have only isolated mitral stenosis. And multi-valve involvement is seen in 38% of patients, and pulmonary valve is rarely affected in rheumatic heart disease. This chart is showing the grading of mitral stenosis based on the valve area in centimeter square, mean gradient in mmHg, and it is divided into mild, moderate, and severe. In mild mitral stenosis, the valve area is more than 1.5 centimeter square, moderate is 1 to 1.5 centimeter square, and severe is less than 1 centimeter square. While the mean gradient is less than 5 mmHg in mild, 5 to 10 mmHg in moderate, and more than 10 mmHg in severe. This chart is showing the stages of mitral stenosis divided into A, B, C, and D, defined as at risk of mitral stenosis, progressive mitral stenosis, asymptomatic severe mitral stenosis, and symptomatic severe mitral stenosis, based on the valve anatomy, valve hemodynamics, hemodynamic consequences, and symptoms. Now we come to the pathophysiology of mitral stenosis. So in mitral stenosis, there is increase in left atrial pressure, which leads to pulmonary venous hypertension, which further may lead to pulmonary arterial hypertension. And right ventricular hypertrophy can be seen, which leads to right ventricular dilatation, which may lead to right ventricular failure or tricuspid valve ring dilatation. Functional tricuspid regurgitation can also be seen, which further leads to right ventricular failure. And with mitral stenosis, left atrial dilatation can also be seen, which further leads to atrial fibrillation or stasis of the valve and thrombus formation, which can lead to systemic embolism. What are the effects of pregnancy on mitral stenosis? So in normal pregnancy, there is increased blood volume, but in the volume is increasing in mitral stenosis patients. There is increased risk of pulmonary edema is there due to increased blood volume. And in normal pregnancy, there is decreased SVR. In mitral stenosis, risk of hypotension due to fixed cardiac output state is there. And there is increased heart rate in normal pregnancies, because of which in mitral stenosis, decreased diastolic time is there, and increased cardiac output is there in normal pregnancy, because of which in mitral stenosis patient, increased transvalvular gradient is seen, and autotransfusion during labor and delivery is decompensated. Enlarged atria may lead to atrial fibrillation, and pregnancy is a hypercoagulable state and more prone for systemic emboli. There is increase in NYHA status of patient by 1. Some valvular heart lesions associated with high maternal and fetal risk during pregnancy are severe atrial stenosis with or without symptoms, atrial regurgitation with NYHA functional class 3 and 4 symptoms, mitral stenosis with NYHA functional class 2, 4 symptoms, and MR with NYHA functional class 3, 4 symptoms, aortic or mitral valve disease resulting in severe pulmonary hypertension, and aortic or mitral valve disease with severe LV dysfunction, and mechanical prosthetic valves requiring anticoagulation, Marfan syndrome with or without AR. So these are some associated lesions related to valvular heart disease and high maternal and fetal risk during pregnancy. This is a classification defining the maternal mortality associated with heart disease in pregnancy. It is defined into group 1, group 2, and group 3. In group 1, it is in all the groups, it is showing some and indicating some cardiac lesions associated with the mortality. So in group 1, the lesions are there in which mortality is less than 1%. In group 2, mortality is 5 to 15%. And in group 3, mortality is 25 to 50%. And what is our aim in medical management during pregnancy in a patient with mitral stenosis? So our main aim is to maintain SVR and avoid tachycardia. For this, the patient is advised bed rest, oxygen therapy, beta-1 blockers for heart rate control, diuretics, digoxin, calcium channel blockers. Anticoagulation therapy is mandate for all patients with mitral stenosis, atrial fibrillation, and bacterial endocarditis prophylaxis is taken care of. Anticoagulant therapy is given to the mitral stenosis patients, and it is indicated in patients with mitral stenosis and atrial fibrillation, any previous embolic events, and documented left atrial thrombus, sinus rhythm with severe left atrial enlargement, sinus rhythm with spontaneous contrast on echocardiography, and patients with prosthetic valves. Treatment is usually with warfarin to maintain the INR between 2 and 3. Patient with mechanical prosthetic valves, anti-thrombotic medication with frequent monitoring is advised, and INR levels are kept between 2 and 3. And discontinuation of warfarin and initiation of intravenous unfractionated heparin is advised before planning of vaginal delivery in a patient with mechanical prosthesis. Low dose aspirin once per day in a pregnant patient is given in second and third trimester with mechanical or bioprosthesis. What all interventions can be done in pregnancy? So percutaneous balloon mitral valvectomy is a procedure of choice, and before pregnancy it is indicated when the patient is symptomatic with severe mitral stenosis or patient asymptomatic with severe mitral stenosis but favorable morphology for PBMC. And during pregnancy, it is indicated in patients with severe mitral stenosis and favorable morphology with for PBMC with symptomatic in spite of medical therapy. And ideal time for PBMC is 12 to 14 weeks, as there are decreased risk of radiation to the fetus. And valve replacement can also be done if valve morphology is unfavorable and patient with severe mitral stenosis remains symptomatic. And valve replacement should be considered at that moment. An ideal time for valve replacement is 13 to 20 weeks. Otherwise, if the patient is still symptomatic and not tolerating the daily routine work, then there is no ideal time and it should be replaced. What is our role? The role of anesthesiologist. So anesthetic intervention is needed in the specific stages of delivery, like in normal delivery, labor analgesia is required. So anesthetists are required. In elective or emergency cesareans, non-obstetric surgeries, or post-op in critical care setup. What are the anesthetic goals in mitral stenosis? So we have to manage ventricular. We have to manage ventricular preload, autotransfusion, avoid fluid overload. Heart rate should be managed. We should avoid tachycardia and maintain sinus rhythm. And careful airway management is taken care of. Aspiration prophylaxis is to be taken care of, and maintain PVR, avoid pain, hypoxia, hypercarbia, hypothermia, hyperinflation, and acidosis. Maintenance is done, abrupt fall or aortocaval compression, maintain tilt of uterus to maintain venous flow, and anticoagulation therapy is given. Blood loss assessment and prompt replacement is done during normal delivery and during cesarean also. What is the plan? So if the most preferred is normal vaginal delivery in cardiac cases, and the indications for lower segment cesarean section are Marfan syndrome with dilated aortic root, severe heart failure, acute aortic dissection, patients on anticoagulants in preterm labor, lower segment cesarean section almost exclusively for obstetric indications. This is a chart showing the hemodynamic goals in mitral stenosis. So the parameters are heart rate, preload, afterload, and contractility. It is indicating some drugs which are indicated and some drugs are contraindicated. Labor analgesia is stresses upon to stress should be avoided. There should not be any stress. Because of stress, patient may have tachycardia. And epidural analgesia, combined spinal epidural technique can also be given. And intrathecal administration of lipophilic opioids is given in first stage of labor. And in second stage, uterine contraction without maternal expulsion efforts is desired. Epidural local anesthesia, low doses with opioids will decrease preload and venous capacitance maintained. Mitigates preload, shorten second stage, and hypotension management with phenylephrine is done. Left uterine displacement for good venous return to be done under monitoring, invasive monitoring in cases of severe stenosis, as we have already discussed in the case. Hypotension to be managed with phenylephrine. Fetal heart rate monitoring should be done in all stages of labor. Some catheter can be used for providing anesthesia for LSCs. Regional anesthesia, no, there are no guidelines have been specified for the regional anesthesia. It depends on patient's cardiovascular status and experience of anesthetist. Usually avoided in patients with MVA less than 1.5 centimeter square, and subarachnoid block causes rapid onset of extensive sympathetic blockade, vasodilatation, sudden hypotension, and severe tachycardia. Avoid or low dose in moderate to severe MS. Single shot technique not recommended. Intrathecal anesthesia with low dose LA and opioids are recommended. Proper precautions are to be taken if the patient is on anticoagulants. Epidural technique. Desired sensory level achieved with administration of incremental doses. So titratable techniques are preferred. Lower the risk of sudden hypotension. As we are giving a sudden drug, then there are high chances, like boluses we are giving at once, and there are high chances of hypotension. But if we are giving an incremental dose, then there are low chances of hypotension, and uteroplacental perfusion is better. In case of hypotension, small bolus doses of phenylephrine can be given. Advantages of epidural technique are it can be used as a sole anesthetic in mild to moderate mitral stenosis. Adequate sensory level is reached with titrated doses of local anesthesia and post-operative analgesia. It can also be used for post-operative analgesia, and decreased sympathetic stimulation is there. Disadvantage of epidural technique is it causes slow induction and delay in the onset of action. Combined spinal and epidural. The advantages are faster onset and improved analgesia, better hemodynamic stability. Epidural volume expansion technique is there. Post-operative, it can also be used for post-operative analgesia, helps avoid general anesthetics in case of failed subarachnoid block. Auto-transfusion blood is well taken care of. Improved microvascular blood flow prevents DVT and allows early ambulation and return of bowel movements. What are the advantages of general anesthesia? So it is rapidly established, better hemodynamic stability and prevention of aspiration is there as we are intubating the patient, and controlled ventilation provides the advantages of maintained PVR, prevent VQ mismatch, and can administer IPPV and PEEP. Cardioversion can be performed if required under general anesthesia, and elective post-operative ventilation in cases of heart failure can be done. In preoperative preparation, to take appropriate informed risk consent and consent for proposed ventilation should be taken, and arrange for post-operative intensive care. Anxiolytics are given to the patient, the tab alprazolam 0.25 mg in the night and morning of the surgery. Continue all cardiac medication till surgery. Discontinue warfarin 5 days before surgery and replace with unfractionated heparin. Get subarachnoid on serum electrolytes on morning of surgery. Arrange for adequate blood and blood products. OT is prepared and difficult airway cart is readied. Patient shifted with oxygen supplementation and left lateral position. Anti-aspiration prophylaxis is taken care of, and antibiotic prophylaxis is recommended. Monitors which we are attaching in the to the patient in OT are ECG, SpO2 monitoring, non-invasive BP monitoring, ETCO2, or if the patients are of moderate or comes under the moderate or severe mitral stenosis, then invasive BP monitoring, CVP monitoring, and PCWP, depending on the severity of symptoms, is done. In pre-medication, benzodiazepines should be used judicially in titrated doses, and induction is done with fentanyl low dose 0.5 to 1 micrograms per kg can be used. Etomidate is preferred and thiopenton can be used in low doses. Ketamine should be avoided as it increases heart rate and BP, and propofol should be avoided as it causes hypotension. Modified RSI with succinylcholine can be considered, and patient may have prolonged arm brain circulation time, and pre-oxygenation is done to avoid any degree of hypoxia. In muscle relaxants, vecuronium, rocuronium have least effects on heart rate, and atracurium, cisatracurium or mevacurium have histamine release, so they should be avoided. And pancuronium causes relative tachycardia and should be avoided. In inhalational agents, sevoflurane or isoflurane in titrated doses is given. Halothane should be avoided. And nitrous oxide causes pulmonary vasoconstriction, should be avoided in cases of PAH. In fluid management, judicious and guided administration of IV fluids is done. Avoid hypervolemia as it worsens pulmonary edema. Avoid hypovolemia also, as we have already discussed, and avoid lighter planes of anesthesia to avoid tachycardia. And hypotension should be aggressively managed with phenylephrine. If inotropes to be added, then dopamine, dopamine, and epinephrine are preferred. If there is intra-op tachycardia, deepen the plane of anesthesia, ensure adequate analgesia, use beta blockers like esmolol, propranolol, or calcium channel blockers like diltiazem. If atrial fibrillation occurs, ventricular rate can be controlled with esmolol, propranolol, diltiazem, digoxin, or amiodarone. For supraventricular tachycardia and unstable hemodynamics, synchronized cardioversion is done. These are the recommended anesthesia agents and non-recommended anesthetic agents in a chart. The induction agent, what is recommended is etomidate, and ketamine is not recommended, and maintenance agents are opioids, and muscle relaxant is succinylcholine is the most preferred one, and vecuronium, and further it indicates other drugs which are recommended and non-recommended. Non-depolarizing muscle relaxant is achieved slowly with neostigmine and glycopyrrolate to reduce drug-induced tachycardia caused by glycopyrrolate. The choice of anesthesia depends on the lesion, its severity, and the experience of the anesthesiologist. Regional anesthesia technique based on patient profile provides the least degree of hemodynamic alterations. General anesthesia can be safely administered to these patients provided the hemodynamic perturbations associated with laryngoscopy, intubation, surgical stress, and extubation are blunted by the appropriate choice of pharmacological agents and anesthetic techniques. Uterotonic drugs. So precautions should be taken, as ma'am and Dr. Amit have already discussed. Methyl-etomitrine, potent vasoconstrictor of uterine and systemic circulation. It increases preload and afterload and PAP. Oxytocin given as an acute bolus can cause a marked reduction in BP and fall in SVR. So caution should be taken when we are giving oxytocin to the patients. And prostaglandins like prostaglandin can cause sudden uterine contraction, which increases systemic blood volume, and pulmonary edema can be seen with this, and also increases PVR and cause tachycardia. In post-op management, patient is reversed if hemodynamically stable, but if some complications are there, then patient should be kept intubated and it should be reversed in ICU setup. In cases of decompensation, pulmonary edema, post-operative mechanical ventilation is advised. Oxygen supplementation is advised and monitored in post-operative period for 24 to 72 hours till blood volume reaches stable levels. Post-operative analgesia is given to the multimodal anesthesia preferred, as we have already discussed. anticoagulants to be restarted in ASRA guidelines, and management of post of hypothermia and shivering is done, and continue the cardiac medications as the patient was taking earlier. Thank you.
Thank you. Okay, so Dr. Jyoti has put everything in detail. We have two questions which are there in the panel. So what should be the ideal dose of oxytocin and how long do we have to continue oxytocin? So one is oxytocin, we usually put 10 to 20 units in 1 liter. So that means 5 to 10 units in 1 VAC, and we let it go very slowly, roughly 30 to 60 micro units per minute. So that makes it roughly 1 VAC to go over 3 to 4 hours in case it is 5 units within that. So that much. Most of the patients of cesarean, we continue oxytocin, or the obstetricians continue it for roughly 3 to 4 hours or so post-op. But the patients who have an increased tendency of bleeding or maybe a hypotonic uterus, like the patients who are previously on anticoagulants or so, which have an increased tendency to bleed, or particular case where the uterus is likely to be bleeding, like hypotonic, patient repeatedly having PPH, or the previous cesarean, some of the times there is a problem. So those, the oxytocin is continued for a greater period of time, sometimes even up to 12 hours or so. Okay, so what is the admission criteria according to severity of MS, asked from Dr. Jyoti. But I will say all the patients who are severe mitral stenosis, that is NYHA of 3 or 4, or a documented mitral stenosis where it becomes moderate to severe, the exercise limitation according to NYHA, or the patients who have pulmonary artery hypertension, or the patient where some clot was there and it was diagnosed, or some other problem is there, those all patients need to be admitted. Okay, sometimes the patients are also admitted in our specialty in our country because the patients need to be shifted from warfarin to injectable heparin. So that also becomes an indication of shifting the patient and admitting the patient. When should ultra fractionated or low molecular weight heparin be stopped before GA and LSCS? So one, the question would have been more appropriate for us as anesthetist. Like, in case I'm planning to give a neuroaxial block, when should we stop these? So one, warfarin is, we do a bridging therapy. So that is usually stopped 5 days before we shift it over to heparin. Most of the time, currently the patients are getting a low molecular weight heparin. So we make sure that before we do for an ultra fractionated, at least 6 hours have passed by, preferably 12 hours. For a low molecular weight, it is again at least 12 hours have passed by, and we try and we check it and then we give it. And before any epidural fiddling is done, like suppose if GA is to be given, then it is not that important from our point of view for epidural hematoma. But yes, the patient will have a surgical incision and there is a high likelihood of bleed. So we can, in case like suddenly the fetal distress is there and the patient is getting a heparin and he has just got it 2 hours prior, then do we say let the fetal distress go, continue, we are not going for cesarean? No, we do not give a regional anesthesia. We don't give a neuroaxial block. We take up the patient under GA and we keep blood and blood products and we go ahead with that. So we do that. Okay, I think these are the questions I saw. That's it. Anything else, Dr. Jyoti? So we've already summarized everything and people would have listened to that.
Yes, ma'am.
Dr. Amit, thank you.
Thank you so much, ma'am.
Thank you, ma'am.
One more thing I would like to emphasize, please remember that these are all pregnant patients. Their oxygen requirement is much higher as compared to the normal healthy people. And in mitral stenosis, the moment the cardiovascular system gets compromised, then the oxygen delivery also goes less. The people should remember, like most of the healthy adults, non-pregnant state require 3 to 3.5 ml per kg per minute of oxygen. While in pregnancy, it is nearly double to around 6 ml, 6 or 6.5 ml. That is during pregnancy, when we are talking about pregnancy, we mean to say nearly at term. So the oxygen requirement is quite high. In fetus, it goes, or the newborn baby, it goes up to 7 ml per kg. So this much oxygen. So that means even a small compromise in the cardiovascular system can lead to a disastrous thing. That is why Dr. Amit went on saying most of the time, whenever he was saying cardiac failure, he was also saying hypoxia. It was coming reflexly because whenever cardiac failure is there, or cardiac compromise is there, these particular patients, pregnant people, the chances of careful. So that's it. The key features already been discussed many times. So thank you so much. Okay.
Thank you.
Welcome back, everyone. The results of the second quiz are out, and the winner is Dr. Rupesh R. from AIMS Rishikesh. Many congratulations. I will now like to invite Dr. Surinder Sharma to chair today's next session. Dr. Surinder sir is Chairman Anesthesia at Medanta Medicity, Gurugram. His areas of special interest include orthopedic anesthesia and pain management. I welcome you, sir. Kindly unmute yourself, sir.
Thank you so much. Welcome, Dr. Raghuveer Singh Radu. And I think others have also joined, Dr. Tepat Bindra and Dr. Karlika Doctor. It's a pleasure to introduce to you today 3 topics which are very essential and very important, not only from the point of view of post-graduation, but from the point of view of actual practice we do. And the first talk, we have a very eminent teacher and academician and a good human being, a friend of friends, always and ever helpful, Dr. R.P.S. Gehdu, who's professor in anesthesia and HOD in pain medicine at D.Y. Patil Medical College, Navi Mumbai. His area of interests are difficult airways, cancer pain. He was at Tata Cancer Institute and did a lot of work on pain. And obviously his important interests are with cancer and pain. His achievements, well, he's been an examiner, paper setter for various exams. He has written chapters in books. He's been editor for books. He's been an international faculty, national faculty, always sought after teacher. And today, confidentially, let me tell you, he's going to reveal one of the question in the paper which you are going to get, which is about the anesthesia machine check and safety features. And he'll tell you in detail all the specific points, how to attempt that and understand the basics of the whole system. Dr. R.P. Gehdu, please.
Thank you very much, Appec, for making me a part of this such a fantastic academic program. And I'll be speaking to you on the anesthesia Boyle's machine. Which is the most famous machine that is being used every now and then, because every hospital, every company has got different machine, but Boyle's machine is the only one which is being maintained as a standard. So let's start with the Boyle's machine. If you see, the objective of my lecture will be basically Boyle's machine contains a gas supply system, which can be a jumbo cylinders or a pipeline system. Then it has got 3 parts, that is high pressure system, intermediate pressure system, and low pressure system, followed by, of course, circle absorption system. So this is most important part for us to discuss today. But before we go, we must see the historical aspects also, which is more important. That Boyle's machine was basically invented by Sir Henry Edmund Gaskin Boyle, who invented it in 1917, but the first public demonstration was done in 1918 in the Royal Society of the Medicine. Thereafter, in 1933, it was Coexter who used the dry bobbin flow meters, and this was replaced by the rotameter, which are presently seen in 1937. They are dry bobbin flow meters. Anesthesia machine is a device which delivers precisely known but variable gas mixture, including anesthetizing and life-sustaining gases. But always remember that it's a continuous flow machine. Earlier, they used to use the intermittent flow machine, which were also called as demand flow machines. But today we are all using intermittent flow machine systems. Now, the essential components of this machine system are, of course, as mentioned over here. That is, apart from the gas cylinder, we can start from the flow meters, thereafter the vaporizer, and thereafter it is the exit point where the gases exit into the APL breathing system, APL wall, and thereafter it is going to the patient. So this is how the Boyle's machine has been divided into 3 parts. That is, first, here you can see it is a high flow system. Then this is the intermittent pressure system and low pressure system. In high flow, it contains basically all the cylinders, and it is available up to the pressure reducing valve. Beyond pressure reducing valve, we actually on the machine go directly to the low pressure system, and intermittent system basically contains all the pipeline systems. So let's come to the high pressure system. High pressure system receives the gases from high pressure E-size cylinders attached to the back of the anesthesia machine. The components of the high pressure system is hanger yoke, that is a reserve gas cylinder holder, check valve, then cylinder, pressure indicator, and pressure reducing valve. These are the four essential parts of the high pressure system. Let's come to the medical gas cylinder. The thing which we use commonly in the anesthesia system is E-size cylinder, which has got a dimension. Let me be very clear that these are the things which are being asked in the practical examination when we come to the table via. So E-size cylinder is 4 1/4 inches into 26 inch, which is the length of it. 4 1/4 is the width, and 1/4 is the thickness of the cylinder. The parts of the cylinder are the body. So this is the body, then this is the shoulder and the cylinder valve. So it is constructed by steel and molybdenum. Basically, molybdenum is being added to make it lighter by weight, but at the same time, it makes it much more stronger. So this is one of the safety mechanisms that can be seen. There are multiple markings on the cylinder, but the most important marking is if it is being made up of the steel, then it is 3AA. Well, if it is 3AL, in that condition, it's an aluminum made, which makes it MRI compatible. So whenever this machine is being used or the cylinder is being used in the MRI, it is used as a 3AL type of the cylinder. Thereafter, we come to the cylinder valve, which is made up of either brass or the bronze. And in the cylinder, on one side, it basically contains the port from where the gas exits, and the second side contains the conical depression, which is bang opposite the port, and just below that, there is a safety relief valve, which is very useful when the sudden increase in the gas pressure occurs. We'll come to that a little later. So these are the different sizes of the gas cylinders in the E size. If you see on the oxygen, which has got a color coding, which is again a safety mechanism, which has got a black body with a white shoulder, and the pin index is 2.5. It is in the gaseous form. The cylinder pressure is 1800 to 2200 psig, while the cylinder volume is 659. While that of nitrous oxide, which is a blue in color coding, pin index is 3.5. It is, I can say 7/8 of it is in the liquid form, and only above 1/8 is a gas form, which as and when this 1/8 is being used, another 1/8 comes from the down. So this is how the gas liquid gets converted into the gas. The cylinder pressure over here, that is the reason it has got a very less one, 745, but the volume, because it's in the liquid format, it has got a volume of almost 1590 liters. Cyclopropane, orange color, 3.6 pin index. It is also liquid plus gas, while carbon dioxide is gray cylinder, which is 2.6 and liquid and gas form. Air is also there. Air cylinders are also available, which is just reverse of the color coding as oxygen, that is white body and black shoulder. While the pin index, there are two pin index that are being given, 1.6 and 1.5, but it is available in the gaseous form. Let's come to the pin index safety system, which is very important. This is how the pin index safety system, as you can see, this is the port from where the gases will exit to the machine. And these are the pin index systems. These two holes are the pin index systems. So the pin index system basically contains, as it has been earlier said, 2.5, 3.5, 6.5, 3.5, 4.5. This is how it comes. So that even if I want to put any other cylinder, I cannot put, because it has to have a pin index of 3.5. If it is been put in a wrong way, you will see that it will not be attached over there. So there will be potential leakage of the gases. Now come to the safety relief valve, which is just on the opposite side of the cylinder port. So this is most important thing, because whenever the cylinder is being kept into the, let's say, in a hot room or in the room which is enclosed, so whenever there is a temperature rise, there is a pressure rise, so it can explode the cylinder. Or if the cylinder is being transported into the truck and it is banging onto the walls of the truck, In that condition also the pressure increases and that can lead to the blast of the cylinder. To prevent this blasting because of the increase in pressure, the safety relief device are being incorporated, and there are 3 types of that. Of course, all cylinders don't have 3. It's only 1 in each cylinder. The one is the fusible plug, which is the most common one, which is made up of an alloy, which is called as Woods metal. Many times in the examination, the people do ask that, what is Woods metal in this Boyle's machine? So basically, you should have to say that it is a safety relief valve, which is made up of bismuth, chromium, cadmium, and tin. So it is been an alloy of 4 different metals. That is the reason at a certain temperature, when the temperature exceeds, whenever the pressure increases, temperature also increases, and that is the time this alloy or the fusible plug will melt, and that makes the gases released. Second one is a frangible disc, which as you can see over here in the red color, it's over here. So this is what we call it as a frangible disc, which is kept in such a delicate fashion that whenever there is increase the pressure, the disc automatically falls down, that releases the excessive pressure. The third one is a spring-loaded valve, which is the one which can be can be reusable, while the fusible plug and frangible disc are not reusable. There, it has to be sent back to the company, and they will reinstall this fusible plug or frangible disc. In spring-loaded valve, whenever there is an excess pressure, the spring gets compressed because of this excessive pressure, and that releases the extra pressure. These are the valve systems. Next part is the hanger yoke, on which we are going to hang the cylinder. So this is a hanger yoke which has got multiple parts as it has been shown. The Bodex seal is also called washer, which is one of the safety mechanism again, because of this Bodex seal, there is no leakage of the oxygen or any other gas, and that prevents any mishap that can occur. Then gas inlet port is just in between the Bodex seal. Safety pin index I already told you. The retaining screw is the one behind on which it fits onto the cylinder, and then yoke handle and yoke plug. That is not important. Next part is Borden's pressure gauge. Basically, it is an anaerobic type of pressure gauge which doesn't contain any air, but it has got a bent tube, as you can see over here in the yellow color. So this is a bent tube which is U-shaped, and this bent tube is basically attached to the pressure of the cylinder that is being coming from here. So whenever the gas is being released, this bent tube becomes straight, and that makes the pointer go up or down whenever the gas is being either released or put off. So this is how you can mark out whether how much pressure is there in the cylinder. Of course, in the earlier days, it was only the oxygen cylinder which is being shown over here. The oxygen pressure gauge was there, but now even the nitrous has come out, which has got a blue dial, while oxygen has got a white dial. Check valve assembly is the one which is just next to the port. So this check valve assembly plays a very important safety mechanism, because it allows the gases that it releases from the cylinder to enter in the machine, but prevents the gas exiting from the machine when there is no cylinder attached. So it is something, in a simple example I can give you, when we fill up the air into the cycle tube. So whenever we are pumping the air, there is a ball valve which moves away, and the gas or the air goes into the tube. As soon as we release the pumping mechanism, the ball comes back, and that is how whatever we have filled the air into the tire or tube, it doesn't come out. The same mechanism is over here. That's what I have shown over here also. So it allows the empty cylinder also to be replaced with a full one, but that doesn't make the in-use cylinder to leak the gases from this side. So from other cylinder, the gases will not come out from here. It's sort of a one-way valve. Next part comes the pressure reducing valve, which is the one which was introduced in 1937 and all. So this is the one which is very important for us. Here, the most important thing is it works on a principle that it reduces a high variable cylinder pressure to a lower and constant pressure suitable for the use of the anesthesia machine. Because if it is a higher pressure that is being used, it can damage all the further parts, right from the flow meter to the pipeline system and vaporizers, and ultimately to the patient's lungs also. So that is why a constant low pressure is very important. This is how the pressure reducing valve works. Earlier it was called Adams valve. Now it is called just a preset valve or pressure reducing valve or even regulator. Now, why we need it? Because it helps in fine tuning of the flows in the flow meter. And then it prevents the damaging of the machine like flow meters, etc. It also makes the system more economical because higher pressures are going, so high flows are going, so which are actually patient may be needing 4 or 5 liter, but because there is no control over that, so it may be releasing 10, 15 liter. So this is a waste, and also it can increase the chances of OT pollution if this control is not there. So basically this pressure reducing valve also decreases the chances of OT pollution. And the principle that is one is very important. A large pressure acting on a small area is balanced by a small pressure acting on a large area. As you can see, the red markers, red pointers are for the high pressure system, which ultimately goes over here, and it gets ultimately it comes as a regulated low pressure. So here it was something like 1800 psig, while it comes out at a 35 to 45 psig. Then comes to the intermediate pressure system, which basically, as I told you, it is concerned with the pipeline system. So it receives the gases from the regulator or the hospital pipeline at a pressure of 40 to 55 psig. It contains all these parts: pipeline system, pipeline pressure indicator, master switch and all, but this is not a part of the Boyle's machine, and it is a separate big topic, so we will not cover right now about this. Now comes to the oxygen failure device, or what we call, whenever there is a master and slave mechanism. Whenever the oxygen pressure suddenly drops down or oxygen percent drops down below the 20% or so, automatically the nitrous itself gets cut off. This is what is called master and slave, where the oxygen acts as a master and nitrous acts as a slave. So this was the mechanism that was earlier present, master and slave. Today, the new system has come that is called Link 25, where there are two different chain-like system, where for nitrous there are 14 teeth and for oxygen there are 28 teeth. So whenever there is even a one rotation of the oxygen teeth will reduce the nitrous by multiple times. This is how this new system works. Now come to the next part, that is low pressure system, which basically starts after the pressure reducing valve. So it extends from the flow control valve to the common gas outlet. And it consists of flow meters, vaporizer mounting devices, check valves, and common gas outlet. Let's come to the first part, that is flow meter assembly. So all flow meters, remember, are arranged in the parallel, while all vaporizers in the olden days were arranged in the series. But today, of course, you can use one only vaporizer at a time. Earlier, there were any vaporizer you can use earlier. But now I can say that in the flow meter, they are all being arranged in the parallels. The components of the flow meter is being shown in this diagram also, that this is a flow control knob. Thereafter, this one, the round one, what is shown is a needle valve. Then these are the Thorpe tubes or rotometers. Then there is a bobbin or float. Then there is a spring float stop, which stops the float from jumping out. And then there is an anti-static spray that is being sprayed inside, so as to prevent any friction that leads to the dropping of the pressure. Now, flow meter knobs are color coded, touch coded, and placement coded, so that if you see the oxygen, it is being placed a little more anteriorly, while the nitrous and all other things are being put little posteriorly, so that when you're blindly also we touch, we'll first touch the oxygen. While oxygen is touch coded, it is being very rough, while nitrous and all are very smooth. The needle valve is at the bottom, so that whenever, whatever amount of the knob we rotate, that much the needle will open up the system. Thereafter, the flow will increase. Now, the flow meters are basically made up of two tubes. They are called Thorpe tubes. The inner tube is being going down in a decreased manner, while the outer tube maintains the same one. Outer tube is uniform in diameter and inner tube is tapering downward. There is an anti-static spray that is being present, that is also called Crockstein. Commercial name is Crockstein. It has got bobbin and indicator, which are of different types. It can, in the earlier days, it was H shape, I shape, O shape, disc shape, then boat shape, plum boat shape. But today they are using is the one which is shown in the last, that is the skirted bobbin. The reason why skirted bobbin is being used is they say that through these skirtings, that is, the gases will rotate through this skirting. That is how it makes the bobbin rotate. So this is one of the another safety mechanism so as to know whether the gas is really flowing or not. Then, of course, in the present days, there are electronic flow sensors that have been put up, which has been now replaced the conventional gas flow monitors and gas tubes. So here, it basically shows you there are some systems where you can see the individual oxygen and nitrous also, but there are some where it is being shown in a together format, in a graphical format. So that also can be shown here. It is being shown as a graphical format, and yet it is being shown as a number format. Now, what are the factors that are affecting on the flow in the flow meter? This is what is being asked in the short note also in the examination in theory. So remember, calibration of the flow meter is being done at 1 atmosphere and 21 degrees centigrade. That is at the seashore level. So factors are affecting our ambient temperature. For example, if I am using this flow meter on the Himalaya, naturally the temperature is low. Same thing, atmospheric pressure. If I'm using it again at the Himalaya or the air or in the seashore, in the bottom of the sea, the atmospheric pressure acts differently. Then size of the annular opening, larger the opening around the float, larger will be the flow. Then pressure drop across the constriction, that is due to friction of the bobbin to the walls. So that also is one of the factors. And last but not the least and important is properties, physical properties of the gas. That is at low flows, which acts as a Poiseuille's law, where the flow is governed by the viscosity. So this is what is called laminar flow, where at a higher flow, the Graham flow, it is being called, the flow is governed by the density of that gas. So this is again a laminar flow, but here the high flows density is going to decide the factor affecting the flow in the flow meter. Now, how the flow meters are being arranged? Normally, earlier it was arranged, oxygen was first, that is proximal, and nitrous was distal, but now the oxygen has been taken distal for the reason that whenever there is a crack in any of the proximal flow meters, the gases will leak out while the patient will be ensured to get oxygen, that is for sure, so patient will not suffer. That is how the newer machines has got one more safety mechanism. Next comes the oxygen flush valve, which is being a part of the machine all. But this is the one which is being used in case of emergency. Whenever we press this button, you get at least 35 to 75 liters of the flow. The only question that is being asked in the exam is whenever we press the oxygen flush, the oxygen bobbin falls down, why not others? The thing is, there is a direct bypass system which takes the gases straight from the cylinder to that flush valve. That is how it works, that the bobbin falls down only of the oxygen more. But the students give answer back pressure effect. Remember, back pressure is not a very important one. Next comes the circle systems. The advantage of the circle system is, of course, there is a relative stability of the inspired oxygen concentration or the gaseous concentration. There is a conservation of the both respiratory moisture as well as heat. There is a less chances of O2 pollution, and very low flow can be used. Even sometimes we use 500 to 1 liter also is enough for us. But disadvantage, of course, it has got a very complex design. That is why if it is being used for a longer time, there are multiple one ways also, so it can give sometimes a very high resistance. The circular substrate, the principle is, if a sufficient amount of oxygen is being added to the supply of the body vessel needs, the CO2 is eliminated, then the same mixture of the anesthetic acid can be used again and again. This is what we call it as an economical one. There are multiple components, as you can make out, apart from the CO2 absorber system, that is the canister over here. There are other systems, that is unidirectional valves, which are being over here, followed by inspiratory and expiratory port, and then fresh gas outlet is somewhere here back. So this is how all the system works. Now the absorbents are there. There are multiple absorbents that were available earlier. Today beryllium is no more used, but soda lime is the one which is most commonly used nowadays. The principle over here is the base neutralizes acid. So base is basically all the soda lime, while acid is the one which is in the HCO3, that is in the gas. So soda lime contains, it's a wet type that is being used. Here 81% is the calcium hydroxide, 4% is the nitrous oxide, 1% is the potassium hydroxide. then 14 to 90% is the water, then silica, which hardens the granules, and Kisselgar, which basically maintains the porosity and indicators. This is very important because it is the 4% sodium hydroxide, which is the initiator of the reaction that is going to happen after the CO2 has been coming into the system, and which ultimately leads to the absorption by the calcium hydroxide. The size of the granule is 4 to 8 mesh, and hardness of the soda lime is 75. There's something called channeling, which basically whenever the soda lime is being used, the soda lime at the corner of the system, that is canister, is being used more, so that leads to the channeling, so gases escape from there more. Now these are the indicators that are being present, multiple indicators there. Different institute has got different indicators. So you can see that color changes. The initial color is white, which becomes pink in phenolphthalein, then ethyl violet, and so many other mimosa shade are also there. Now the contents of the absorber, sometimes they do ask you that it contains the volume of the canister is being divided into two segments. There is a granular space and air space. Basically, granular space is being 0.9 gram per cc of the soda lime, while airspace is 45 to 75% of the volume of the canister. I think normal exhaustion time is about 8 hours. The problems with the soda lime absorbent are, of course, today trilene is not been, but whenever it was used earlier, it used to produce what called dichloroethylene and phosgene, which both were neurotoxic. So that is why it is not been used with the soda lime. So there was a trilene lock earlier, but today it's not been used. Sevoflurane has been used, but they say it is also unstable by producing compound A. And it has been said that whenever we are using sevoflurane, it is not recommended at a fresh gas flow of less than 1 liter per minute for the maximum 2 Mach per hour. So we should ensure that the sevoflurane is being, whenever we are using sevoflurane, it should be at least 2 liter plus fresh gas flow should be there. Now, ideal arrangement is also important so as to ensure that the maximum inspiratory concentration of oxygen and inhalation should be there, as well as a proper utilization of soda lime, so that often again and again the gases don't enter the soda lime, so that the soda lime is overused. So ideal arrangement, they say, is rebreathing back and relief valve should be upstream to the canister and downstream to the expiratory unit action valve, while the fresh gas flows should be upstream to the inspiratory unit action valve and downstream to the canister. This is the ideal arrangement that should be there. Now, checking the safety mechanism of the machine is important. To check it every day is very important for knowing the proper functioning of the gas delivery system, proper functioning of the electronic gadgets, that is suction machine, plug points, etc., so that there is no spark and oxygen, chances of blast are there. Then proper functioning of the anesthesia machine part, that is, you should mention that there is no leak, no occlusion, or some parts are not missing. So these are also very important. Plus, a standby ambu bag and emergency kit has to be kept ready. Now, what is the checklist we want to do? You should ensure that the checklist is being done always before the start of the theater, as well as the checklist should be before the starting of the new patient also. We should ensure that every time you take a new patient, it should be checklisted again. So checking the high pressure system is always check the oxygen reserve cylinder supply, so that whenever the central pipeline or some cylinder gets off, you should be able to have one standby oxygen cylinder also should be available to us. Then open the oxygen cylinder and verify at least half full, and check for a wrong cylinder or proper gasket and broken pin index. That also should be checked earlier before we put it onto the patient. Always check for the leaks. Either it can be audible leak, or if needed, we can just put a soap water to find out is there any bubbling coming out, so as to ensure that there are no leaks. Then open the flow meter to see whether the flows are being seen or not. Then close the cylinder so as to make out that pressure gauge drops less than 100 psg in 5 minutes. It means that cylinder control valve leaks or leaking pipeline check valve is there or not. Then check the central pipeline supplies also, whereby check the hoses are being connected and pipeline gauges are being reading the pipe figures very much correct. Then hose connection problem should also be ensured, as well as the standby central supply should be ensured. High pressure system, again, you can check the cylinder proper color coded pins, full status functioning of the safety relief valve. Then check the cylinder tag in detail so as to know that cylinder cannot get blasted. Then also check is there any Bodex seal which is damaged, so that if it's damaged, there will be leaks going to take place at the connection point. Then you should also check the preset valve, whether it is leaking or not, because these are the common sites of the leak. Then always keep a spare cylinder, attach ventilator in case needed. Proper electric supply also should be ensured so that there are no sparks, that there are no leaks also should be there. Flow meters also can be checked so that there are no leaks or cracks that are being found on the flow meter. Static electricity development so that bobbin gets stuck down. It has been found that whenever the bobbin stucks down, there is a 30% loss of the flow. Check the master slave mechanism, whether it is working or not, so that whenever we decrease the oxygen, suddenly nitrous falls down or not. If it is not falling down, that means master slave is not working properly. All vaporizers should also be correctly installed and see that their full and filling ports are being closed so that there are no leaks that have been taking place at the filling port. Only one vaporizer to be turned on at a time. Of course, this is the present day it's one, and overfilling of the vaporizer also should be prevented. Thank you very much.
Thank you, Dr. Gaidu. Brilliant and very, very explanatory things for the students. And I'm sure whenever asked any question in their exam, they'll be able to answer it properly. Not only in their exams, in their field of work, in their operation theaters, they'll follow these, know what the things are, and do the property safety checks so that the patient is safe, they are safe, and the whole world is safe. Thank you so much for a brilliant lecture. Thank you, Dr. Gaidu.
Thanks, Appec, and thank you also, Sulindarji.
Okay. At the end of the thing, we'll have some questions, which we'll request you to stay on. Thank you so much. Next speaker is Dr. Tripat Bindra, an ever-smiling sought-after excellent teacher with a brilliant academic award. She's a professor at GMC Patiala. She has interest in obstetric anesthesia, pediatric anesthesia, airway management, and ACLS. She's an ACLS AHA-approved teacher, airway workshop instructor. She's a member of various associations and is an active participant in all the conferences and a very common face seen teaching students all over. And she has been very active in setting up COVID ICU at GMC Patiala during these worst times which we had some time ago. And she has a large number of publications. She will be talking to us about supraglottic devices, which are saviors many a times in difficult times or even otherwise in the routine use. So Dr. Tripat, over to you. Thank you.
Good evening, sir.
Good evening, everyone. I'm very honored to be a part of the academic program of Appec 2022, and I am here to discuss the supraglottic airway devices. By the ASTM, supraglottic airway devices can be defined as the airways that are intended to open, secure, and seal the supraglottic area to provide an unobstructed airway in spontaneously breathing or ventilated patients, typically during the anesthetic procedures. They have become a standard fixture in the airway management, filling the niche between the face mask and tracheal tube in terms of both anatomical position and the degree of invasiveness. These devices, they sit outside the trachea but provide a hands-free means of achieving the gas-tight airway. The most important among these is the classic laryngeal mask airway, which was introduced by Sir Archie Brain. And later on, many additional devices they have developed and they have added to the LMA family according to the specific needs. Indications of supraglottic devices include they provide us with an alternative airway during general anesthesia, especially in short surgical procedures and minor therapeutic or diagnostic procedures like in the radiotherapy suits, ECTs, endoscopies, and they improve the airway seals in patients with difficult mask ventilation, especially in the edentulous patients or in the patients with facial hair. They help us to provide surgical anesthesia without intubation, providing the patent airway with minimal changes in blood pressure, heart rate, intraocular pressure, intracranial pressure or bronchial tone. And they are extremely useful in cardiopulmonary resuscitation to secure the airway with minimal interruption in the chest compressions. And they're now essential part of the difficult airway trolley and can be used for emergency ventilation when the intubation has failed, and also help in assisting the tracheal intubation as the intubation conduits. And they are very useful as a primary airway device when the urgent airway patency is required in the lateral position. Relative indication, professional singers to avoid vocal cord trauma. Very crucial role in the difficult airway. So they can be used as an intubation conduit in the awake intubation, that is in patients with a recognized difficult airway. After proper preparation, LMA can be used as an intubation conduit. In patients with unrecognized difficult airway, they can be used as an intubation conduit in the non-emergency pathway or as an airway device in the non-emergency pathway. Here, in the unrecognized difficult airway, in the non-emergency pathway, that is when the mask ventilation is adequate, LMA can be used as an airway device, ventilatory device for a specific procedure, or can be used as an intubation conduit. Extremely crucial role as an airway device in the emergency pathway, that is cannot ventilate, cannot intubate situation, and also as an intubation conduit in the emergency pathway. Here, this is the emergency pathway when the mask ventilation is not adequate. Here, LMA can serve as a life savior when as a ventilatory device, and can also be used as an intubation conduit if the intubation is mandatory. The contraindications for supraglottic airway devices include limited mouth opening less than 2 fingers, glottic or subglottic obstruction, local pathology in the pharynx, larynx or upper airway, facial or upper airway trauma, non-fasted patients, increased risk of aspiration, acute abdominal or thoracic injury, need for high airway pressure ventilation, and in patients with reduced lung compliance or increased work of breathing. LMAs can be classified according to their evolution, and this is a simple classification as devised by Tim Cook. The first generation devices are the simple airway devices with a low pressure pharyngeal seal, and they do not have any specific design to lessen the risk of aspiration. They include classic laryngeal mask airway, flexometallic laryngeal mask airway, all other laryngeal mask, Ambora 1, Ambora 40, intubating laryngeal mask airway, laryngeal tube, air cube, perilaryngeal airway. While the second generation supraglottic devices, they're specially designed for safety. They have a high pressure pharyngeal seal. They have a port for the gastric drainage tube, which help to reduce the risk for aspiration. And there is an integral bite block. So they include ProSeal LMA, LMA Supreme, laryngeal tube suction D, iGel, Embu again, Combi tube. Based on the sealing mechanism, they can be classified as cuffed perilaryngeal sealers, cuffed pharyngeal sealers, or they can be cuffless pre-shaped sealers. And the basic among these is, first I'll be discussing the first generation supraglottic devices, an overview of the first generation devices. The LMA classic, that is comprised of three main components: the airway tube, the mask, and the inflation line. Mask is designed to conform to the contours of the hypopharynx with its lumen facing the laryngeal opening, and there are fixed aperture bars in the mask that so that the just to avoid the epiglottis, that the epiglottis does not block the laryngeal inlet. And this is made of medical grade silicone and can be autoclaved and reused many times. The seal pressure as recommended by the manufacturer is the 25 centimeters of water. It's available in 8 sizes to fit infants and the adults. More than one size should always be available because the correct size cannot always be predicted. And whenever there is a doubt, a larger rather than a smaller size should be chosen for the first attempt. LMA Unique is a single-use PVC made modification. The tube is stiffer, and while the cuff is less compliant and more difficult to insert as compared to classic, and the similar sizes are available as the classic LMA. Flexible LMA has a flexometallic tube which is narrower and longer and more difficult to insert as compared to classic LMA, and introducer is needed to stabilize the airway tube during insertion, and it has a less incidence of dislodgement once placed and useful in head and neck surgeries, ENT and upper torso procedures where the need to reposition the airway is required. Now the insertion, before the insertion of the classic laryngeal mask airway, first and foremost is to select, this is true for any supraglottic device, first is to select the appropriate size of the LMA. Too small an LMA will predispose to gas leaks during positive pressure ventilation, while a large LMA may tend to come up within the mouth or may have a higher incidence of sore throat. Inspect the LMA for any tear or blockage. A visual check of the mask and the airway tube should be done. Cuff should be fully deflated with a dry syringe to form a flat oval disc. This can be done by pressing the hollow side of the cuff against a clean flat surface. And the deflated cuff should be wrinkle-free. Use a water-soluble lubricant to lubricate the posterior surface of the LMA just prior to insertion. Insertion is done in the sniffing position with the neck flexed and head extended. Use a non-inserting hand to stabilize the occiput. The tube portion is grasped like a pen with index finger pressing on the point where the tube joins the mask. Place the tip of the tube against the upper teeth, inner surface of the patient's upper teeth and aperture facing the forward. The tip is pressed upwards against the hard palate. The neck is kept flexed and head extended, and mask is advanced into the pharynx using the index finger. Press the mask into the posterior pharyngeal wall using the index finger and continue pushing with your index finger and guide the mask downwards until the resistance is felt. Now grab the tube firmly with the other hand and then withdraw your finger from the pharynx. Press gently downwards with the other hand to ensure that the mask is fully inserted. Inflate the mask with the recommended volume of air. So the LMA typically follows the path as followed by a bolus of food while swallowing. That's along the hard palate, soft palate, posterior pharyngeal wall, and the upper esophageal sphincter. Do not overinflate the LMA. A maximum intracuff pressure of 60 centimeters of water is recommended. Normally, that should be allowed to, the mask should be allowed to rise up slightly out of the hypopharynx as it is inflated to find its correct position. And now connect to the circuit and flare the lungs to confirm, and insert a bite block and then secure the element. Other methods of insertion include the thumb index method is another method when the access to the head end is not available. Here, thumb is placed at the junction of the mask and the airway tube, and the LMA and the mask, and it's pushed along the hard palate and then the soft palate with the help of the thumb. And whole of the thumb is inserted into the mouth, and while the fingers are extended over the face in a fan-shaped manner. And LMA can also be inserted with partial inflation of the cuff or by 180-degree rotation, as with the Goodell's airway, or with laryngoscopy or stellate, or insertion from side of the mouth opening. The signs of the correct placement are a slight outward movement of the tube upon LMA inflation indicates that it is correctly placed, and the presence of a smooth oval swelling in the neck around the thyroid or the cricoid area can be seen. Upon manual ventilation, if there is adequate chest rise and feel of the bag, that that helps us to know that the LMA is adequately placed, and capnography and chest auscultation confirm the adequate placement of the laryngeal mask. And upon the appropriate placement, the mask lies in the floor of the hypopharynx, with distal tip of the cuff lies against the upper esophageal sphincter, and the sides of the cuff, they lie in the piriform fossa, and the upper part of the cuff, here the upper part of the cuff, that lies in the at the level of the tongue base. So there can be various problems encountered during the placement of the laryngeal mask airway, maybe because of the inadequate lubrication or deflation or inaccurate technique. The failure to pass the deflated mask up against the hard palate can cause the mask tip to fold back on itself. The mask tip can fold back on itself. Now, when this has started to fold, if it's pushed further, the epiglottis can be pushed into the down-folded position, leading to mechanical obstruction. Mask tip can be deflated forward. It can push down the epiglottis again in the causing obstruction. And mask can either push down the epiglottis, and inadequately deflated mask can push down the epiglottis, or can even enter the glottis, which can lead to mechanical obstruction. The benefits of using the laryngeal mask, they include the increased speed and the ease of placement, and lesser requirement of expertise as compared to the endophageal intubation. There are minimal changes in the intraocular pressure and the intracranial pressure during insertion, and there is improved hemodynamically stability at induction and during emergence of anesthesia. There's increased airway tolerance, less incidence of sore throat, lower frequency of coughing during emergence, and improved oxygen saturation during emergence. And drawbacks include there's inability to deliver gases at high airway pressure. There can be inadequate positive pressure ventilation, and the seal is not good. And there can be chances of aspiration of gastric content, trauma to the pharyngeal mucosa, mechanical kinking, and twisting. Now, these are the various steps which should be taken into account to reduce the aspiration. Now, coming to the overview of LMA fast track. It is a modification of the classic laryngeal mask airway, consists of a rigid, anatomically curved, short and wide bored shaft that follows the anatomical curve of the palate and the posterior pharyngeal wall. There is an epiglottic elevator bar at the mask aperture that replaces the fixed epiglottic bars, and this helps the negotiation of the easy negotiation of the flexible endotracheal tube through it. And also armored flexible endotracheal tube is with a longitudinal and horizontal black line which coincides with the epiglottic elevator bar. There is also a stabilizer rod is also provided along with seal. Pressure is again 60 centimeter of water maximum. LMA fast track is inserted in the neutral position. Hold the rigid handle parallel to this rigid handle is held parallel to the patient's chest. Position the mask tip against the hard palate and slide the tip to distribute the lubricant and prevent the folding of the tip. Now advance the curved airway tube until the straight airway part is in contact with the chin. Inflate the cuff and check for the ventilation. If the ventilation is adequate, then introduce the flexometallic endotracheal tube till with the black line facing the rigid handle till the 15 centimeters mark. Now grip the ILMA handle firmly and lift it forward without levering and advance the tube. Inflate the cuff and check for tracheal intubation. After confirmation, deflate the cuff and remove the connector, and then remove the ILMA over the stabilizing rod. Stabilize the endotracheal tube to prevent accidental extubation. Reconnect the connector and the breathing circuit and confirm the position again. So Chande's maneuver is very useful, very helpful in negotiating the tube into the endotracheal tube into the trachea. They increase the seal pressure and align the axis of the trachea and the endotracheal tube. Firstly, rotate the ILMA in the sagittal position. Here, rotate in the sagittal position in an attempt to find the least resistance in the ventilation. In the position where the least resistance to ventilation is found, and then grasp the handle and draw the LMA forward 2 to 5 millimeters in lifting action without levering the teeth, so that the tube is in the can easily be negotiated into the trachea. Various advantages of the intubating LMA include that very useful in can't intubate, can't ventilate scenarios, allows very fast insertion into the correct position without moving patient's head or neck, and can be used alone or as a guide to intubation, facilitates ventilation between ILMA insertion and ETT insertion, conduit for fiber optic intubation in the presence of blood and clot in the oral cavity, and a difficult laryngoscopic view is irrelevant to the success of ILMA intubation. Disadvantages include they're more likely to dislodge in head and neck manipulation, unsuitable for MRI, difficulty in insertion with limited mouth opening, and there can be displacement of the endotracheal tube. So LMA C-track, it is also, an innovation of the LMA, similar to the intubating LMA. Here, the fiber optic technology allows real-time visualization of the glottic opening and of the endotracheal tube passing through the vocal cords. It's very easy to learn and very effective. So, inserted similar as LMA fast track, has a poor image quality than the flexible fiber optic endoscopes. Cannot be used in a patient with limited mouth opening. Air-Q intubating laryngeal airway that is specifically designed as an intubation conduit. It's made up of medical grade silicone. Here the airway tube is wider and more curved, similar to the anatomical curve of the upper airway. So shorter length, which helps in easier removal. So after intubation, it can be removed without dislodging the ATT using a reusable ILA removal stellate. Ambu Aura Ones, it's a single-use LMA with a preformed curve. Ambu Aura 40 reusable silicone version of the Ambu Aura Ones. Ambu Aura I designed to facilitate intubation like ILMA. The three parts, airway tube, mount area, and the bowl, including the inflatable cuff, they're molded as a single unit for extra safety so that no separation takes place. And there is the preformed curve that facilitates insertion without exerting any force on the upper jaw in neutral position. Cobra perilaryngeal airway, it is also a single-use PVC made latex-free device, and the proximal end, it has a novel head design, grill of a soft bar with a cobra head shape that lies in front of the laryngeal inlet. Streamlined liner of the pharyngeal airway slipper, it's a plastic made uncuffed disposable device, and it is anatomically pre-shaped to line the pharynx, hollow, and the boot-shaped distal part. This is the hollow end of this boot-shaped distal part. Toe rests in the esophageal entrance and bridge, bridges fits to the piriform fossa. Available in 6 sizes. Cuffed oropharyngeal airway. This is also a single-use device and quick and easy to place. Recommended for using spontaneously breathing patients with no risk factor for aspiration. Now the overview of the second generation devices. Second generation devices have been designed to increase the safety. They have an inbuilt gastric channel to aspirate the gastric contents and so decrease the chances of aspiration. There is an integral bite block, and the pharyngeal seal that is better. Most of them can also be used as an intubation conduits. Most important, most specialized modification of classic LMA is the ProSeal LMA. It is silicone made. The features include esophageal drain tube, posterior inflatable cuff, reinforced airway tube, integral bite block, and a metallic introducer. The leak pressure is 35 centimeters of water, which is higher than the classic LMA, available in 7 sizes. Insertion can be done by a standard technique, but that's difficult and can only be done by the experienced users. A metal introducer is attached to the concave side of the device, and it is then introduced in the same manner as the intubating LMA. So this technique is most commonly used, and it's the preferred technique. Can also be railroaded over a bougie via drain tube. This technique also has a higher success rate. An easy passage of orogastric tube has been shown to correlate with the optimal anatomical airway positioning of the device over the larynx. It has various advantages, which include increased airway seal pressures, so better positive pressure ventilation, decreased chance of aspiration because the esophageal opening is isolated from the airway. The drain tube vents the gas leaked into the esophagus, and large bulk of the PLMA reduces the space available for the regurgitated fluid to pool, and there is increased esophageal and pharyngeal seal, and the stomach may be assessed with the orogastric tube. Disadvantages include it is a less suitable as an intubating device and takes slightly longer time to insert than the classic LMA. Can cause airway obstruction by compression of the supraglottic structure and contraindicated for oral surgery. LMA Supreme is a single-use PVC made device. It has a features of ProSeal LMA, intubating LMA, and LMA Unique. It has a large inflatable plastic cuff, but no posterior cuff. Esophageal brain tube is there, and there are fins in the mask bowl to prevent the epiglottic obstruction. The pharyngeal seal is intermediate between the classic LMA and the ProSeal LMA. The iGel LMA, it is a novel supraglottic airway device designed by UK anesthetist Mohammad Nasir, single-use device. It has a non-inflatable cuff made from a unique soft gel-like material, allowing the ease of insertion and a reduced trauma. And there is an epiglottic rest that reduces the possibility of epiglottic downfolding and airway obstruction. The buccal cavity stabilizer aids in insertion and eliminates the potential for rotation. Integral bite block reduces the possibility of airway channel occlusion, and the gastric channel allows for the passage of the nasogastric tube to empty the stomach contents and facilitates venting of the air. Insertion is in the sniffing position. Chin should be gently pressed down and introduce the leading soft tip into the mouth of the patient in a direction towards the hard palate and glide the device downwards and backwards, downwards and backwards with a continuous and gentle push until a definitive resistance is felt. So this is iGel has definitive, the cuff has a very low coefficient of friction, very easy to place, can be commonly used as an intubation conduit. It's a very useful and very commonly used device nowadays. Embora again is also a second generation laryngeal mask. It satisfies the three fundamental airway management needs by integrating the gastric axis and intubation capability in an anatomically curved single-use device that facilitates rapid establishment of the safe airway. The thin and the soft cuff is designed to deliver high seal pressures documented up to 40 centimeters of water. So gastric tubes up to 16 French can be easily passed through the gastric tube channel. Laryngeal tube is a multi-use latex-free single-human silicone tube. It has two cuffs. Distal cuff blocks the entry of the esophagus and reduces the possibility of gastric insufflation. And the proximal cuff seals the oropharynx. There are two ventilation outlets in front of the larynx for efficient ventilation and passage of the fiber optic bronchoscope. The connector is color coded for easy identification of different sizes. Advantages are easy insertion, high ventilation pressure can be used, and better protection from aspiration can be used to intubate the trachea. Esophageal tracheal combi tube is a PVC double lumen device with two inflatable balloons and two lumens. 95% of the cases, the tube enters the esophagus. Proximal balloon seals the oral and the nasal cavity, and the distal one seals the esophagus. Insertion is done in the neutral position. Lubricate with the sterile lubricant and insert the combi tube that it curves in the same direction as the curvature of the pharynx. Begin the ventilation through the longer tube. If the auscultation of the breath sounds is good and the gastric inflation is negative, then continue. like this, continue, or otherwise otherwise vice versa. Easy Tube is also a new disposable PVC double lumen latex-free airway device. It has a design closed similar to the CombiTube. Alicia airway device is a novel silicone-made latex-free device. It has 3 separate channels for ventilation, intubation, and gastric tube insertion. The ventilation and the intubation can be done simultaneously, or side by side, but they join at the ventilation outlet. The intubation channel allows passage of a 8 mm endotracheal tube for blind or fiber optic guided intubation. Vasca mask was introduced in 2012. It is a self-recoiling membrane distally open cuff and consists of a bite block over the full length of the airway, a self-sealing variable pressure cuff which adjusts to the contours of the mouth and the pharynx, a dual drainage system, and a tab for manually curving the mask to ease the insertion. Other newer supraglottic devices include elder laryngeal airway, glottic aperture seal airway, glossopalatal tube, triple endoscopy access airway, etc. The complications, they occur rarely in clinical practice, but various they have been reported. To summarize, an ideal supraglottic device should be affordable and should be providing a good reliable sealing with aspiration protection, could be used as an intubation conduit with high success rate of insertion on first attempt. There is no solid evidence of any device performing better than the classic LMA among the first generation supraglottic devices. In the second generation supraglottic devices, PLMA proved to be very efficacious and safe in both routine and advanced uses. Supraglottic device with a drain tube has become the first choice as a standard of care now. And other newer devices like iGel, LMA Supreme, and laryngeal tube suction tube, and Vasca mask, they have increasing positive evidence of their superiority. All these developments in the field of supraglottic airway devices have paved the way to take an ever larger role in the modern airway management. Still larger clinical trials they are needed so as to prove the superiority of any one supraglottic airway device over the other. And this is now I conclude my talk, and any kind of questions, discussion, we can do. Any questions are welcome.
Thank you, Dr. Tipat, for very, very extensively dealing with this topic of airways, of supraglottic devices. You have passed air through all the airways, and there are so many of them that I don't think anybody would lack anything else to find a better one for what their personal use. I think I can't see Doctor on the screen. Is she there? The next speaker?
Trying to join.
Ma'am is trying to join, sir, but she's unable to join right now. She's trying.
She's not there?
You've not received any questions for the presentation, sir. Otherwise, I would have moved on to the questions, but there are no questions still.
Yeah, I think I can make a couple of comments on this. Not
Sir.
too bright ones, but one is that for all the students who are going to appear for the exams, what Dr. Gadu emphasized and very relevantly emphasizes that basic thing is the Boyle's machine, which is the basic principle of anesthesia machines. So they should have a good knowledge, as he has emphasized, of these machines, because I may be having in my Medanta Institute, one particular type of anesthesia machine, he may be having in his Tata Institute or in his medical college, a different kind of machine. And everybody is not supposed to, specifically the postgraduates, they're not supposed to know about every machine they have. But the examiner will say, okay, leave this. You don't know about this machine? Okay, go ahead. Tell me which machine are you using in your institution, right? So you should have a basic knowledge of Boyle's machine, anesthesia machine principles, which are basically same for all the machines, similar. The pattern may be different, or the style may be different, or the mechanisms may be different. They may be electronic these days and all those things, right? Dr. Gedu.
Yeah, absolutely, you're right. But the thing is, let me tell you again, as you rightly said, many institutes have got many different machines. But as far as exam standard is concerned, whether it is theory or practical, it's always asked about is the Boyle's machine only. Whether it is reducing valve, whether it is a flow meter, or whether it is a safety mechanisms, it's always been asked about that only. Even cylinders and all. So I think you are absolutely right.
Yeah. So
that's the reason whenever I go for this lecture, I always emphasize on to the Boyle's machine only.
Yes, I think some of examiners who are more oriented toward newer machines may sometime want to know about some newer machine. But if you don't know that, you can say that we are using this kind of machine. So then he may ask you questions on that. And if you can't answer that also, that may not be in too good impression on the examiner. That the machine you're using, you're not able to tell about the principles and the mechanisms.
You are supposed to know the basic Boyle's machine. That is most important.
Yeah, to pass out, that's probably the best.
Correct.
I think I can see Doctor here.
Yes, Tarlika has come.
Yeah. Yeah.
Tarlika is not muted.
Would you please unmute yourself?
Welcome, Dr. Tarlika.
She is not muted. She is not unmuted.
Tarlika ma'am, please unmute yourself.
Please unmute yourself.
Okay.
Yeah.
Can you hear me now?
Yes, ma'am. Very clear, very clear.
Okay, thank you very much. And
Okay,
sorry for the trouble. The lecture is getting uploaded. If you want me to start, I can start it, but then it will not be comfortable, like to play it.
Ma'am, you can do it live. You can share the screen and you can do it live as well if you're comfortable.
That also I can do it, but in this mobile, I don't have. I have it in the laptop. Should I do that? I can do it, no problem. Just a minute.
Then another thing about the supraglottic airways, I think the people or the anesthesiologists or the vintage of those going through cyclopropane, chloroform, ether to halothane and to the modern anesthetics, we had none of these kind of things available. So many a times when I talk to my students or junior colleagues, they are sometimes wondering, sir, what did you do when there was no supraglottic airway or there was intubating laryngoscope and all that? So they can't even imagine that life could exist and safety could be there without it. I said, just go outside your medical college, go to a peripheral area, and you'll know how people work and how things go on. These are only things which add to our safety and our ease. But on the other hand, the basic things in anesthesia, they can save and support any patient.
I must say one thing, there are still certain
To
places.
do it, sir. I'm trying to
There are
come
still
live.
some places where tile is still being used in Maharashtra.
Oh, yes. Oh, yes.
Still being used.
Yes, I've used it a lot.
But this is another question that is being asked. Actually, I didn't discuss this now since Tarlika is not coming over here. I think I can talk that also because today, if at all, I want to use what you call trilene, can I use it with soda lime? Because earlier it was stated that it causes phosgene and all those things. But let me tell you, today I can definitely use it with the soda lime. There's no problem at all today because the thing is, there's nothing to do with the trilene. Trilene had no problem at all. The thing, they have changed the quality of the soda lime today. So that soda lime doesn't become that hot. And it was basically the temperature which used to spoil the trilene to convert it into the phosgene and all. So today I can definitely use the trilene even with a soda lime or the closed circuit.
Yeah, that's the development we have. Yeah.
I'm lucky, as you have said, Surinderji, I'm lucky that I have used both trilene, chloroform, halothane, ether, open drop anesthesia, everything.
Yeah.
I must
We
have
had
given
in-
more than 2,000-3,000 open drop anesthesias.
Yeah. We had in Delhi one of our very senior colleagues who used to give ether anesthesia, open ether anesthesia, even in practice till quite late for even laparotomies. And he was master. I mean, you could not see his patient coughing while induction. You could not see his patient bucking while surgery was going on. Not his patients were, surgeons were complaining that the relaxation was not adequate. He used to cover the face with one of the sheets or towel, which people thought that he probably doesn't want to let us know the technique he's using. But then I spoke to him once. He said, no, it is because I don't want me to inhale ether. So that's why I cover it up so that most of it doesn't come to my face. And in one of the, if you know Dr. I.K. Sethi, he once was coming from Chennai to Delhi. There was a railway accident. There was a cardiothoracic surgeon of that fame in South. He was on that train as well. So they both got out and they saw many casualties. So they thought in one of the small centers they had ether. So they were doing some stitching and all that. So Dr. I.K. said he was giving open ether and he was doing the stitching and surgery or reducing some joints. And then after, he says that, I don't know, but sometime later, he said, oh my God, where is Dr. Sethi? And he was lying down because he had inhaled so much of ether in that closed space that he says, I fell down because this thing. And
that
then,
I don't agree. This
so
I
these
don't
are-
agree because honestly, I never used to cover my face. We used to get inhalation of all those ether and all. In fact, when the ether was stopped, I must say, whenever I used to change my theater, we used to take the ether drops on our handkerchief and smell it.
to feel at home. To
Yes.
feel at home.
Yes. Anyway, I have conducted many open drop camps also for tonsillectomy. Must have given more than 400 or 500 tonsillectomy cases under open drop.
Yeah.
In the periphery of the peripheral areas.
I think that, I mean, they were not, they were more maligned, but they were quite good anesthetics. I think the techniques and everything
Most
was
ultra safe anesthesia technique that I have used.
Perfect, yes.
Of anesthesia.
Can you hear me, sir?
Yes, yes, we are waiting for you only.
Yeah. And I like to add up in that what Dr. Gedus has said. When I was a resident doctor in Baroda, like we used to have the surgical camps, and in that we used to administer open ether only.
Good.
We are the
Same thing.
maximum person. Yeah, thank you.
Okay,
And
let me introduce Dr. Talika Parimal, doctor. She is a professor and head Department of Anesthesia and in charge of pain medicine in BJ Medical College and Civil Hospital, Medicity, Ahmedabad. She is a teacher with a pleasing personality, great academic records, and was the chairperson of ISA Annual 2021, chairperson for the scientific programs in ISA Annual 2021 Ahmedabad, and she conducted it very well. Thank you, Doctor, for being here.
Thank you.
Now the field is all open for your
Thank you, sir.
talk on neuromuscular monitoring.
Yes, sir. Yes, sir. I'll share the screen. So it's more of a, I could not do the live thing, but what I can show is with the slides, and it's more of a technical things rather than the practical, what I wanted to demonstrate. Yeah. So good afternoon to all of you. I bring greetings from my BG Medical College. And let's learn something. What we are using on day-to-day basis is neuromuscular blocking agents and how to monitor it. And it was introduced in 1958, how to assess it during the anesthesia period. With awake patients, what we do is we check with a test for the voluntary muscle strength, and during anesthesia, like you were talking, that we used to see from the bag muscle tone, indirect pressure of the pulmonary compliance, tidal volume, and the inspiratory force. Now coming to the little anatomy and physiology of neuromuscular junction. So it is a synapse between motor neuron and a muscle fiber. The motor neuron are the nerves that innervate the muscle fibers. The motor unit is a single motor neuron and the muscle fiber it innervates. And axon, as the axon, it approaches to the muscle and it divides into the terminals, branches, and loses the myelin sheath. It is very important here. Axon terminal forms a spatial junction, which is like a knob-like structure, and it is like a terminal button. And this fits into the shallow depression in the underlying muscle fiber. And this is where you can see, this is the terminal button, and this is the neuromuscular junction. Now, the membrane of the nerve terminal and the muscle fiber, they are separated by a small gap of synaptic cleft. And again, this is formed by 3 cells, the sand cells, motor nerve, and the muscle fiber. This motor neuron from the ventral horn of the spinal cord, this finally gets innervated into the muscles, and this is only one synapse. And the motor neuron loses its myelin sheath to terminate to the muscle fiber. And it is in the terminal branches against the muscle surface, which is very well covered by the Schwann cell. The terminal Schwann cell extends to the muscle fiber, which encloses the neuromuscular junction and separates it from the extracellular fluid. The nerve terminal, which is thick one, and that's the active zone. The muscle surface, which we know as muscle end plate, that has a corrugated with deep invaginations of the junctional cleft, which has again primary and secondary clefts. And these shoulders of the folds are densely populated with the acetylcholine receptors. This acetylcholine is synthesized and stored in the form of small vesicles in axonal terms in the muscle nerves, and it is abundant in number. This nerve terminal is available in 2 fractions, a small one and a large one. Small one is immediately available in active pool stored in the vesicle. A large reserve pool found both free in the cytoplasm and in the vesicles. And when a nerve is stimulated, there is a generation of the action potential that reaches the nerve terminal. The voltage gated ion channels that opens up, and there is a easy influx of the calcium, and this leads to the fusion of many vesicles and releases the acetylcholine into the synaptic cleft. Now, this acetylcholine gets attached to the receptors on the muscle end plate and depolarizes it by opening the ion channels, and this produces a potential and triggers the adjacent muscle membrane to initiate a contraction. Here you can see the myelin sheath, then the calcium channels, then the voltage gated sodium channels, and this is the motor end plate. Again here, when the action potential arrives over here, the synaptic terminal, presynaptic terminal that causes the calcium channel open up, and there is an influx. And this calcium uptake into the terminal causes the release of the neurotransmitter, that is acetylcholine over here in the synaptic cleft, and this is synthesized and stored in the synaptic vesicles. Again, this acetylcholine, when travels through across the synaptic cleft to the postsynaptic membrane, which is known as the motor end plate. Now coming to the figure again, you can see all this gate and acetylcholine. Then again, this small fraction that is over here, this is the sodium channel. These sodium channels, this acetylcholine molecule, this combines with the receptor side and it opens up the sodium channels. Now, this was the anatomy and physiology. Coming to the type of peripheral nerve stimulation, this is monitored by the evaluation of the muscular response to the supramaxillary stimuli and of the peripheral motor nerve. It can be magnetic nerve stimulator or electrical stimulation. Now, each muscle fiber, it goes by the all or none pattern, as we have learned. Response of the whole muscle depends on the number of muscle fibers that is activated. Response of the muscle decreases in parallel with the numbers of fibers that are blocked. Reduction in response during the constant stimulation reflects the degree of neuromuscular blockade. And that is why we need the maximum stimulus cell. Then what are the essential pieces what we should look for in the peripheral nerve stimulation? So supramaximal current, it is approximately 25% higher intensity current that is required to depolarize all the fibers in a particular nerve bundle. And submaximal is, that is the intensity which induces the firing of only fraction of fibers in a given nerve bundle. It is less painful than the previous one, supramaximal, because it is less in intensity. Then what is stimulus frequency? This is rate hertz at which each impulse is repeated per second. The other important factors are current intensity, nerve stimulators, constant or variable voltage delivery system, or there is a temperature, threshold current, and maximal current, as we have learned it. Now, why we need all this monitoring? With the experience, we learned that the zytocurium, vacurium, all those has a residual curarization of TOF ratio up to 0.9 to 0.7 in different percentage of patients in postoperative recovery area. So we just thought that we need to monitor, and this monitoring is going to help us for the onset of the neuromuscular blockade, level of muscle relaxation during the surgery, the recovery from blockade to minimize the risk of residual paralysis. That problem we are going to face in the postoperative period, and impairment ability to maintain the airway, increased risk of postoperative pulmonary complications, and significant residual curarization, which we are not able to do clinically. Again, it is important where we are using the prolonged infusions of neuromuscular blocking agents, like in ICU, then long-acting neuromuscular block drug use, surgery and anesthesia prolonged, like in cancer surgeries, it lasts for 10-11 hours. Then inadequate reversal may have devastating effects, and morbid obesity can add to it. Administration of reversal may cause harm in form of tachyarrhythmias and cardiac failure. And where the liver and renal dysfunctions are there, there is altered pharmacology. Then to diagnose the neuromuscular disorders and surgeries with profound neuromuscular blockade, that is like thoracic surgery and neurosurgery. Now this equipment can be divided into two. One is with the quantitative monitoring of blockade and one does not. We have objective monitoring, recommended one, and most of it is used widely one in form of acceleromyography, electromyography, and mechanomyography. Now the stimulator can be subcutaneous electrode and ball electrode. The current needed to depolarize all the fibers in the nerve bundle is a maximal current. And as we have already learned, the supramaximal is 25% more needed, monophasic, rectangular, 50 milliampere, 0.2 milliseconds, and constant current at 0 to 5 ohms. There can be different patterns. The batteries can be needed in that, and ECG electrodes we have to use in that. There are different places where we can use the ECG electrodes. That is, one is near the orbicularis oculi. These are the placement. Then we can see this placement near the ulnar nerve, and we can see the adduct pollicis. And the other one is the posterior tibial nerve right over here, and we can see the thumb movement here. Now, which muscle we should select? A muscle with a motor element, which is close to the skin, and contraction in the muscle or the group which the nerve supplies must be very visible and easily approachable and it should be accessible to the response of the monitoring. Now, the patterns what we can get is single twitch stimulation, train of 4, as we know, tetanic stimulation, post-tetanic stimulation, double breast stimulation, and it is recommended that monophasic impulse with rectangular waveform and duration of 0.2 millisecond should be used in all the nerve stimulators. Now, single twitch. It is a square wave supramaximal stimulus at a regular interval. The twitch response is depressed, and when this NMB agent occupies more than 75% of the post-synaptic nicotinic receptors, and this is very well appreciated for the abdominal surgeries when it is more depressed and occupied 90% of the post-synaptic nicotinic receptors. The onset of block judgment has to be very useful. Then you can guard the rest of the doses. Application of the supramaximal stimulus can start from 0.1 Hertz to 1.0 Hertz. It has a limited value in clinical setting, but of course, the technique does not provide reliable information for the recovery or the onset of the neuromuscular blockade. But it is mainly important in the investigation of the onset of the neuromuscular blockade. Now, as you see over here, the stimulation when we do it, it is 0.1 to 1.0 hertz. You can see the constant line here. Then response when it is in the depolarization block, it is all sustained over here, then it is fading away slowly. In depolarizing block, it is all constant there, fades up, and again it comes back. The time period you can see in minute varies up. Again, non-depolarizing and depolarizing. Here you can think about the neostigmine. You can see the fade. In scoline, you can see the fade. There is no fading that is there. Now, if the large doses of depolarizing muscle relaxants are given, as we know, in form of repeated boluses or infusion, it's likely that the phase 2 block can occur, and that can have a characteristic of the non-depolarizing block. And like that, if you go for the top monitoring, you can see the fade observed. It is of two types, normal and abnormal cholinesterase, and it is possible to reverse the abnormal cholinesterase case. Now, there are certain recommendations for the stimulation. The train of 4, if you see the pattern, it is adequate and moderate block can be there, and recurring can be intermediate and adequate. DBS can be intermediate, and the onset and block is not adequate. Then post-tetanic, it is not adequate in pattern and moderate block, while it is for the onset of the block and deep block. Then tetanus is not adequate in any of the thing. Now coming to the train of 4 stimulation, it is the supramaximal twitch, 4 impulses at a 2 hertz at an interval separately 0.5 seconds, and it is the most commonly used of stimulator and does not require any baseline. And you have to compare the 4th twitch, that is T4-T1 ratio, and that is going to indicate the fade. The loss of twitches in T4 can be 70 to 75% block. If it is T3, then it is 85%. If it is T2, it is 85 to 90%, and T1, it is 90 to 95% block. This is how we can interpret the blockade and loss of twitches in top. Again, some part it is covered up here. So it is all the 4-1, it is profound block. Okay. If there are 2 twitches present, then it is sufficient for most of the surgery. Then if it returns all the 4 twitches, this is top. You see 0.2, 0.4, 0.7, and you can 0.9, it's all present over here. So we have to reverse the patient. Now, how we correlate with the clinical one and the top? The 5-second head lift or the leg lift, it relevance to 0.6 top equivalent. Normal hand grip strength can be 0.7 and masseter is 0.86. It's all uncomfortable at top 0.75. Here again, one can see this is, we are reversing over here. The top ratio is 0. And it is when we extubate, it is top is 0.75. Now, tetanic stimulation, it is a high frequency with supramaxillary stimulation applied at 5-second interval. The muscle response was a single forceful and sustained contraction, and this block is filled. It is muscular recovery, non-polarizing blockade. Visual 100 hertz, 5-second tetanic stimulation is comparable to top ratio of 0.85. The sensitivity is up to 70% in detecting the residual curarization, and its specificity is about 50%. It is painful, and TOF can be repeated in 10 seconds, while this cannot be reproduced in 6 to 10 minutes. The fade, why this occurs? Large amount of acetylcholine is released. Equilibrium between the mobilization and synthesis of acetylcholine is present. The muscle response caused by tetanus stimulus of the nerve at 50 hertz, it is maintained. The released acetylcholine is many times higher than the amount necessary to evoke the response. And because of all these reasons, we see the fade when we stimulate the muscle. Margin of safety at postsynaptic membrane is reduced when we are using the non-depolarizing muscle relaxant, and it typically reduces the twitch height with the fade, as we have seen in the previous figures. Then there are some presynaptic receptors known as Bowman, and there is one agent, bungarotoxin, that is a pure postsynaptic blocker, and there we do not see the fade. Now again, when we see the non-depolarizing, the control is here, and there is moderate one over here, the fading part. The depolarizer, you can see the control, and there is a constant fading, but it is at a low twitch height. Now coming to the PTC, used when no twitches are present, number of twitches present inversely related to the time of return of the train of 4. This facilitates the mobilization of the acetylcholine from the storage to the increased synthesis of acetylcholine. The profound neuromuscular blockade is required during the retinal surgery, and if it is not there, then it has its own bad effect during the surgery and the surgeon is not comfortable. I lost the connection. Okay. It allows the tactile or visual evaluation of the deep non-depolarizing neuromuscular blockade, and it does not respond to top stimulation. During PTC 50 Hertz and at 5 seconds, followed by 1 Hertz, supramaximal single stimuli that can be after a gap of 3 seconds. The PTC results in the number of single stimuli responses following the titanic stimulation. Ideally, it is a very deep neuromuscular block, so it is 0, and it is 5 to 7 responses detectable. Return of top response is eminent. Now here we can see the post-titanic count over here from 0 to 16, and we can see all the different muscle relaxants. Many of the residents might not have used many of these relaxants like pancuronium, and they are more using the cis-hydrocurium. So we can see this post-titanic simulation at different time intervals. The DBS, it was introduced in 1989. It minor neuromuscular blockade. Then the tactile evaluation of the top ratio 750 milliseconds, and the burst can be in series of 3 impulses, or it can be 3:2, which is normally used, and the fading of second impulse series compared to the first correlates the top ratio at less than 0.6. This method is much more sensitive one. Here we can see the application is at 0.2 milliseconds and at an interval of 750 milliseconds. Again, you can see the control top. DBS is 2, and this is recovery when we are trying to see the top 0.2, 0.4, 0.7. It's almost there, and top 0.9, it is completely there. Now, which one to use and for what purpose we have to use? Single twitch is only for the onset, to check the onset. PTC is for the intense blockade during the intraoperative period, and TOF is for the surgical period and for the recovery. Now, these responses can be evaluated by visual and tactile method, mechanomyography, electromyography, acceleromyography, and other methods. So electromyography is the oldest method for estimation of neuromuscular blockade. It goes by the force of muscle contraction, which is in proportion to the compound action potential of the muscle. And this has a very good correlation with, but cannot be used and cannot be interchanged. This is mainly used at the site of the limbs, and other sites also can be there at diaphragm and larynx, but it is preparation and maintaining constant temperature. Otherwise, there can be artifact that can be there, and this is mainly used for the research purpose only in clinical practice. So this is the electro, and this is the stimulator, and these are the stimulating electrodes, and this is what we are going to check it out. Coming to the mechanomyography, it is isometric contraction of the muscle following the nerve stimulation, and a force transducer converts the force of contraction into the electrical signal. Ulnar nerve is commonly used, and this is not used in the clinical practice nowadays. And they say one can use it for the onset purpose only, and still it is for the newer the neuromuscular blocker. It is the gold standard method. They use it for the research purpose. Acceleromyography, again, it's a technique in the day-to-day practice because it is cheap, practical, and easy to use. and electrodes are capped at the target now, and that converts the muscle thing, and you can see the contraction in the adaptopolysis. And the basis for this method is the Newton's second law. Force is equivalent to mass into acceleration, where mass is a constant factor and acceleration is measured. And if the movement end organ is the thumb, we used to see the thumb movement, and the electric current will be passing from here. This you can see. Here you can see the level of block over here. TOF and PTC both are there. We are injecting the NVA here. You can see the onset over here in the TOF. PTC and TOF is 0 over here when the intense block is there. And when you go for the deep block, then you try to evaluate the PTC, it is there, but the TOF is not there because it is still a deep block. Moderate block, you can see something over here. Some responses are there, and recovery phase, we can see most of the responses. Now, when there is a residual paralysis in the postoperative period and the TOF ratio is 0.70 or 0.75, then it can be in form of diplopia, visual disturbances, hypoxia, stridor. Overall weakness can be there. The person is not in negative test, and speaking may be affected in that. Overall in that, the generalized weakness and visual disturbances is the key factor. Then 0.85 to 90%, again, it is diplopia, visual disturbance, and generalized fatigue can be noted. Now, again, coming back to acceleromyography, this technique can correlate well with the mechanomyography, but intraoperative measurement, it is much more influenced by artifacts, patient movement, and unstable responses in acceleromyography. So when we fix up something here, we have to fix up the thumb and forearm so that this doesn't move and the interpretation is not wrong. And we use certain devices to fix up over here. Like see, we have fixed up this, so the thumb is not going to move and we can have perfect interpretation. Now, kinemography is that the moment the muscle is there, we generate the voltage, but it is not very much used. Phonomyography, again, it measures the sound intensity, and these are the things we use. The microphone is there in the muscle, and you can see the simulation of the ulnar nerve. Mainly, we are using ulnar nerve for all these purposes. Now, what are the limitations when you use these neuromuscular blocking monitors? And this response may be normal in spite of the persistent receptor occupancy by the neuromuscular blocking drugs. T4 to T1 ratio may be 1, but at that stage also 40 to 50% receptors are occupied, and TOF ratio can be 0.8 to 0.9, which is very high. The adequate recovery and ventilator functions and protections are not equal. Operative nausea and vomiting reaction. There are randomized controlled trials that's conducted all over the world and come to one conclusion. Thus, there is something called acupuncture point P6, which is located at the proximal end of the wrist crease between the tendon and the palmaris longus. Here, the flexor carpi radialis muscle of the forearm, and there this point is there, and if you stimulate that point, it is just said that the postoperative nausea, vomiting chances are reduced. That was the latest use of the muscle, these neuromuscular monitoring devices. And this is where we exactly do it. And that's all about it. We used to use it when we were residents, and it was mainly in cases where we expect more prolonged muscle relaxation, and that the onset time will help us guard the further doses of the relaxants, because the technology was not much advanced. You all will agree with that. So this is a very important part for anesthesia people to learn how to use this neuromuscular monitoring system. The easiest available is the TOF guard, which is very easy, and we can just learn the things for all the muscle relaxants, the newer one and the older one. Hope I have covered most of the things. It was all in hurry, I did it, but I tried to cover them. Thank you very much.
Thank you, Dr. Tarlika, for covering this exhaustively. And I'm sure most of the questions will be answered, but there are a couple of questions which have been raised. One is there a correlation between TOF and temperature?
Yes, it is said that the temperature it definitely affects, and if the temperature is more, the top ratio is likely to change. Actually, I have not seen this. I've just read it. In clinical practice, I have not come across this, and that's why I just written down. But any one of you can share your experience if you have come to that. I think Dr. Gedu sir might be able to comment something, or madam can comment something, because you must be using that regular basis.
No, actually not that way. But the thing is, the case reports that have been, I have gone through is, whenever there is a case of malignant hyperthermia, there is a different tone of all your muscles. So
Yes.
that exactly all your neuromuscular readings dramatically changes totally, so that the patient goes into a total sort of a trismus or muscle spasm. Even if you are given just a scoline dose, you need not go for any other dosage. Same thing happens when you give a patient who is a very hyperthermic, like if a patient, I have given one patient who had 103, 104 degree temperature, and that time that I'm talking to you something like 1986, 87 story. We didn't have, we just had what you call D-tubocurarine and flaxidil.
Yeah, yeah.
Intubated the patient with a dexamethasone, and after that, patient never came out for at least, I can say, 35-40 minutes. We could not just make out what is that, because I have given just one intubating dose of this. It was not that I have put the patient into the phase 2 block.
Yeah.
It was not a repeat schooling that was being done.
No,
But
we
still, it
were
took a
much.
longer time, because the muscle
Yeah.
contraction becomes a very much what you call prominent. So it takes a lot of time.
We had these experiences with the thyroid patients, sir, where the temperature
Yes.
is not
You're right.
exactly the same what you. So when the muscle, we used to use the first dose, then we used to see how much time it is there, and then we used to titrate the next doses. And if patient doesn't have a recovery, complete recovery, before giving the reversal agent, we used to check it out. But I'm not very sure that what was the reading, it was top upside or downside, but it was definitely, it was altering that. And second one, what I will like to comment over here is, we should regularly use this top, so we come to know about it, and maybe we take up it as a research project next time.
Maybe.
That how the temperature affects. And even in cancer patients where the surgeries are lasting for 10 hours altogether, or 11 hours, there this is of very much importance, and the AC in the operation theater is very much on. So this hypothermia factor, again, that is going to add up to that.
Yes.
Yeah. Another question has been raised is why no fade is seen with succinylcholine?
Succinylcholine, no fade is seen. That is what. There was a fade, but it was not touching the ground. It was
It
little.
is never a significant fade, correct?
Yeah, it was never a significant one.
Yeah.
And it is all about the it is about all the cholinesterase, what we use it.
Sarlika, just can I add something?
Yeah, okay.
For your lecture, but when I have seen, there are a lot of things when you get a short note to be written on phase 2 block.
Yes, yes.
Block, apart from your giving scoring repeatedly, you will end up into the non-depolarization. But I just wanted to add one more thing, that there are 5 stages of the phase 2 block, which you have to mention it. Like the first stage is, of course, a depolarizer block. Following that, there is a stage of tachyphylaxis. Then there is a stage of Vedensky inhibition, following which there is a stage of fade and facilitation. And lastly, it lands up into the non-depolarizer block.
Right. Absolutely right, sir. Sir, the time limit was there, so I did not describe all the things.
You don't worry, dear.
And another thing, we were using the scoline in PIH patients when the ventilative facilities were not much there. So PIH patient, we used to manage up with scoline only. We used to give different frequent doses of it, and patient used to come out very nicely. We never had any complications. Only few patients had to go on ventilator because that was not easily available during that time. But the surgery used to be over by 15 to 20 minutes by the obstetricians.
I think that probably sums up all the questions and the answer session. And Dr.
They can
Devang,
write
is
to
there...
me, sir. So you can send the questions to me. I will send them by email.
Sure. Dr. Devang.
Dr. Devang?
Dr. Devang.
Yes, sir. Thank all of you, sir. Am I audible, sir?
Yeah, again, see, there is a question now
Am I
come.
audible?
Yeah.
Phase 2 block.
My
Yeah,
God.
phase 2 block.
Get us up 5 stages.
I already spoke 5 stages. And the thing is, that, of course, in that, again, since he has already asked my question, though honestly, it's not my topic, but still it's my interesting topic. I must say that the treatment parties, of course, in our days, we used to have an enzyme that was available, which was coming from the Himalaya plant product that was called collates. That was available in those days. That was very much useful, but today it is not available. So we can use the fresh blood, which contains a rich of the pseudocholinestrases also. Because in these conditions, there's no point of giving a neostigmine and all those things, because it's a phase 2 block, not inducing the non-depolarizer block at all. So either you have to keep on ventilating, but to speed up the things, you can give a fresh blood, or even you give fresh plasma, FFP, and following which you can just continue the ventilator, and in case needed, you can also add up something like you can give more of the fluids and all those things, so that the things are being taken care of.
Giving blood also, again, it increases the chances of a cross infection and all, but you have to go ahead with it. There is no other alternative available.
The thing is, stored blood carries less of the pseudocholinesterase.
Yes.
While if it is a fresh blood, it is rich
Fresh
in the
blood is good.
pseudocholinesterase.
It is good.
Yes.
Fresh
So
blood
that
is
is preferred instead of giving a platelet or a plasma. But platelet or the plasma itself are again frozen one. So it has got a lesser value of the pseudocholinesterase. So if your blood is being matching and it is being freshly given by somebody, it can be given.
Yes.
It works very well.
Yeah.
Thank you, sir. Thank you for your valuable explanation. And I would like to extend my thanks to all of you, sir. Gedu sir, Indra ma'am, Tarlikaban ma'am, and Surinder sir. Thank you so much.
Thank you very much.
Thank you, organizers.
Thank you, everybody.
Thank you, all of you.
Thank you, Surinder
Thank
ji.
you, all the organizers.
Thank you, all of you. Thanks a lot.
Now it's time.
Yeah.
It was a great session.
Thank you.
Thank you.
Thank you.
Thank you. Thanks,
Thank
Appec,
you,
again.
everyone.
Thank you.
Thank you so much for
Thank
making me a
you.
part of it. Okay, thank you.
Yes, sir. Now it's time to declare the winner of daily quiz. The winner of yesterday's, that is 1st of March's daily quiz is Dr. Deepthi Priyanka. She is from ABVMS and Dr. RML Hospital, New Delhi. Congratulations, Dr. Deepthi. And I believe the winner of day before yesterday's quiz was not announced due to some technical difficulty yesterday. So the winner of 28th of February's daily quiz is Dr. Akansha Khatri from PJMS Rohtak. Again, many congratulations. Now for the last session of the day, it is an interesting simulated drug viva voce on muscle relaxants. It will be moderated by Dr. Namita Arora and Dr. Neha Gupta. Dr. Namita ma'am is Professor Anesthesia, ABVMS and Dr. RML Hospital, New Delhi. Her areas of interest are difficult airway, neuroanesthesia, and ATLS training. Dr. Neha ma'am is Associate Professor, ABVMS and Dr. RML Hospital, New Delhi. Her area of interest is pediatric anesthesia. Answering the questions will be Dr. Priyanka Singh, Dr. Priyanka Marwaha, and Dr. Arpit Jain. Over to you, madam.
Dr. Priyanka.
Good afternoon, ma'am.
Good afternoon. So you have drugs in front of you. Can you pick up a vial of succinylcholine?
Yes, ma'am.
Okay. So describe the vial.
This is a 10 ml vial of succinyl fluoride. Each ml contains 50 mg. Benzyl alcohol is present as preservative. And the expiry date of this vial is May 2022. And it is written that not for use in newborns and should be stored between 2 to 8 degrees Celsius, protected from light.
So good. You should always read the expiry date. Okay. So what class of drug is this?
It is a depolarizing muscle relaxant.
Yes, depolarizing muscle relaxant. So what is the dose?
Ma'am, dose of succinylcholine is 1 to 1.5 mg per kg.
Okay. And duration and onset of action?
Onset of action of succinylcholine is 30 to 60 seconds and duration is 5 to 10 minutes.
Okay. So how does it act, this drug?
Succinylcholine, its structure is similar to the acetylcholine. It is a quaternary compound. It acts as the nicotinic acetylcholine receptors and activates the voltage-gated sodium channels and cause influx of sodium and efflux of potassium, and causes persistent depolarization followed by relaxation.
Okay, so it is the persistent depolarization that it no longer responds to further stimulation and causes muscle paralysis. Yes. So what type of block, when we say depolarizing block, what type of block is it? What's it called?
It is called phase 1 block, which
Very
is
good.
caused by phase 1 block is a depolarizing block caused by succinylcholine, resulting in persistent depolarization
That's
followed by
okay.
relaxation.
What are the characteristics of the block?
The characteristics of the block is there is decrease in the muscle twitch or neuromuscular monitoring. No fade phenomena
So
is seen.
amplitude of single twitch is reduced. Okay.
And no fade phenomena is seen. And there is no post-tetanic potentiation.
Okay. When you say no
With the
fade,
depolarizing.
when you say no fade is seen in train of 4, what do you mean by that?
That there is no decrease in the amplitude.
No, there is a equal decrease in amplitude, uniform decrease in amplitude from first to the fourth response. Unlike in depolarizing, in non-depolarizing, when there is a fade, that is the first response is of higher magnitude, and then the height of the further responses keep on reducing. There is a gradual fade from first to fourth. Okay. Yeah. So when we give scoline, what are the adverse effects?
Ma'am, there are several adverse effects associated with succinylcholine. First of all, cardiovascular adverse effects. Ma'am, it causes sinus bradycardia, nodal rhythms, ventricular dysarrhythmias.
So
it
why
causes hypokalemia.
Why does it cause these cardiovascular side effects?
Because like acetylcholine, it also acts on the muscarinic receptors.
Yes.
Present in the heart.
Yes, good. So which other system does it cause side effects?
Other side effects is like hyperkalemia. It causes increase in the intraocular pressure, increase in the intragastric pressure.
Why hyperkalemia?
Now, it causes hyperkalemia because it causes proliferation of extrajunctional nicotinic receptors. So it causes hyperkalemia in some.
See, scoline cannot cause proliferation of receptors. When scoline acts, you said that it causes sustained depolarization. What does depolarization cause?
Ma'am, it acts on the voltage-gated sodium channel, and it causes influx of sodium and efflux of potassium. So this is how it causes hyperkalemia.
Yes. So there is efflux. So how much is the rise in the potassium level with a dose of?
Ma'am, 0.5 yes, ma'am, 0.5 milliequivalent per liter increase in the potassium level.
So this is what happens in a normal individual. But is the hyperkalemia pronounced in certain conditions?
Yes, ma'am. It is pronounced in certain conditions like in burn patients, in upper motor and lower motor denervation injuries, in closed head injuries, in severe abdominal infections, it causes increase. It causes hypokalemia.
So it is in these conditions that there is what you were saying, proliferation of extrajunctional receptors. And because there are increased number of receptors, that there is more receptors available for scoline to act, and as a result, there is more efflux of potassium causing hyperkalemia. Okay, so this hyperkalemia can be a dangerous hyperkalemia. And like you said in burns, so when in burns, what is the time period when you can safely use succinylcholine?
In burn patients, we can safely use succinylcholine within less than 48 hours and after 2 years.
So that is initial 48 hours of burn injury we can safely use, because by then the proliferation of receptors has
not.
Very good. Then what else did you say were the side effects? You said myalgia. Yes, what else? What else?
Ma'am, it also causes masseter muscle spasm.
And you said rise in
intracranial pressure.
Yes.
Intracranial and intragastric pressure.
Very good. Very good. Okay, so where is scoline used? Scoline is still, it was discovered long back, right? It was it came into the market long back and still used. It finds its unique usage where?
Ma'am, since it's an ultra short acting muscle relaxant, so it is used in rapid sequence induction.
Yes, so that is in full stomach patients. Because it provides excellent intubating conditions. And where else can it be used?
Ma'am, it can also be used in electroconvulsive therapies.
Very good.
Intermittent use of succinylcholine.
Yes, yes, very good. Again, for the same reason, because it is short acting. And there we use a smaller dose so that not complete paralysis is caused, right? Then any precaution one needs to take for intermittent scoline usage?
For the scoline, like if we are giving a second repeated dose of succinylcholine, we must use atropine before giving succinylcholine because it causes sinus bradycardia in the patients.
Yes, very good. So this is very, very important for one to know that one should use atropine before the second dose, right? So can it be used in neonates?
No, ma'am, we should not use in neonates because there could be underlying neuromuscular disorders undiagnosed.
Yes, yes. Okay. And what happens if we use it in open eye injuries?
Since it causes increase in the intraocular pressure, it will cause herniation of the contents through the perforation.
Very good. Because of the rise in the intraocular pressure. So what is precruderization?
Precruderization is when we give 1/10 dose of a non-depolarizing muscle relaxant 3 minutes prior to the full dose of the succinylcholine. This is called precruderization.
Very good. Very good. And why do we do it? Why is it done?
To prevent fasciculations, the uncoordinated movements.
Yes. So why are we wanting to prevent fasciculations? Because they lead to myalgia, severe myalgia, right? And also fasciculations prevent the rise in the intragastric and
intracranial and intraocular pressure.
Because we are using it in full stomach patients for rapid sequence intubation. So when we do precruderization, it reduces the chance of regurgitation and aspiration. Right? Okay. Then what is self-taming? Have you heard the term?
Yes, ma'am. Ma'am, in self-taming, we use 1/10 dose of the succinylcholine. Again, 3 minutes prior to the full dose of the succinylcholine.
Yes. So as the name suggests, self-taming is when one is using the same drug before giving the full dose, right? Okay. And when we were talking about pre-cruderization, is the dose of scoline the same when you use it with pre-cruderization?
A dose of scoline is increased in precurization.
Yes, it is increased. Yes, increased by around 70%.
70.
Dr. Neha, would you like to ask any more questions?
Yeah, Dr. Priyanka, could you tell me something about phase 1 and phase 2 blocks?
Ma'am, phase 1 block is a depolarizing block.
Yes. What is phase 2?
Ma'am, phase 2 block occurs when we use repeated dose of succinylcholine or succinylcholine infusion, or the total dose more than 3 to 5 mg per kg, then it starts behaving as non-depolarizing muscle relaxant. The phenomenon is desensitization of the
So basically, phase 2 block. Yes. Yes. Okay. Thank you, Dr. Priyanka.
Okay. Thank you, Dr. Priyanka.
Good morning, ma'am.
Good morning, Dr. Priyanka.
Good morning.
So could you pick up an ampule of vecuronium for us?
Yes, ma'am. This is an ampule of vecuronium containing the salt vecuronium bromide in the concentration of 4 mg. The the ampule contains a lyophilized amorphous powder. It has no preservative added.
Okay. So what class of drugs does it belong to?
It belongs to non-depolarizing muscle relaxant.
So what's the mechanism of action?
It acts by competitive antagonism of acetylcholine at the nicotinic acetylcholine receptors.
Okay, so it does not let acetylcholine bind to the receptors and hence causes blockade of your neuromuscular transmitter. That's right. So how can you classify non-depolarizing relaxants?
Ma'am, non-depolarizing muscle relaxants can be classified into two aminosteroid compounds and benzyl isoquinoline compounds. They can further be classified into short-acting, intermediate-acting, and long-acting drugs.
Okay, so examples of each?
In aminosteroids, there is no short-acting drug. Intermediate-acting is vecuronium and rocuronium. Long-acting is pancuronium. In benzyl isoquinoline, short-acting is mivacurium. Intermediate-acting is etracurium and cisatracurium, and long-acting is tubocurare.
Okay. So what is the intubating dose of vecuronium?
Intubating dose is 0.1 mg per kg.
Its onset of maximum blockade and duration of action?
Onset is 3 to 4 minutes and duration is 30 to 45 minutes.
Okay. So which was the muscle relaxant, which was a predecessor of vecuronium, the same class of drugs?
Pancuronium.
Okay. So how is vecuronium better than pancuronium? Which one is better? Which one have you used? Which one have you used?
I have used I have never used pancuronium. I've only used vecuronium.
Okay. So any problem? Have you read about it? Any problems that were encountered with
yes,
pancuronium?
ma'am. Pancuronium has cardiac side effects because of its vagolytic and direct sympathomimetic activities due to catecholamine release. It can lead to increase in heart rate and hypertension.
Yeah. And what about vecuronium?
Vecuronium does not possess any of these actions.
So that is the one major benefit of vecuronium over pancuronium, that it is very hemodynamically stable drug and does not cause tachycardia like pancuronium. All right. And it is intermediate acting, whereas pancuronium was a longer acting.
It's long acting.
Yes. How is vecuronium metabolized?
Ma'am, vecuronium is metabolized up to 30% in 30 to 40% in the liver and up to 30% by renal metabolism.
Yeah, a major portion of metabolism and excretion occurs through
Hepatic route.
liver. And biliary excretion plays a major role, it being a very highly lipid soluble drug. So any patient with hepatic dysfunction, vecuronium would not be metabolized and excreted normally. In contrast to pancuronium, how was pancuronium?
Ma'am, up to 70% of pancuronium, because it is a big molecule, it is up to 70% is excreted by the kidneys, because it is also very highly water soluble.
Water soluble.
Water
Yes.
soluble.
Yes. So pancuronium, major route of excretion is renal, in contrast to vecuronium, which is mainly excreted in the bile.
Bile.
Okay. Okay. Now, can you next pick up a vial of rocuronium?
Ma'am, this is a vial of rocuronium. It contains the salt rocuronium bromide. The vial contains 10 ml of a colorless clear fluid, and the concentration is 10 milligram per ml. It is for IV use only.
Okay. So
there is no
again,
preservative.
Okay. So I guess the class is same. It's intermediate acting. It's an aminosteroid as well. Same as vecuronium. So how is this different from vecuronium? Any special property of rocuronium you can tell?
Ma'am, we can use rocuronium for rapid sequence induction.
How?
Ma'am, by giving a higher dose of 1.2 mg per kg in contrast to its intubating dose, which is 0.6 mg per kg.
Very good. Very good. So how does the dosage affect the onset and the duration of action?
Ma'am, if we give a dose of 1.2 mg per kg, the onset of action is 60 seconds. If we give 0.6 mg per kg, the onset varies from 2 to 3 minutes.
Yes. So in a dose of 0.6, it acts like vecuronium. It's an intermediate acting agent. And for RSI, the dosage is 1.2 milligram per kg, as rightly said. Correct. How is it metabolized?
Ma'am, rocuronium is up to 60 to 70% of it is metabolized in the liver.
Liver. So again,
and
liver
it is also excreted in the bile.
Right. Correct. Okay. So next, can you pick up an ampule of atracurium?
Ma'am, this is an ampule of atracurium containing the salt atracurium bisalate. This is a 2.5 ml ampule containing colorless clear liquid in the concentration of 10 milligram per ml, and this does not contain any preservative.
Okay. What class of non-depolarizing muscle relaxant is it?
Ma'am, this is intermediate acting benzyl isoquinoline drug.
Yes. Intubating dose, time of on. Yes, ma'am.
How is it preserved? Atracurium?
Ma'am, it has to be preserved by storing it in the refrigerator.
Very good. Good. Okay, Neha, sorry for the interruption.
Oh, no, ma'am, that's totally fine. Okay, so where were we? What is the intubating dose?
Ma'am, intubating dose is 0.5 mg per kg.
Okay. Duration, as you said, it's intermediate acting. So again, it's
30 to 45 minutes. Time of onset is 3 to 4 minutes.
Anything special about this drug which makes it different from the drugs that we have discussed till now?
Yes, ma'am. It's metabolism. 2/3 of this drug is metabolized by ester hydrolysis and 1/3 is metabolized by Hoffman degradation.
So what is the significance?
Ma'am, we can use this in both hepatic and renal dysfunction.
Okay, so the metabolism is independent of liver and renal functions and can be used in patients with dysfunction of these organs. Right. Any adverse effects?
Ma'am, it causes histamine release, which can lead to hypotension, tachycardia, skin flushing, urticaria, and bronchospasm.
Okay, so it's contraindicated or should be used with caution in all the patients?
With previous history of allergic reactions and asthma.
Because it can cause bronchospasm. Any other adverse effect?
Ma'am, its metabolite laudanosine can cross the blood-brain barrier and decrease the seizure threshold.
In what kind of patients? In all patients, can we see that effect?
No, ma'am. We can see that in patients who have been given infusion of atracurium for a long time, such as in ICU, or in hepatic dysfunction patients, because laudanosine is metabolized in the liver.
Yes, okay. So any other drug which does not have all these adverse effects and has the advantages of atracurium?
Ma'am, cis-atracurium, which is a cis isomer of atracurium.
Yes. So does it have those
It does
adverse?
not.
It does not
No, ma'am.
cause.
It does not cause histamine release, and it does not produce laudanum.
Okay. Okay. How is it metabolized? Cis-atracurium?
Ma'am, cis-atracurium is metabolized up to 30 to 40% is metabolized by Hoffman degradation and 60% by hydrolysis.
Okay, so Priyanka, tell me, if you have a patient of biliary obstruction, obstructive jaundice, so what would be your muscle relaxant of choice in that patient?
Ma'am, atracurium or cis-atracurium?
Okay, cis-atracurium may be the first choice if you have that.
Yes, ma'am. If I have that, otherwise
then
atracurium.
atracurium. Second would be atracurium, and if you have none available out of these two, then any other?
Ma'am, pancuronium.
Yes, yes, because it mainly has the, as we've already discussed, renal route of excretion. So
Renal
pancuronium
route.
would be a better choice as compared to vecuronium. And
Vecuronium.
same with renal derangement patients. If you do not have cis-atracurium or atracurium, the next choice would
Vecuronium.
be vecuronium or rock. Very good. Very good. So any other ultra short acting non-depolarizing agent you are aware of?
Ma'am, mivacurium.
Okay, so mivacurium, have you ever used it? Is it available in our
No,
country? Okay, you haven't used it. So why do you think it's ultra short acting?
Ma'am, it is ultra short acting because it is metabolized in the plasma by pseudocholinesterase, same route as succinylcholine.
Yes,
that makes it
the
ultra short.
duration is almost same as succinylcholine. Any adverse effects of mivacurium?
Ma'am, it causes histamine release.
It has a potential for histamine release like all other benzyl isoquinolone of drugs, but normally not seen when given slowly. Okay. Ma'am, anything that you would like to add to ask her?
What is priming?
Ma'am, priming is giving 1/10 dose of non-depolarizing muscle relaxant 3 minutes prior to giving full dose of non-depolarizing muscle relaxant. This is done to decrease the time of onset by 30 to 60 seconds.
Okay, good. Any disadvantages?
Disadvantages of?
Priming.
Priming.
Or you can say the adverse effect of priming. What do the patients feel when they are given a priming dose? You give priming dose and then you wait for 3 minutes to give the other drug, right?
Yes, ma'am. Ma'am, they feel difficulty in breathing.
Very good.
And inability to move their body.
They feel restless because of that. They feel weakness and difficulty in breathing. Yeah. Very good. That's it, I think. Neha?
Yes, ma'am. Yes, ma'am.
Thank you.
Thank you.
Thank you, ma'am.
Okay.
Good morning, ma'am.
Good morning. Dr. Arpit?
Yes.
Okay. Dr. Arpit, can you pick up an ampule of neostigmine?
Yes, ma'am. Ma'am, it's a single-use ampule of 1 ml quantity. It contains neostigmine methyl sulfate at a dose of 0.5 mg per
0.5 mg per? Can you repeat that, Arpit?
Ma'am, it's a single-use ampule. It contains neostigmine methyl sulfate at the dose of 0.5 mg per ml. It does not contain any preservative.
Okay. What class and what else do you see when you see the ampule? You should also look for the expiry date.
Actually, your voice is not clear, ma'am.
You should also look at the expiry date.
Yes. Yes, ma'am. And the
Yeah.
expiry date of this drug is April 2023.
Very good. Very good. That's very important. And you should look if the contents are clear and if there are any suspended particles, right?
Yes, ma'am.
Okay. So what class of drug is neostigmine?
It's an anticholinesterase inhibitor.
Is it an anticholinesterase or anticholinesterase?
Acetylcholine.
So it's an anticholinesterase.
Anticholinesterase.
Yes. Okay.
Yes, ma'am.
So what does it do? How does it act?
Ma'am, it inhibits the enzyme acetylcholinesterase, which is present in the synaptic cleft, which metabolizes the neurotransmitter acetylcholine.
Yes.
Thereby, ma'am, it increases the concentration of acetylcholine in the synaptic cleft, which then occupies the receptors which were activated by a non-depolarizing muscle relaxant, replacing them from the receptors,
Yeah, I mean,
and thereby
I would not like to use the word activated, occupied. The receptors are occupied by non-depolarizing muscle relaxant. So, because it's a competitive type of inhibition.
inhibitor.
So, if the other is in excess, like acetylcholine is in excess, it is able to displace the non-depolarizing muscle relaxant. Okay.
Yes.
So, is it what is the dose of neostigmine and how is it used? Is it used with some other drug?
Ma'am, the dose of neostigmine is 0.03 mg per kg to 0.07 mg per kg.
Yes.
Ma'am, it's generally used with parasympatholytic drug like glycopyrrolate.
Okay. Why is it used with glycopyrrolate?
The time of onset for neostigmine and glycopyrrolate are approximately similar. The time of onset, the peak action for neostigmine and glycopyrrolate are approximately similar. The peak
So what
action
is-
for neostigmine is
Is
7 to 11 minutes, and for glycopyrrolate it's 7 to 10 minutes.
okay. Okay. So, but why is it used with glycopyrrolate? Why is glycopyrrolate added
Ma'am,
worse?
Ma'am, neostigmine causes side effect due to increase in the acetylcholine neurotransmitter in the synaptic cleft. The side effects can be cardiogenic, like heart bradyarrhythmias, and due to its action on respiratory muscle, it can also cause bronchospasm or bronchoconstriction. To counteract those side effects, we add glycopyrrolate with the neostigmine.
Yes. So we have to add glycopyrrolate when one is giving. So you are actually using it to reverse the nicotinic action at the nicotinic receptors. But because when you give the drug, it will produce increase in the amount of acetylcholine at all the receptors.
Yes, ma'am.
Right? So you have to block the muscarinic receptors to prevent any side effect. So you have to use glycopyrrolate.
Yes, ma'am.
Okay, what dose of glycopyrrolate is used?
Ma'am, glycopyrrolate, the dose of glycopyrrolate is 0.005 mg per kg to 0.01 mg per kg.
Okay, yes. So coming back to neostigmine, how is it metabolized?
Ma'am, it's metabolized by plasma esterase enzyme into quaternary alcohol. Yes,
Okay. And you said the side effects are bradycardia and bronchospasm? Okay.
Ma'am, it can cause bronchospasm.
Okay. Any other side effects?
It can cause increased peristalsis, increased secretion, meiosis.
Very good. And cause excessive salivation, excessive lacrimation.
Yes, ma'am.
है ना?
Yes, ma'am. Hypersensitivity. Yes, ma'am.
And what else? All these are muscarinic effects, which we block. That is why when we normally give neostigmine, we do not see these side effects, right? Any other agent you can use with neostigmine to block the muscarinic effects? You can use atropine.
We can also use, yes, ma'am, we can use atropine.
We can use atropine, although glycopyrrolate is preferred. Isn't it?
Yes, ma'am.
Yeah.
Yes, ma'am.
Okay. Any other agent that you know which can be used for reversing the neuromuscular blockade other than neostigmine?
Sucamadex.
Sucamadex, very good. So how does it act? What is the structure?
The three-dimensional structure of Sucamadex represents a hollow truncated cone or a donut. The interior of that structure is hydrophobic and outer shell is hydrophilic. It acts by encapsulating the aminosteroid muscle non-depolarizing muscle relaxants like rocuronium or vecuronium.
Very good. Very good. And it forms a firm bond with them, and which does not
Yes, ma'am.
dissociate, right? So where does it find its use? Important. You see, normally we don't use Sucamadex. It's not easily available, right? We are using neostigmine.
Yes, ma'am.
But specific situations where we feel stuck, when we are not able to use neostigmine, when we have to use it immediately after having,
ma'am, giving intubating dose.
yes, especially so with rocuronium. When we use rocuronium for RSI, but the surgery is short, and now because we use 1.2 milligram per kg and the dose causes a duration of almost an hour, and if the surgery is short, we can use Sucamadex for reversal, right?
Yes, ma'am.
Yeah. So what
Yes,
is
ma'am.
the dose of Sucamadex?
Yes, the dose of that Sucamadex after giving intubating dose of rocuronium, it's 16 mg per kg.
Yes.
Ma'am, in a moderate neuromuscular block.
That is if you
its
have
dose
to
is-
immediately use it after giving the
Yes,
intubation.
ma'am.
Yeah.
Yes, ma'am. Ma'am, in a moderate neuromuscular block, the dose is 2 mg per kg, and in a deep block, the dose is 4 mg per kg, ma'am.
Yeah, very good. Okay. And it is given intravenously. No?
Yes, ma'am.
Okay. So how is it available? Although even I haven't seen a vial, we don't have it available here in our hospital. But you should know how is it dispensed? How is the vial?
Sucamadex is available in vial in a 2 ml or 5 ml vial, and the dose is 100 mg per ml.
Okay. So it's available as a 200 milligram or a 500 milligram vial, right?
500 ml.
Yes.
Yes, ma'am.
Very
Yes,
good.
ma'am.
Okay. So you said that the use is in RSI when we use rocuronium. Any other use you
Yes,
can
ma'am.
think of? What if we are in an unanticipated difficult airway situation? We have given relaxant,
ma'am.
but we cannot intubate, cannot ventilate situation. Right?
Yes, ma'am.
There also we can use
Yes, ma'am.
Sucamadex because that it will come to
Yes, ma'am.
help us and rescue the patient from the muscle relaxant effect, isn't it?
Yes, ma'am.
What else?
Neostigmine we generally don't use in deep block.
Yes.
We only give neostigmine after patients start showing his own response.
Some response. If there is some recovery, only then we can.
Yes,
We
ma'am.
need some receptors to be free for neostigmine to be effective. Yes.
Yes, ma'am. Ma'am, we can use Sucamadex in deep block also.
Yes. So what are the limitations of Sucamadex?
The major limitation is cost. It's expensive drug.
Yes.
Therefore, it's not easily available.
Yes.
So gamma dex can cause hypersensitivity reaction in some patients.
Yes. Yes. In fact, what other side effects it may cause? Metallic taste.
It can, yes, ma'am, metallic taste.
Nausea.
Nausea, yes. So what if you have used Sugamadex in a patient, okay? And
Yes, ma'am.
one needs to again give anesthesia to this patient. Can we now give a muscle relaxant?
It's generally not advised to give the same muscle relaxant again for 24 hours.
Very good, excellent, yes. Not for next 24 hours. So what do we do? Which muscle relaxant can we give?
We can give succinylcholine or benzyl isoquinoline muscle relaxants.
Very good. So we have the other options which we can use in case we need to get the case done again. Yes.
Yes, ma'am.
Anything else? Anything that you think, Neha, I have left out? You can ask him.
Dr. Appec, could you tell us what are your criteria for adequate recovery from neuromuscular blockade?
Yes, ma'am. Ma'am, sustained head lift for 5 seconds, sustained leg lift for 5 seconds, sustained hand grip for 5 seconds, sustained tongue depressor test, peak inspiratory pressure of at least 25 centimeters of water.
Yes.
Patient should be able to follow commands, maintain a patent airway. Patient should able to protrude his or her tongue out.
Okay, so these are your clinical criteria, and any monitoring that can be used?
Ma'am, we can use neuromuscular monitoring, ma'am. It includes force stimulation.
Which one have you used? Have you seen any?
Ma'am, we generally use train of force stimulation, ma'am.
Okay, okay. So what do you see in that, and how do you know that the patient is adequately reversed?
Ma'am, in train of force stimulation, we give force stimulus to the patient, which are given at the interval of 0.5 seconds with a frequency of 2 hertz. Ma'am, we calculate the TOF ratio.
Yes.
We see the stimulation of fourth stimulus and compare it with the first one, which gives us the TOF ratio. For adequate neuromuscular recovery, a ratio of at least 0.7 is generally seen. And for extubation, ma'am, we extubate at the ratio of at least 0.9.
Yes, it should be 0.9 or more for us to extubate the patient. Okay.
Yes, ma'am.
That's it. Thank you, Dr. Arpit.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am, for this presentation. There are a few questions, ma'am.
Okay.
Dr. Mansa Kantha is asking, why salt chloride for scoline and bromide in vecuronium? She wants to ask probably why chloride is used for scoline while bromide in vecuronium.
Neha, do you know this? I don't know the answer for this.
And even I have not heard such kind of question even. Okay, I'll go to the other question, ma'am. Sarvanan Sri Kumar.
Maybe these salts are stable. That is why I'll have to read and get back.
Yes, ma'am. Another question is from Dr. Sarvanan Sri Kumar. who would like you to explain the rationale for self-taming?
See, self-taming is similar to pre-cruderization, and some studies have been done to use scoline, small dose of scoline before the full dose, again to reduce the incidence of myalgia. So this has been found to be as effective as pre-cruderization.
Dr. Sonalika wants to know, can we use atropine in place of glycopyrrolate with neostigmine at the time of reversal?
Yes, you can. Yes, you can use atropine. In fact, in earlier days, we used to have only atropine, and we used to use atropine with neostigmine. But in some patients who have a propensity to bradycardia or who are prone to bradycardia, in those patients, we were not giving them together, but were loading them separately in different syringes, were giving first atropine and followed by neostigmine once the response to heart rate was observed, and then was followed by neostigmine. It can be used.
Right, ma'am. I think that answers all the questions, ma'am. Thank you. Thank you for your session, ma'am.
Thank you. Thank you.
And with this, we wrap up today's program. On behalf of Team Appec, I would like to express heartfelt gratitude to all faculty members who took out the time and delivered such educative lectures and discussions. Also, I would like to remind our delegates that daily quiz will be live at 6 p.m. today. The link for the same has already been sent in the delegate WhatsApp group. With this, I take your leave. Thank you.
Thank you.